herself in Bhubaneswar. The whole state of Odisha is celebrating, and we just celebrated Kartik Purnima. So this is a good fortune and blessings of Jagannath Prabhu. So we start the first day of the Congress with you all. So hope these 3 days you'll have a good scientific feast. So this is a good time that you can interact, you can liaison with each other, we can exchange our views, ideas, because oncology itself is going through a different changes. If you look into last 2.5 years of COVID pandemic, so there were n number of approvals which probably did not happen even in the normal times. If you look at the FDA approvals, we itself have almost 14 approvals in lung cancer itself. So that shows that science has never stopped even in the lockdown and in the COVID pandemic. So we'll start the day's event, and I will introduce one of our beautiful soul colleague, medical oncologist, who is from Odisha, but again relocated back to Odisha after her tenure at Delhi. She is Dr. Romila Tiwari Patnaik, presently attached with Amri Hospital. So she will be the masters of ceremony, and I will be assisting her throughout these next 3 days because she may not be knowing many people. She will take some time to accustom, and we'll start. So Dr. Romila, please on the stage, and we'll start with the first panel discussion. Over to you, Romila.
Good afternoon, everybody. Thank you, Dr. Vishwas, for that warm introduction. I feel privileged and take immense pleasure in inviting and in welcoming each one of you over here. And it's like the way Dr. Vishwas told, this is the new norm of having hybrid events, physically present or virtually present. The learning goes on. Honorable dignitaries, learned delegates, respected seniors and dear students, we start the session, the first session, none other than head and neck cancer, very much prevalent in this part of world. And I take an opportunity to invite esteemed Dr. Kripa Sindhu Panda sir and Dr. Surendranath Senapati sir to please chair the session.
So Dr. Panda and Dr. Senapati sir are our stalwarts in the field of oncology, not in the state but across the country. Dr. Panda sir is yet to join, and at this moment, so our state is privileged to have both the society's highest position with us, with Dr. Professor Senapati sir and Dr. P.K. Das sir. So the moderator of the session will be none other than Dr. Vijay Patil. He was supposed to come because of some family exigency. He had dropped last moment. So many of you may not be knowing Dr. Vijay Patil, Professor Dr. Vijay Maruti Patil. So he is so famous overnight now. You can see the oncology Twitter full for last 2 months with Dr. Vijay Patil, because Dr. Vijay Patil, Dr. Kumar Pravas Banita, so they have been doing wonders in the head and neck and lung cancer, but in per se head and neck cancer, because now they are associated with low dose of immunotherapy, triplet metronomic therapy, so which is so relevant for our patient population where the money is concerned.
So I request the panelists to please join the desk. Dr. Chinmay Pani, Medical Oncologist, Bhubaneswar. Dr. Prashant Kumar Parida, Medical Oncologist, Cuttack. Dr. Deepak Das, Radiation Oncologist, Bhubaneswar. Dr. Chiraranjan Khadanga, Radiation Oncologist, Bhubaneswar. Dr. Saroj K. Das Majumdar, Radiation Oncologist, Bhubaneswar. Dr. Rajesh Kumar Padhi, Surgical Oncologist, Bhubaneswar. And Dr. Sunil Jaiswal, Surgical Oncologist, Bhubaneswar.
So thank you, Romila. So Dr. Vijay Patil, so who will be joining and moderating the session virtually. So over to you, Dr. Vijay.
One of the things which I would start with is with the palliative therapy in these patients. So this is the first case, and it's a 63-year-old male who has come with the performance status of 1, CA left GBS. This patient has undergone chemoradiation, and he has failed within 5 months in the lymph node. And this failure is within the RT portal. So let me come to the panelist here. So this is a patient who is greater than 60 years of age, left GBS, post-surgery, has received adjoint CTRT, has failed within 5 months. So let me first come to Dr. Rajesh Parida with a surgical oncologist in the panel. Would you do salvage surgery in this patient?
Hello.
Yeah.
Dr. Patil, are you able to listen to me?
Yes, I can hear you.
So it's a small request. Can you repeat the case summary?
Yeah. I'll repeat the case summary.
Yeah, thank you.
This was a 63-year-old male. I'll show the slide again. 63-year-old male who had a CA left GBS, gets operated because he had extranodal extension. He received chemoradiation. The chemoradiation has finished 5 months back, and the patient has come back with a lymph node. The lymph node is in the area of neck dissection and also within the RT portals. So the patient has come back to the surgeon again, and he is asking, should I undergo a salvage surgery here? Yes or no?
Good afternoon, sir. Actually, this is a case of 63-year-old CA GBS with a surgery post CTRT. Then patient had a node failure. Then after 1 month, do you want whether they go for a surgery or not? Is it clear, sir? Is the question?
Correct. That's the question.
Sir, preferably if it is only 1 month duration of post RT, I don't want to surgery. I prefer maybe after 3 months. But after 1 month surgery, it's very difficult.
Okay.
So if after 3 months, I can try.
Okay. So could you, for the benefit of the audience, enlist which are the patients in whom you would prefer doing salvage surgery?
Sir, you see, this is a case of failure cases. So I want whether it is opposite side and same side from 1 to 5. Whatever the nodes left, I will try to remove. And again, also I will try other side also.
Okay. Can you also press what is, if the patient is eligible for salvage surgery, why do we need to first consider patient for salvage surgery and not for palliative chemo? What is the importance of salvage surgery in head and neck cancers?
Sir, you see, importance of salvage surgery in head and neck surgery, one is debulking. One, again, is a huge bulk of tumors, you have to debulk. And again, if it is a post-CTRT failure, if you know, you can know also you can't go for radiation again. So then you have to go for a surgery, and chemo is always a palliative in this. So surgical intention is the only surgical intention, primary, or other than that, anything else is a palliative intention.
That is perfect, Dr. Jaiswal and Dr. Parida. Salvage surgery is the only thing in head and neck cancer when you give in palliation which can give you long-term control. We cannot unfortunately have randomized trials in this sequence, and I'll go back to one of the publications which we made, in which we had patients in seen in our joint clinic, in which patients were fit for salvage surgeries, and 91 patients were willing for salvage surgeries, as opposed to 22 patients who were not willing for salvage surgeries. And this graph clearly shows you that those patients who were willing and underwent salvage surgery, did much better than patients who did not underwent salvage surgeries. You get a 2-year survival of around 45 to 50% by doing salvage surgeries, which you don't get with EA. And as correctly pointed out, we need to select our cases for salvage surgery. This is a brilliant paper which came in Cancer from MD Anderson group, which shows that there needs to be a DFI of at least 10 months. Patients who have a DFI of 10 months or more, they do well. And patients should be having a localized disease, and that adequate reconstruction and functional reconstruction should be the patient should be eligible. Then only he benefits. Now come to the radiation oncologist. Let's say that let's assume that a different case has come. The patient has undergone salvage surgery. In this patient, as Dr. Parida and Dr. Jaiswal correctly pointed, we won't go for salvage surgery because the DFI is too less. But we are assuming that the DFI was, let's say, 2 years. The patient has undergone salvage surgeries. Would you give adjuvant RT or adjuvant CTRT in these patients? And let me ask the question to Dr. Deepak Das.
Sir, it will depend on the time from the last treatment. That is very, very important. And the field of recurrence and the volume of recurrence and what is the dose the patient received and chemotherapy received or not. But
perfect, Dr. Das. So for the benefit of the audience, can you what is the DFI you will be looking for irradiation? What is the volume you will be looking for irradiation? Can you enlist a few of these points so that we are clear about which is the patient who after salvage surgery or even after, this is the candidate who will be taken for irradiation?
So there should be a minimum 6-month gap between the last dose of radiation and the recurrence or start of re-radiation. And the volume, it has been shown that if the volume is more than 100 centimeter cube, so there is a higher chance of toxicity. And it has been seen that if with previous irradiation there is toxicity, so with re-irradiation that will also increase the toxicity. So these are all the factors that will depend the dose of irradiation or if you will give irradiation or not. I think Dr. Saroz sir and Senapati sir is here. They will add comment.
Okay.
So, thank you. So once recurrence is there, we think of doing surgery because we have overall survival advantage. Then we also think of doing chemoradiation because there is progression-free survival advantage which is significantly achieved. So if we have done this surgery for curative intent, always think of doing chemoradiation adjuvantly. But we have to be very choosy about the patient we select for this because patient who has received radical treatment, second time radiation which is called re-irradiation is a challenging task. So we have to have all the details of that previous therapy, but more or less, as Dr. Deepak told, the size of the tumor should be less, like 27 centimeter cubic cc. Then only we can have. Plus the normal structure received radiotherapy. At least 1 year time should be there. Time is the biggest factor. More than 2 years, we are comfortable. At least 1 year, we can give, which is the shortest period. We are trying with even 6 months duration also, we are trying with that. So the simple answer is this, yes, we will go for chemoradiation after surgery is done.
Sir, let me ask you one more question.
Yes,
If this patient, let's say, has got treated at some other center, are you comfortable treating at your center, or you want the treatment to be at the other center only where the original plans would be there for radiation?
This is a very good question because always I counsel the patient, please go to the initial center where the radiation was there, so that beam matching and the previous plan, you have to see that. Otherwise, we talk to the radiation oncologist who had treated earlier, because this time we have to match that and respect the spinal cord and other structures, which is really a concern. At least like 2/3 of tolerance dose, we have to protect that. There are different models and literatures are saying, so we are very cautious about that. We go up to 60 gray, 55 gray, 56 gray, like that. Each case is challenging and we have to take the history. Otherwise, first choice, refer the patient to the initial center.
I'll have one more question for you, sir. If it's, let's say that salvage surgery was not done and patient is post-bleeding, where do you place brachytherapy, radical brachytherapy in salvage settings?
If surgery is not done, then we take this patient for brachytherapy. Brachytherapy has an advantage of it's a conformal treatment. Even the hypoxic component of the cell will be affected by brachytherapy. It's a good modality actually. So we also do, like say base of the tongue when the surgery is not possible. That is the case, we can reach there, brachytherapy can be done. This is good side. So if larynx is there, pre-vertebral fascia is involved, we can not do the surgery, then we can go again do brachytherapy there, like that. And nowadays we have proton beam therapy also for re-irradiation, skull base area extension is there, we can do that also. So there are options. You have to always think of doing like on the basis of techniques or either external beam RT by IMRT or by brachytherapy.
Okay. Okay. So I'll show you some data for radiation, and that was perfectly put on by the radiation oncologists on the panel. We have a randomized study here by Dr. Janet, in which patients who were post-salvage surgery were randomized to observation versus radiation. And as it was correctly pointed out, there was a disease-free survival benefit by giving chemoradiation, but there was no benefit in overall survival. And hence, we need to consider these patients who are post-salvage surgeries with high-risk features to be considered for chemoradiation. And just to put a point, these high-risk features are different from the afferent settings. In the Janet's paper, any patient who had 1 centimeter more of deep infiltration was offered chemoradiation. And any T4 or more of larynx, if it was there, it was offered chemoradiation. Now, let me come to the medical oncologists on the panel. Let's say that the surgeon says that the DFI is 7 months or 8 months.
No, I'm okay. I think there is some technical issue.
Okay, Dr. Chinmay.
Okay.
So did you get the question?
No, I know the questions. Am I audible to you, sir, now?
Yes, you are audible, Dr.
Yes,
Chinmay.
yes. So you put the question now in such a way that the recurrence happen in 8 to 9 month period. The T5 is 8 to 9 month, what you told,
Yes,
I believe.
correct.
Okay.
Correct.
So, and now the disease is localized or disease is locally advanced, surgical, non-resectable? I just want to more clarification on that.
Disease is localized and it is surgically resectable. Your surgeon has requested you, I would be more happy if the DFI is slightly more. So can you give some chemo for the time being, and I'll operate after 2 or 3 months, looking at the biology of the disease.
Okay. So there is no data to support on recurrence setting to give neoadjuvant chemotherapy followed by surgery. It is always directed to the local control on the basis of either you do resurgery. If it is surgically not possible, then go for the concurrent chemotherapy as you already discussed, because that is in the still that is in the curative intent if the TFI is more than 10 months as per the previous study you described.
That's an absolutely correct thing which described. In fact, in Tata, we tried this in patients who had a lower DFI, trying to give them neoadjuvant chemotherapy, trying to prolong that year and then select the patients. But we saw that if the patients have failed within an year, giving NSCT does not improves their outcomes. And so I agree with Dr. Pani that it doesn't help in this kind of patients. Now, Dr. Pani, a salvage surgery has been done. The patient has been seen by both Dr. Das and Dr. Chiranjan, and they say that, the patient's previous RT sequelae are till there. The organs at risk constraints cannot be met in this patient, so we cannot give any re-radiation. The multidisciplinary clinic has sent the patient to you for an opinion that patient salvage surgery has been done and there are high risk features seen, multiple notes are positive. Would you want to give some adjuvant chemo? What would be your opinion in that situation?
Okay, so basically to narrow down the questions, you were asking me about the pseudo-adjuvant therapy kind of thing you were asking.
Correct.
Yeah, so the data on the pseudo-adjuvant therapy per se, there is no level of evidence to show that post-surgery, if patient is not fit for radiation, to go for chemotherapy. But I think from your center, there is the data of oral metronomic therapy in the high-risk group of patients post-surgery. They have given observation versus the oral metronomic therapy, and they got some significant benefit. I think you are the right person to elaborate on it.
So I just wanted to put this because we give a lot of metronomic in palliative setting, and that has done quite a bit of wonders. But in adjuvant setting, in such situation, this was a randomized study in its patients who had undergone surgery. After surgery, they were not fit for radiation. They were randomized to observation versus metronomic. If you could see the curves here, metronomic it is not statistically significant, but numerically the curves are not in favor of metronomic. So at present, patient if salvage surgery has been done, if it's not fit for irradiation, it's worthwhile to keep this patient on observation only. And we have already discussed about the classical indications for who would be the good candidate for irradiation. So this patient actually is a platinum refractory patient who has failed very early. And let me ask Dr. Parida, Dr. Prashant Parida here, what would be your chemotherapy options in this patients, chemotherapy, systemic therapy options in these patients, and why?
So in platinum refractory, someone who has taken the extreme-like regimen, then based upon the recently two published trials, that is Keynote and Checkmate, we have options of using immune checkpoint inhibitors or IO drugs like nivolumab and pembrolizumab. So both have shown improvement, though there was no improvement in the DFS, but there is improvement in the overall survival. So we have options of using these IO drugs or immune checkpoint inhibitors, especially in platinum refractory setting. Even someone with early failures, I will try to start IO instead of someone has failed chemoradiation within 6 months, so I will prefer IO. And even in frontline setting, the Keynote 4.8 trial also shows improvement in OS in frontline setting also. So we have options of using nivolumab or pembrolizumab in platinum refractory setting.
That is perfect, and this has already been quoted. Not only improves overall survival, it also improves quality of life in these patients. And the same thing goes with pembrolizumab. And I would just, there's 1 minute left, so at 1:30 we need to close the panel. Just to elaborate that if patient is not affording, which is case in multiple situations, you can use a low-dose nivolumab with metronomic combination. That also gives a good response rate with a good overall survival. So my question here is, if you use palliative chemotherapy in oral cancers, in first-line setting, let's say that the patient is platinum sensitive, or if the patient is metastatic, oral cancer come with lung mets, what is the expected outcome with chemotherapy alone? And let me ask a question to Dr. Parida.
So we are, over the years, we are using the extreme type of regimen, platinum 5-FU with Erbitux or cetuximab, or TPX like regimen where survival is around 10 to 12 months, 10.5 months more precisely, when in the extreme it is 10.5 months versus 8 months or 7.5 months. So with initially platinum 5-FU and with the addition of cetuximab, there was improvement of 2.7 months improvement in survival. And with the TPX, which is a better tolerated regimen compared with the extreme, it is also similar outcome. So these are the systemic therapy, and I must congratulate you for the low dose nivolumab. You have excellent data presented by you, this low dose nivolumab along with metronomic therapy. So that is an option. But these are the systemic palliative systemic therapy upfront we are using, either extreme or TPX like regimen.
Those are perfect what Dr. Parida told. I just wanted to point out one here. When you look at extreme trial data, and if you look at oral cavity as a the survival you get with cisplatin 5FU is only 4.4 months. This is a similar survival even which came in the Chinese FDA study of cetuximab. And oral cavity is the site which benefits maximum negative extreme kind of regimen. So again a question to my medical oncologist panel. Do you think long-term survivals do happen if you give immunotherapy regimens in the first line setting? And let Dr. Pali take this question this time. And Dr. Vishwas, this will be my last question. After this, I'll hand over to you.
Sorry, practically I could not hear your question.
Okay. The question is, does giving immunotherapy leads to long-term survival? Let's say 10% patient at 5 years, 20% patients at 5 years, if given in the first line setting.
Okay. So basically, you are asking what is the long-term survivor in this context that you are asking? You are asking about 3-year survival and 4-year survival and 5-year survival data.
Yes.
So exactly in TP extreme, I cannot document the median overall survival. I think the 13.4 month, and I didn't remember. I think the 4-year or 5-year data would be in the range of 10 to 20%. I cannot quote clearly what is the long-term survival.
Okay. So the extreme data suggests that the 5-year survival is at around 5%, but the IO data, both in the CPS greater than 20 and greater than 1, actually shows that around 30 to 20% of your patients can become 5-year survival. The point I was trying to make here is that with immunotherapy molecules, we might start seeing head and neck advanced patients also going for 5 years and 6 years. With that, I think I have already exceeded the time which was allotted to me. I thank all the panelists for their discussion, and I thank the organizers for giving me this opportunity, and I hand it over back to the organizers for the further sessions. Thanks a lot, Dr. Vishwas, for the opportunity. And thank you, the panelists.
Okay. Thank you.
So, Senapati sir, some concluding remarks.
Thank you, Patil, for excellent moderating this session, and also the panelists. So this is a common problem that we come across in our day-to-day life, particularly advanced head and neck cancer. Very frequently, we fail at the oral cavity. So before we conclude, can I request Dr. Patil that what will be your take-home message?
So my take-home message is here, the way the slides went. So if the patient is advanced head and neck cancer and coming for palliative, it needs to be a multidisciplinary discussion. If salvage surgery is possible, the patient needs to go for salvage surgery. If the patient's radical re-radiation is possible, it needs to go for radical re-radiation, because as you correctly pointed out, long-term controls are seen with these two modalities. If these two are not feasible, then only the patient goes for palliative systemic therapy. If affordable, full dose IO in today's world gives the best results. If not affordable, we can go for low dose IO like protocols. If not affordable for low dose IO also, we can go for metronomic kind of protocols which are very easy on the patient. And we must not forget the role of referring this patient for early palliative care when we are starting with any kind of palliative regimens in these patients. Okay. That would be my take-home message.
Fine. Thank you. Do you allow any questions? No?
Yes, sorry.
Any questions from? Any questions from the audience? No? Okay.
I thank the chairperson, sirs. Thank you, the moderator, Dr. Patil, and thank you, the panelists. Now we swiftly head towards our next session based on thoracic cancer. Thank you. Thank you so much. The chairpersons for the thoracic cancer session would join us on the virtual platform. The first topic is being presented by Dr. Jogmaya Patnaik, medical oncologist, low Latin.
So now,
the low Latin.
So we have a keynote talk by Professor Gopalchandra Kundu.
Sorry, yeah. I'm really sorry for that. Yeah.
So he will talk on understanding the tumor heterogeneity and multi-targeted therapy, breast and other cancers. So we happened to be introduced almost a day back. So he is presently R&D from KIT deemed university. So he has almost 40 years of rich experience. So over to Professor Kundu, sir.
First, I'd like to thank Dr. Ghanshyam Biswas and his colleague to invite me for a short span of time. So next 15 minutes, can you turn on my slide? Turn off this light. So currently I am Director Research and Development KIT University as well as Professor at KIMS, KIT University. Before that I was Director of National Center for Cell Science, Pune. Can I have next slide please? So what I am going to talk next 12 to 15 minutes to understand the tumor heterogeneity in the tumor microenvironment, especially in the breast cancer as a model system, and I will show some lung metastasis in skin cancer. So you know that tumor heterogeneity is a major issue because there are many different kind of cells. They are present in the vicinity of that tumor microenvironment and they express varieties of genes and protein. And in a coordinated way, they basically controls and regulates tumor growth and metastasis. Next slide, please. I had PPT slide. Why you are opening PDF? So, in case of breast cancer, you know, all of you know here in this audience, 4 major subtypes, like luminal A, luminal B, HER2 overexpressing, and triple negative TNBC breast cancer, as well as that inflammatory breast cancer, where that entire organ become inflamed. Next one. So it starts with a little lump, and then next one. Then this tumor grow at the primary site. Next one, please. And then it goes to that target to the lymph node, metastasize to lymph node. Next one. And then not only in the lymph node, is metastasized to lung, liver, brain, and bone. And majority of them, they die because of metastasis. Next one. So I am going to give you, going through that one of the latest, our work in collaboration with Dr. Sudeep Gupta, Tata Memorial Hospital. He is also currently director of ACTREC, Mumbai. So the purpose of this project, that when the luminal positive breast cancer patient, they develop resistance. For example, I will be giving a case report of patients with 51 years age, and then with a multiple therapy including the 4-hydroxytamoxifen, 5-FU aromatase inhibitor, and develop resistance. And basically understanding that how you overcome the resistance and what is that mechanism of developing this resistance. So we compare resistance versus sensitive in luminal positive breast cancer patients. This is in collaboration with Tata Memorial Hospital. So that basically the purpose of this project to identify the potentially therapeutically relevant biomarker and what are that important therapeutic target in breast cancer, luminal positive breast cancer patients who develop that resistance with a series of chemotherapeutic drugs as well as the targeted therapy. So to do that, we came with a latest model that is called patient-derived xenograft, PDX model, which is very close to what happened in case of patient, and also establish the primary culture at the cellular level and use that genomics and proteomics approach, especially whole genome sequencing, exome sequencing, transcriptome analysis, as well as proteomics and phosphoproteomics analysis to identify that important and potential therapeutic target in this class of patient. Next one. So this is, we started with the all sample we received from Tata Memorial Hospital, with their all that informed consent and everything. And Dr. Sudeep Gupta, he was handling entire program from Tata Memorial Hospital as well as ACTREC. As you can see that we divide this patient tissue, some of them directly implant into that animal, develop PDX. India, you don't see this PDX model very much, but many other countries, including US, Europe, and Singapore, Australia, they all cancer, they develop their PDX model. These are also very important to screen drugs because many companies are here. So these are one of the best model what you see here. So we established this PDX model, or some of that we established the primary culture from that patient derived tissue, and then once you develop that PDX model generation 1, so we gone to the generation 2, 3, 4, etc. To check their whether they behave close to that patient. Next one, please. So these are the patient's ID number, and we have all these details. We started with the code number. Next one. And you can see that we have established this tumor by implanting the tumor into that specialized animal. Next one. And we characterize this whether they behave like a luminal positive by using that HER2, N-cadherin. These are EMT marker, ECAD, NCAD, vimentin, Chi67, pan-cytokeratin, especially ER alpha, PR alpha, etc. And they are showing positive. Next one. And then since we have that different generation of the tumor and we compare with the patient's tumor, and we have done that differential expression by RNA-seq, and we find, next one, that whatever we find that this expression of different genes in patient's tissue as compared to the different generation, so they are very close, and from there we came with important therapeutic target. I am not going to talk in details because of shortage of time. Next one. So we had series of publication. It's a very high quality clinical cancer research journal like Cancer Research, Oncogene, etc. Next one. Working in this area, basically identifying different drugs, repurposing drugs in that various cancer model. Next slide. So this also it happened. This is one of the godfather of clinical cancer research, Bob Weinberg, who has discovered the hallmark of cancer. So for last few years I am collaborating with him. He is from MIT Harvard, Harvard Medical School. Next. Some more publication. Next one. Next. Next. Yeah, so next 2-3 minutes I like to talk in skin cancer. Skin cancer, you know, there are two genes, mutation of these two genes. One is BRAF and another NRAS, and most of the patients, they develop lung metastasis. This is very common in Australia, Europe, US, etc. Those who are lack of melanin and white skin. Next one. So what we have done, we have isolated the cancer stem cell from these skin cancer derived cell line using varieties of signatures and marker. The markers you can see here, and this is by flow cytometry. We have analyzed that expression of cancer stem cell. Next one. And then we have tested based on that RNA-seq differential expression in cancer stem cell positive versus negative using CD133 as a marker. This is heat map and volcanoplots. Next one. And you can see there are many genes upregulates or downregulates, and if they are cancer stem cell, they should have drug resistance, they should have angiogenic property, metastasis, self-renewal, etc. Next one. And we check the expression of various stem cell specific transcription factor like OCT3, 4, nanog, etc. And they are very high in this cancer stem cell, CD133 positive cancer stem cell as compared to negative. Next one. And if they are cancer stem cell, they should have long-term tumorigenic potential, which we have tested using that preclinical animal model. Most importantly, next one. So these cancer stem cell we have injected through intravenous route and develop lung metastasis and capture these images like a CT PET scan in this case using bioluminescence technology, and this is ex vivo imaging. So these are metastasizing to lung. The purpose of developing this model to screen various drugs for the treatment of skin cancer. Next one. So we came with various druggable molecules and drugs, including dacarbazine, dabrafenib, trametinib, GSI inhibitor, and some of the druggable molecule. There are many clinical trials going on. So we selected some of that molecule, including androgapilide. Next one. And you can see that in lung metastasis model, if we use this one of the druggable molecules like androgapilide, it is basically blocking the lung metastasis, which we have checked by H and E staining. They have less micro and macromets, and also we checked based on the level of VEGF. Next one. So basically we use combination of, I have not shown all detailed data, dabrafenib, dacarbazine, trametinib along with GSI inhibitor, and we found that it is suppressing lung metastasis. Next. And these are some of the translational potential. We are closely working with various hospitals, including Tata Memorial Hospital and few others, Mangeshkar Hospital, and here KIMS, etc. Next. Next. I have many international collaborators. Next one. And many international, especially US, Australia, Norway, etc., Germany. Next. And my research group. Next one. Next. That is the highest national award I received, that is called Santi Swarup Bhatnagar Prize. Next one. Thank you very much for your attention.
Thank you, Professor. So anybody, any questions, Senapati sir, Pikeda sir?
Actually, what was your observation? I am asking about this breast tissue. In one group, you have taken that some patient had the hormone resistance and also some had hormone sensitive. So what was your observation at your lab? What is the difference that you appreciated? I think that should be the take-home message.
So what we find, this project still going on. This is this project running 5 years with Tata Memorial Hospital, ACTREC, my center, as well as NIBMG and IOB. So there are specific genes and proteins which are responsible for this resistance, and how to overcome when you are giving that multiple cycle of chemo. And how to overcome that, we are using that some composition of that druggable molecule which can basically overcome this resistance. Right, right. Thank you.
Thank you, sir. Thank you so much. So over to Romila.
So we start the second session, that is on the thorax cancer. I would request the chairpersons who would join us virtually, Dr. Ramakant Deshpande and Dr. Hemendra Modi from, who will join us on the virtual platform.
So Dr. Ramakant Deshpande, a great teacher, a great thoracic surgeon, a TMH alumni, and he is a stalwart in his own field. And Dr. Hemendra Modi, he is my buddy, so I started my oncology career in Odisha with Dr. Hemendra Modi. So he is presently at Rajkot, is Aruni Hospital. So over to the chairpersons before the first talk is being introduced.
Yeah. The first topic being lorlatinib in management of ALK rearranged non-small cell lung cancer, being presented by Dr. Jogmaya Patnaik, medical oncologist, Bhubaneswar. I would request Jogmaya to please join with us.
Okay, next. Good afternoon. So today we will discuss about the role of lorlatinib in lung cancer. As we know, lung cancer is one of the very important cancers we see day to day in our clinical practice. Worldwide, lung cancer is the second most common diagnosed cancer and the most common leading cause of cancer deaths as per 2020 Globocon data, representing at least 1 in 10 cancers diagnosed and 1 in 5 cancer deaths. Amongst the non-small cell lung cancers, around 80 to 85% of all lung cancers are NSCLC or non-small cell lung cancer amongst the lung cancer. And the 5-year survival rate is very dismal, around 20 to 25% for NSCLC patients. So lung cancer is a very mutation-rich cancer. So we have got various targeted agents along with chemotherapy options for lung cancer patients. So here you see from 2018 to 2040, if we project the lung cancer patients' data, then it shows a completely increasing trend. So from 2018 to 2040, almost we will see that every year we will see almost more than 1 lakh per 100,000 new lung cancer patients diagnosed every year. And almost similar amount of patients also will die of the disease, because most of the lung cancer patients are diagnosed in the advanced stage. So there is an unmet need to find out the proper treatment of lung cancer. So we have various mutations. As I said, it is a mutation-rich cancer. We have various mutations present in lung cancer which are targetable, or they are having some driver mutations. So RAS mutation is the most common mutation present in lung cancer. After that, EGFR and ALK mutations are the common mutations which are targetable. Many mutations are there for which targetable drug is not available. But recently we have some targetable drugs for RAS mutation. EGFR mutation, we have targetable drugs for last around 10 years. So recently we have observed a paradigm shift of treatment of ALK positive lung cancer patients, because ALK positive and EGFR positive lung cancer patients are mostly the non-smoker variety. And ALK gene rearrangement in lung cancer occurs almost around, as per the world data, it is around 4 to 5%, but Asian patients may have more number of patients, like it can reach up to 10 to 15% also. So this ALK rearrangement occurs typically in adenocarcinoma histology, mostly in never smoker, and they are mostly younger patients. Thankfully, we have proper diagnostic tests to detect the EML4 and ALK rearrangement, like the EGFR mutations. The EGFR and ALK mutations are mutually exclusive, but we see some patients of ALK and EGFR co-mutations, also these patients we see in clinical practice. So the ALK mutation, actually it is a fusion. It was reported since 2007, and there occurs a genetic rearrangement for which the mutation and the fusion occurs, and because of that there is a genetic deformation, and this deformation occurs as a driving mutation for development of non-small cell lung cancer. So after 2007, after the discovery of the EML4 ALK translocation, we have tried to develop various ALK inhibitors like crizotinib, which came in 2012. In 2015, alectinib, ceritinib, digatinib, all these drugs came. Initially, they were approved in later lines. Gradually, the second generation or third generation have come into the first line. Third generation lorlatinib was approved in 2019 for the treatment of ALK positive lung cancer. In 2021, it was approved as the frontline treatment. So, so how we test, another important point is that in patients with ALK positive lung cancer or in EGFR positive lung cancer, around 20% patients, advanced lung cancer patients will be there who will be having baseline CNS metastasis, who may have symptomatic or asymptomatic disease. So as for the guidelines, NCCN or ESMO guidelines, we should do a baseline MRI to find non-symptomatic or asymptomatic CNS metastasis in those patients of NSCLC who are ALK or EGFR positive or any targetable mutation positive, because the asymptomatic lung metastasis can be up to 20%. However, in clinical practice, we do MRI for patients who are symptomatic. For those patients only we do in a resource constraint setting, performing MRI, brain MRI for all patients may not be feasible. So MRI amongst the CT or MRI is the standard diagnostic modality to detect the CNS metastasis. So how we manage CNS metastasis in ALK positive NSCLC patients? Several systemic and local therapy options are available. Systemic therapies, basically the ALK TKIs or chemotherapy. We should also use whole brain radiotherapy or stereotactic radiotherapy. Sometimes neurosurgical intervention also helps us in managing these patients. But these treatments are used in a combined form. If the patient is minimally symptomatic, we can just give them targeted therapies. Those who have good CNS penetration, if the patient needs any local therapy, then radiotherapy or surgical options can also be provided to these patients. So the current international guidelines recommend first line treatment of ALK positive NSCLC by the ALK tyrosine kinase inhibitors like alectinib, brigatinib and lorlatinib. Other drugs are also there like crizotinib, ceritinib. These are the total list of ALK inhibitors. So how should we sequence the patients with ALK positive NSCLC and those who are treated with TKIs with or without chemotherapy with CNS disease? So patients with CNS disease or metastasis are diagnosis. First algorithm, there are two algorithms. First is that you give the first line lorlatinib, which is a third generation ALK TKI, followed by, if there is progression, then you give chemotherapy. Or another sequence is there, you give first or second generation ALK TKIs followed by second line lorlatinib, or followed by, if progression, there is option of chemotherapy still present. So another option in the treatment of ALK positive disease is liquid biopsy, which is a minimally invasive technique. Liquid biopsy, but is unlikely to characterize the molecular landscape of patients with CNS metastasis with precision. And in those cases, a CSF analysis for NGS, CSF sample for NGS is a better option. And another thing is that the biological features of the tumor also can be detected or detect or influence the ALK TKI response. So comprehensive molecular characterization of the tumor is also an important thing. And the ALK TKI uses also improves the patient's quality of life. They are good drugs which are oral and they have less side effects. Patient can take at home and with a better quality of life. And tailoring the treatment based on the molecular profile, like using ALK TKI in patients of any ALK positive lung cancer rather than chemotherapy, also improves the patient's compliance and also lowers the risk of development of CNS metastasis if that patient is to develop CNS metastasis, and in patients who have CNS metastasis, it reduces the risk of deterioration. So in summary, the patients with brain metastasis in ALK positive accounts for almost 10 to 20%. And as for the international guidelines, to detect the patients with CNS metastasis, an MRI should be done. And several ALK TKIs has been evaluated in the setting of the CNS disease, which prolong the PFS and improves the intracranial progression-free survival also. Lorlatinib is a kinase inhibitor. It's a third generation TKI which inhibits the ALK fusion protein, and it's FDA approved for the treatment of ALK positive NSCLC in the first line. So this drug was actually designed rationally to address the unmet needs of ALK positive NSCLC, that is the metastatic brain disease and also acquired resistance to ALK TKIs. Like if we use crizotinib or ceritinib, there will be developments of some ALK resistance to these drugs. So lorlatinib has been carefully designed to overcome these resistant mechanisms, and also it has effective CNS penetration and retention, so that it can go inside the CNS and prevent the further progression of the CNS disease. So in phase 2 study, lorlatinib has demonstrated marked intracranial activity in patients with CNS disease whose cancer have progressed on first or second line ALK TKIs. Therefore, it helps to manage and prevent the emergence of brain metastasis, and also it eliminates the rare pre-existing subclones that may harbor some ALK resistant mutations. Therefore, it delays the emergence of resistant subclones also. So there is a phase 3 crown trial data. This is the first line lorlatinib or lorlatinib versus crizotinib in advanced ALK positive lung cancer. That is lorlatinib used in the first line head-to-head comparison with an established first generation ALK TKI. In this, stage 3 or 4 ALK positive NSCLC patients without any prior treatment were included. Good performance status patients, asymptomatic and treated or untreated CNS metastasis patients were permitted. Measurable lesions should have been there. Then the patients were randomized with lorlatinib 100 mg once daily or crizotinib 250 mg BID. Primary endpoint was progression-free survival by independent review committee. Secondary endpoints were PFS, response rate, and intracranial response rate, duration of response, etc. Overall survival, quality of life, safety were other parameters. 296 patients were randomized from May 2017 to February 2019, and all patients underwent restaging CT, chest or abdomen and brain imaging every 8 weeks. So this is the characters were almost matched, and Asian patients were almost 40%. More patients were never smoker, but some smoker patients were also there, which amounted to almost 20 to 30%. Advanced lung cancer patients like stage 4 patients represent the most variety. 18 months follow-up data showed that comparison to crizotinib, the median PFS was 9.3 months in crizotinib arm and not reached for lorlatinib arm with a good hazard ratio of 0.28. And when we see the PFS by the investigator, still compared to crizotinib, lorlatinib was better. And as we see all the subgroups, like the presence of brain metastasis or not, Asian or non-Asian, male, female, age more than 65 or less than 65, with irrespective of smoking status, lorlatinib was better compared to crizotinib. So if the overall response rate, if we see, almost 76% of the patients in the lorlatinib arm responded to the treatment compared to crizotinib, which was almost 58%. Median duration of response was not reached in the lorlatinib arm compared to 11 months in the crizotinib arm. Intracranial overall response, if we see, almost responders, patients with measurable or non-measurable brain metastasis at baseline, almost 66% of patients responded to lorlatinib compared to crizotinib. Patients with measurable brain metastasis at baseline, 80% patients responded compared to 23% patients with crizotinib. Intracranial time to progression was also better compared to crizotinib in lorlatinib arm. Overall survival, though, was not significantly different, but numerically for some time it was better in lorlatinib compared to crizotinib. If we see safety analysis, then compared to the grade 3 or any grade of adverse events were almost similar. Grade 3-4 adverse events were slightly better, slightly more in the lorlatinib arm compared to the crizotinib. Serious adverse events were definitely more in lorlatinib arm compared to crizotinib. So what are the adverse events occurring with more than 10% frequency in lorlatinib arm? That is hypercholesterolemia, lipid profile defects or edema, weight increased, peripheral neuropathy, cognitive dysfunction. These were more in the lorlatinib arm. Sorry, edema was diarrhea was more in the crizotinib arm, and fatigue was more in the crizotinib arm. Other side effects were almost similar. And if we see the change from baseline global quality of life scores, lorlatinib was better. Like whatever the quality of life from the baseline, after using lorlatinib, the quality of life improvement was more with lorlatinib compared to crizotinib. 36-month follow-up data is also available, and it also showed better PFS in the intention to treatment arm. Like the median PFS not reached in the lorlatinib arm and crizotinib arm, it is 9.3 months. So confirmed overall response rate from the independent review committee was 77% in lorlatinib arm compared to just 60% in crizotinib arm. Median duration of response also was much better in lorlatinib compared to crizotinib. So subgroup analysis of PFS also across all the subgroup of patients, including brain metastasis, including the extent of disease, including the smoking status, and irrespective of the age, lorlatinib was better compared to crizotinib as first line treatment. So patients with baseline metastasis or patients without baseline metastasis, both of them, they responded better to lorlatinib compared to crizotinib. So lorlatinib has a very good response in patients with measurable or non-measurable symptomatic or asymptomatic brain metastasis patients. So the overall median PFS as for the 36 months data, crizotinib has a median PFS of 7.3 months compared to lorlatinib, which the median PFS has not reached as for 36 months PFS data. So as we have already discussed, that overall response rate is almost 77%, complete responses in almost 3% patients, median duration of response not reached compared to 9.6 months in crizotinib, almost intracranial overall response of 60%, and complete intracranial response of almost 60% in lorlatinib. So definitely in patients with CNS metastasis, this is a very good drug. Summary of adverse events also, as we have previously discussed, any grade side effects or any grade toxicities in lorlatinib and crizotinib were almost similar. Grade 3, grade 4 side effects were more in lorlatinib compared to crizotinib. So in conclusion, approximately 18 months of additional follow-up data was presented in this trial after the interim analysis in this Crown 3 trial. So lorlatinib continues to show superior overall and intracranial efficacy, and by the independent review committee, the PFS remained longer with lorlatinib than crizotinib at 3 years. Intracranial time to progression was longer with lorlatinib compared to crizotinib. In patients with brain metastasis, only 1 out of 112 patients had evidence of intracranial progression, suggestive a very protective effect of development of brain metastasis, almost 60 to 70% intracranial response rate, and almost 50 to 60% complete response rate with lorlatinib. So this has also reflected in NCCN guideline, which has shown that in ALK rearrangement patients, first line treatment, lorlatinib is included along with alectinib and brigatinib. So the hypertriglyceridemia and hyperlipidemia, they are the more common problem in lorlatinib, which can be managed with statins, rosuvastatin, pravastatin, all these things can be considered. And serum cholesterol triglyceride testing should be regularly performed after the starting of treatment and every 1 or 2 monthly after initiating the treatment up to at least 6 months. Any patients with hypertriglyceridemia should be managed with lipid lowering agents. So there are some evidence of CNS cognitive effects or cognitive dysfunction with lorlatinib, that is mood swings or speech or cognitive function deterioration. But these adverse events were reported with almost 11% of the patients experiencing more than one type of CNS events. And so these patients, when the already CNS disease is there and lorlatinib adds to some other cognitive dysfunction, that becomes little difficult. But these CNS symptoms can be manageable with or without some medications, and they are not severe. So there may be some dose modifications for this CNS side effects. So if mild symptoms are there, we should continue by the same dose. If any moderate or severe side effect is there, then we can reduce the dose of lorlatinib by 1 dose level, that is 25. If there is life-threatening or any urgent intervention is required for the CNS problems, then permanently lorlatinib can be discontinued. So I have used this drug in one patient. He initially complained of some mood swings and some depression. He was little withdrawal, but that improved within, I think without any medication, that improved within 1 week to 1 to 2 weeks. So overall, just summarizing, lorlatinib is a very good drug. We are actually fortunate to find a drug which has a very good CNS penetration, prevents the CNS progression, almost 60% intracranial response rate. Along with that, a very good action on non-intracranial sites. So this is definitely a very good drug to watch out for the management of NSCLC ALK positive. Thank you. Thank you so much.
Thank you, Dr. Jogmaya. Thank you, Pfizer, for sponsoring this session. So yeah, definitely this is a very good drug and category 1. So in fact, we are starting another patient on this drug. So this gentleman who has progressed after 5.5 years on crizotinib. So thank you. So now we move to our Roche sponsored talk. So Dr. Amit Sharma, so medical oncology from SCG Panda Cancer Curie. So optimizing therapy in first-line metastatic NSCLC. So by the time Dr. Amit is ready, so there is a housekeeping announcement. Due to some technical glitch, we need a 10-minute break after Dr. Amit Sharma. So we do apology to both the chairperson, sir. So because there is a short circuit and we need to repair that. So over to Dr. Amit.
Thank you so much, Rosh, Deepak. So today I am going to present about immunotherapy, the role of atezolizumab specifically. Can you just change it? So we are going to talk about Tecentriq's, the role of atezolizumab in optimizing the treatment for first-line metastatic non-small cell lung cancer. So I will try to explain a little bit about the trials related to that. Okay, so these are my disclosures. So the table of content is basically the disease background. And basically the three main trials, one is IM Power 110, IM Power 150, and IM power 130, followed by, I will summarize the 3 trials. So basically, this is just in brief about the disease. This is a slow growing tumor and accounts for 80 to 85% of all lung cancers. And median age is somewhere around 70 years, and METs generally occur later in the disease process. So 50% of the patients have disease metastasis at the time, only 50% of the patients have metastasis at the time of diagnosis. And there are several targeted agents, one of which has already been shown by Dr. Jogmaya Patnaik about, she showed about lorlatinib. So basically in 80s we have chemotherapy in non-small cell and non-small cell lung cancer, and later on we decided that we will give chemotherapy or anti-angiogenic agent based on the histological type. And then comes the targeted therapy with the role of EGFR, ALK, ROS and BRAF. And thereafter, now those patients, there was always an unmet need where the targeted therapy was not available, and these patients we think about cancer immunotherapy. So this is the impact of targeted therapy in cases of non-small cell lung cancer, where there is actionable biomarkers is available. But look at the pie chart over there. There is 35% of patient who doesn't have any actionable biomarkers. So what to do in these patients? So let's see. So this is the 3 main trials which are designed for the first line role of metastatic non-small cell lung cancers, where targeted therapy is not feasible because of non-actionable any targeted mutations. So these are the 3 main trials. One is IM power 110, IM power 130 and IM power 150. So they are designed basically to test the different hypotheses. For example, IM power 110 was basically designed if there are patients who are PD-L1 strongly positive, can we just give away with the atezolizumab monotherapy and completely avoid the patient from chemotherapy side effects. Then comes the IM power 130, which is basically based on the concept that if we can give steroid sparing agent like nab-paclitaxel along with the chemotherapy, can we give a steroid sparing agent. So basically this was the IM power 130, and my IM power 150 was basically addition of atezolizumab along with anti-angiogenic agent bevacizumab to the chemotherapy to see if we can get any further benefit. So I will go for IM power 110. It was designed for both squamous and non-squamous non-small cell lung cancer. This is very important. Next slide. So this was the basically design of the trial. All the stage for non-squamous or squamous non-small lung cancer who are chemotherapy naive, and PD-L1 selected based on this SP242. And they were basically divided into randomized into 1:1. One arm was atezolizumab 1200 milligram 3 weekly, followed by maintenance atezolizumab 3 weekly till progression or loss of clinical benefit. And chemotherapy was designed based on histology in non-squamous, pamitaxel carboplatin in squamous. There was Gemcis or carboplatin. So followed by chemotherapy maintenance with pamitaxel in non-squamous variety, and squamous best supportive care till progression of the disease. So, so this is basically how they did the PD-L1 expression. It was done on the basis of SP142, which was based on basically tumor cell 3, tumor cell 2 or tumor cell 1, categorized in based on the percentage of tumor cells present which have PD-L1 positivity, and IC1, IC2, IC3, which was basically the percentage of tumor cells which have TILs, tumor infiltrating cells. Again, they were divided into 1, 2, 3 based on more than 50% TC or more than 10% IC, which was supposed to be a very high PD-L1 status, and then in intermediate, which means more than 5% of TC or IC, and then maybe you can say it is PD-L1 negative with more than 1% TC or IC. So based on these things, we will decide, we will get the results, read the results of further trials. So basically very homogenized population. It is very well divided in between both the arms, in between TC 1, 2, 3 or TC. And also in terms of age, ethnicity, and based on tobacco smoking or not, or even histology. It's a very well balanced cohorts. So this is the first result which we got. So median overall survival, we can clearly see there is a benefit of 7.1 months with atezolizumab alone, especially in those patients which are TC3 or IC3 high. So basically you can read it as a PD-L1 positive, or you can say it is strongly positive. Look at the median overall survival, which is 13.1 months at the end of somewhere around 13 months. So it's a pretty good median overall survival, and it is continuing till the data we have up to 34 months. And this overall survival benefit was seen all along the subgroups, only except never used tobacco. Otherwise, we can see there is a benefit all along the subgroups. And again, the updated exploratory analysis of overall survival is maintaining that median follow-up goes up to 31.3 months, and with hazard ratio pretty good, 0.76. So what about subsequent chemotherapy, cancer therapies? In this particular trial, the little bit of crossover was allowed, and this crossover was more or less same. The equal number of patients have been switched on from atezo to chemo or chemo to atezo, and the overall survival was more or less maintained. And when we look at the overall survival, which strongly favored atezolizumab versus chemotherapy after adjusting the subsequent immunotherapy use, the same thing was shown in the previous slide. But so look at and one important thing is, suppose if we have done PD-L1 from some other testing kit like TPS, we calculate TPS, or we calculate use SP263 and calculate TC more than TC values. Even then we can see there is a very good correlation between these TC3 and IC3 in terms of, and all these testing kits, when we compare them, mostly the survival benefits are more or less maintained. So when we look at the PFS, again the PFS benefit is still there. Median PFS is, the benefit is somewhere around 8.1 months, with hazard ratio again very good, 0.63. This median PFS is, even in the update analysis, this median PFS is very well maintained, and hazard ratio is even better, 0.59. And when we look at this is a strong PD-L1 positive TC3 IC3 population. When we look at the overall response rate, again arm A scores much higher, 40% against the only 28% in chemotherapy arm. So when we look at the side effects, we can assume that all the side effects which are related to immunotherapy, like hypothyroidism, and here is a better, we can look at the AST rise, pruritus, and hypothyroidism. These are the three main side effects which are more in immunotherapy arm compared to chemotherapy arm. All the rest of the side effects are more towards the chemotherapy arm. So to summarize, IM power 110, it represents a promising first-line treatment option in patients with PD-L1 high non-small cell lung cancer, whether it's squamous or non-squamous, doesn't matter. And basically it is done for TC3, the benefits are seen only in the TC3 or IC3 population. The safety profile is consistent like any other atezolizumab trial, and all the survival response rates are towards the favor of immunotherapy alone. So this is the second trial, IM power 150. This is done exclusively in the non-squamous, non-small cell lung cancer category. And again, this is a phase 3 trial. And this is stage 4, the design is stage 4 non-squamous lung cancer, chemotherapy naive. And they are again categorized on the basis of PD-L1 using SP142. And they are further randomized into 3 arms. One was atezolizumab along with carboplatin and paclitaxel. The second arm was atezolizumab along with carboplatin and paclitaxel and bevacizumab arm. This is and third arm was carboplatin, paclitaxel along with bevacizumab. So accordingly, the maintenance was they have go ahead with the maintenance with arm A atezolizumab maintenance, arm B where they used both atezo and bevacizumab, they give the maintenance of atezo and bevacizumab, and in the third arm where chemotherapy and anti-angiogenic was used, there bevacizumab maintenance was used. So how actually the whole theory was that bevacizumab increases the immunogenicity of immunotherapy, and there are various mechanisms they have shown that there is a better priming, release of tumor antigen because of chemotherapy induced immunogenic cell death, and bevacizumab also normalize the tumor vasculature so that more tumor infiltrating cells can infiltrate the tumor. So these are several mechanisms where both chemotherapy and bevacizumab act synergetically with immunotherapy. So that was the basic idea. So what was the characteristics of the three arms? Again, mostly this is a very homogeneous population along all the cohorts, but the important thing is 14% of the patient also they have taken liver meds. No other immunotherapy trial has taken liver meds. And second thing was even 10% of those patients have EGFR mutation positive. So they tested on these patient population as well. And again, they also divide the patients on the basis of tumor burden, high burden or low burden. So three main things. One is the presence of liver mets, which were not used in any other immunotherapy trials. Second thing, high burden, low burden. And third thing, EGFR positive patients was also included in this. So these are three exclusive things which are there only in this particular trial, immunotherapy trial. So next, we could see here the overall survival benefit when we compared arm B, that is the basically standard arm where they use all the four drugs, atezolizumab, bevacizumab and chemotherapy. And the arm C was only without any immunotherapy. So when they compare these two arms, we can clearly see that there is a hazard of 0.8. This is good enough hazard ratio. And at the end of 2 years, 40% of the patient in immunotherapy arm was alive compared to only 30% of the patient which are alive in chemotherapy and anti-angiogenic arm. And median, there is a good median follow-up, almost 40 months follow-up. So the improvement of median overall survival is somewhere around 4.5 months, which is again very good. So when we look at what are the response rates and duration of response, again the arm which include all the three type of molecules, like that is chemotherapy, anti-angiogenic agent, and immunotherapy, we can look at the arm B. The response rates are 56%. This is the intent to treat population. If you look at all the categories, TC3 or TC1 or TC0, in all the three categories we can see arm B is heading much higher than any other categories. And look at the high TC3 category, the arm B with atezolizumab, the response rate is as high as 69%. That is tremendous response rates. Look at the PDL1 high again very closely. When we compare arm B versus arm C, we can see in the higher TC category, the hazard ratios are pretty good, 0.7. And again, we can see the after the median follow-up, there is a survival of around 30 months. So good. So next is a PDL1 positive patient. When we look at compare the arm B versus arm C, again that the three drug arm versus chemotherapy and anti-angiogenic arm, we can see the hazard ratios are good, 0.73. When we look at the PDL1 negative arm, even then we can see the hazard ratios not that good, but still there is a definite benefit. The hazard ratio is 0.9. So even in PDL1 negative patients, we can see there is a benefit of adding immunotherapy. So when we look at the EGFR positive EGFR TKI patients, so in those patients, even in those patients, we are included in this particular trial. So look at the results of that thing. So total intent of treatment population was 1,200 patients. Out of this, EGFR mutation or ALK rearrangement was positive in 160 patients. So there is a good number of patients who have EGFR mutation positive as well. But look at the sensitizing EGFR mutation, that out of 160, only 90 patients have sensitizing EGFR mutation. So what was the result? Difficult to explain, but PFS curve, you look at the hazard ratios is still 0.59 with atezolizumab, bevacizumab, CP without using any targeted agent. So this is something, the only one immunotherapy trial which has shown some benefit even in target positive population is this trial. But again, the sample size, population size, is very small. So let's see what we can see in further slides. So look at the arm B versus arm C. Hazard ratio is very good, 0.6 when we add immunotherapy. But when we compare arm A versus arm C, the hazard ratios is 1. So there is no benefit between the arm where bevacizumab is not used. So somewhere down the line, I get the impact when we use bevacizumab along with atezolizumab, then we can get benefit in these subgroup of patients. But when we remove the bevacizumab out of the context, then probably the immunotherapy is not having the same kind of impact in this subgroup of patients. So again, the same thing is seen in the EGFR positive prior TKI therapy. You can see here hazard ratio there, arm A versus arm C without bevacizumab, hazard ratio is 1.22, whether you use immunotherapy or not. So again, the response rates were increased in this arm, in the EGFR positive 70% versus 42%. Good thing. But look at the number of patients, only 24 in that arm and 18 patients in the other arm. Maybe we will look further in these studies. The one interesting thing is liver metastasis. Only this particular immunotherapy trial which used the patients with liver metastasis. So look at the results. Hazard ratio is very nice. Hazard ratio is 0.4, and a patient with liver mets has a clinically very significant, meaningful survival benefit we can see here. So when we have upfront liver metastasis, this is probably maybe we can use this particular agent atezolizumab, because no other immunotherapy trial has shown the same sort of a benefit in liver metastasis condition. And this again arm B versus arm C, the same kind of criteria you can see here. When you mix atezolizumab with bevacizumab, you can see the benefit. But once you remove the arm A versus arm C, no benefit. So look at the overall response rate, again very significant difference, 60% versus 40% in the patients who have liver mets. Again, the third thing which they use is divided on the base of bulky disease. Again, they divide the bulky disease on the base of the diameter of the tumor and a number of mets. So whether it is based on the tumor diameter or the number of the mets, we can see the hazard ratios are very much in the favor of arm which is having immunotherapy. So this is the same thing which has been written. So when we look at the overall the treatment related side effects, they are all, I mean, as we expect them: hypothyroidism, pneumonitis, hyperthyroidism, autoimmune colitis. They are all more into in the arms which have atezolizumab. But overall arm B was very well tolerated. I should say grade 3, grade 4 reactions are very less. So to summarize this, IM power 150 met both the co-primary endpoints. That is with the arm B, where we include chemoimmunotherapy along with anti-VEGF. There was significant, meaningful improvement in PFS and overall survival, and especially though even in patients who have EGFR positive, ALK positive or liver metastasis, and also in the high burden disease. So this is the final and the last trial I would like to show, IM power 130. Again, it is done only in non-squamous non-small cell lung cancer. The idea I already told you, to use nab-paclitaxel instead of normal paclitaxel along with atezolizumab. So just to make sure that we can have steroid sparing agent chemotherapy. So we already discussed that chemotherapy also increased the immunogenicity of the surrounding environment. So immunotherapy worked better. In this condition, the design of the trial is more or less same. Stage 4 non-small cell lung cancer, target non-targetable. EGFR PS based on the stratification was done on the basis of PS, sex and PDL1 ratios. Liver mets were also included in this trial as well. The basic trial design was arm A divided on 2:1. Trial design was arm A contains immunotherapy along with chemotherapy, followed by maintenance immunotherapy till progression, and arm B contain only chemotherapy with combination of nab-paclitaxel carboplatin, followed by pemetrexed maintenance till progressive disease. So look at the subgroup analysis. We can see there is a well-matched group. Nothing to discuss about this. So when we look at the PFS, we can clearly see there is a benefit of adding immunotherapy in nab-paclitaxel carboplatin with hazard ratio of 0.64 in PFS, and similar kind of results we can see here in overall survival graphs. Hazard ratio is 0.79. And when we look at the forest chart, we can see clearly that only, I think, in non-smokers, again, there is current smoker or non-smoker, there may be some hazard ratios are not that good. Otherwise, more or less, it's meeting all the endpoints in all the subgroups. When we look at the investigator assessed PFS, again the hazard ratios are pretty good along with overall survival. Just a sec. This was in those patients which are EGFR ALK positive. In the investigator assessed PFS, the hazard ratio was 0.75, but look at the overall survival. There was no benefit in this trial. As previously we already discussed that unless and until you add bevacizumab, the benefit is not there. Though this is again confirmed here that without bevacizumab, this population that is ALK positive or EGFR positive, the benefit is not there. The same thing is shown here in reflected in overall response rate and duration of response. When we look at the side effects, again there was typical side effects. Chemotherapy side effects are more in the chemotherapy arm, and hypothyroidism, colitis and all that are more common in immunotherapy arm. So to conclude that, IM Power 130 was again a positive study for first line non-small cell lung cancer, providing an alternative chemotherapy regimen, especially in non-squamous variety. And this is the benefit was altogether in all the subgroups, it doesn't matter. And PFS benefit was also there, overall response rates are also better. And there was no benefit in this particular trial in EGFR ALK positive patients. So that again proves the same theory which I discussed in the previous slides. So I think that is the end of my talk. So thank you so much.
Thank you, Dr. Amit, and thank you, Roshan. We take a 10 minutes, no. Any questions, please? Any questions? No. Thank you. So we take a 10 minutes of break for some technical glitch back in. We'll join for the panel discussion after 10 minutes. Thank you.
We are going live again. Come back soon. Come back. Come. हाँ ठीक है मैं सेटा देखी देवी तू आसो तुम आगे है हाँ सब हो गया तुम आसो शीघ्र
नेक्स्ट बघा रोज पर कौन करिया जीवा हेला नहीं किसी है ही नहीं स्टार्ट करो स्टार्ट करो नेक्स्ट should I start? So ladies and gentlemen, we are back after the technical glitch. So we'll start with the panel discussion. So over to Dr. Amila.
Panel discussion on management of early stage lung cancer. It's being moderated by Dr. Vamsi Krishna on virtual platform. I hope he's here with us. Has he joined?
Dr. Yes, Vamsi Krishna is a TMH alumni. So he'll be coming to Bhubaneswar tomorrow for the other session physically. So he is presently the director of AIG, Hospital, Hyderabad. So his panelist will be Dr. Chandrakant, MB from NH, Kolkata, Dr. Susan Paikrai from SCG and AMRI, Dr. Devadullah Biswal from Raipur, Dr. Pratik Tiwari, Dr. Prakash Swain, Dr. Sandeep Barik, and Dr. Manjunath. So Dr. Chandrakant and Dr. Devadullah will be, and Pratik will be virtual.
Dr. Devadullah is also joining virtually.
Yeah. So the panel will be discussing on the management of early stage lung cancer sponsored by AstraZeneca.
So can I please request the panelists to join the stage? Chairperson.
Can I start, Dr. Ghanshyam? Am I audible?
Yeah, please, Vamshi.
Okay. Sorry, I was waiting for you. I thought you'll give me a heads up. Right. So good afternoon, everyone, and it's nice to do this kind of different hybrid and so on meetings. It would be nice to be here, but sometimes it's difficult. So among my panelists, Dr. Chandrakant, I can see is there. Dr. Chandrakant, can you hear me? Dr. Chandrakant?
Hi, sir.
Yeah, very good. Just requesting you to keep your video on, it'll be nice. Dr. Devadullah Biswal, are you around? Dr. Devadullah Biswal? Dr. Pratik? I can see Dr. Prakash Swain is there. He's sitting on the stage. Yeah, okay. And Dr. Sandeep Barik and then Dr. Manjunath. Is Manjunath there?
No.
Dr. Manjunath? Okay. Okay, he's the only surgical oncologist, so I would like to know if he's there. Dr. Manjunath, are you around? There in the stage? No. Okay, fine. So what I'll do is in the next 25 minutes or so, we'll talk of early lung cancer and see what we are doing in early lung cancer nowadays. Specifically, of course, we'll try to look at the medical oncology side of it because, well, by and large, the surgical and radiation is reasonably simple or reasonably straightforward. I will call it simple. So, case is a 67-year-old gentleman, a non-smoker who had only mild cough. He was evaluated outside, found to have a small lesion in the left upper lobe, and the CT scan also showed a left apical lobe tumor. Now, this is the tumor. As you can see, a nice, well-defined lesion in the left apical lobe, and you can appreciate there's not much seen in the middle of the mediastinum here. It's a single node, a single lesion. And this is the PET scan report. Intensely avid, well-defined soft tissue lesion in apico-posterior segment, neoplastic, non-FDG avid prevascular lymph node, which is likely reactive, and no other metastasis seen. Right? So let me just start off with our physical people there. How do you decide the management? Dr. Sushant? Yes. Does this patient ever come to a medical oncologist, or is it something that we should all discuss all cases in the MDT? How is it done at your place?
I think it is the only thing, solitary nodule in the PET CT, I think, because, and if it is the solitary nodule, then we have to go ahead with the CT guided biopsy first from the nodule, and we should go ahead with also MRI brain to rule out the brain mets, and if it is along with that, I have to discuss with our surgeon for the surgery.
Okay, so you will, my question mainly relates to the fact that how are we deciding such cases? Is it an individual decision? Is it an MDT? What is the better way to decide?
Sorry, I didn't get it.
I was asking, is it something decided in the MDT, or is it like you decide and you say to the surgeon,
No,
hey,
no,
you
no.
look at
It should be discussed with MDT, along with surgical oncology, radiation oncology, and medical oncology in the institute, so that we can properly decide whether we will go for surgery or not.
Okay, Dr. Sandeep Parikh and Dr. Rakesh, since you are also there, the same opinion, discuss in the MDT, or is it a decision nowadays made independently still? No, the decision of whether to do a MRI, biopsy, all that is fine. All that has been done. That is fine. The next step, is it decided in an MDT decision or is it decided individually? That's what I wanted to just bring about. Okay, I cannot hear. Okay, fine. In the meantime, if I could ask Dr. Chandrakant, what is your practice and how is it decided in your place?
So definitely, all these patients who require more than one discipline, we must go through an MDT.
Okay, very good. Dr. Deba Dalal, are you there? Dr. Deba Biswal, is he there? Can't see him. Okay. Dr. Manjunath, are you there? Not yet joined? Okay. I see that, I think Dr. Not there?
Okay. Good afternoon, sir. I am Dr. Sunil Agarwal, surgical oncologist.
Great, Dr. Sunil. Good. We wanted a surgeon on the panel. So, this sort of a case, is it decided in MDT or is it something that you would decide based on, your feeling or your experience with the case? The case is a young patient.
Yeah, definitely. This is not a single case. All the case should be discussed with the MDT because with the discussion of MDT, whatever the best possible things which can be done for the patient can come out. So
Wonderful.
Definitely it should be discussed in an MDT.
Perfect. So I think one part which has already been addressed is the role of an MRI. I think all patients do undergo an MRI unless already you are showing some lesions on the PET. I think that's a fair enough summation. Dr. Sushant, you wrote this point that you wanted a MRI. So is this okay? If a PET is showing, then it's fine. Otherwise, any patient with an early lung cancer, we would like to do an MRI brain. I think that's a given, right? All the panelists agree, I hope. So the next question really is, what is the role of pathological or mediastinal staging? And how do you really do it? Do you do it before surgery? Do you do it after surgery? So Dr. Sanjay, since you're the surgeon on stage. Pathological or mediastinal staging, would you advise it? And when do you do it?
So definitely mediastinal staging is very important before proceeding for and deciding what kind of treatment. So I don't know exactly like what you have asked. If you ask me mediastinal staging, it should start from your radiological investigation, which includes CT, and the complementary will be an MRI. Along with that, PET scan will be definitely a helpful one. Now, depending on the result of the PET scan, you can go ahead with a mediastinal staging by mediastinoscopy, and the doubtful if nodes are there, in which level the PET scan shows, you can sample it also, and based on that sampling, you can decide what kind of next treatment you can go ahead with that one.
Okay, Dr. Sanjay, I think you have missed this slide. If you can see the slide, it says there's a FDG avid lesion in the lung and there's a non-FDG avid subcentimetric prevascular lymph nodes. Now the PET says it is likely non-specific. If it says PET is negative, are you still going to prove it? Because the data says that if you have a PET positive, you would like to confirm it with an EUS rather than the other way around. So if it's PET negative, it's likely to be negative. So in this sort of a situation, would you still do some staging or you're comfortable with this?
No, definitely. So this patient, I don't see the size of the lesion, but definitely if I have seen the PET scan, so it's a small localized lesion on the upper lobe. So, and the PET scan is showing no evidence of any other disease. I will take up this patient for a surgical upper lobectomy, but beforehand, I will do a staging mediastinoscopy and do the upper mediastinum nodal sampling and send it for frozen section. If it is coming negative, then I will definitely go ahead with the surgical part. But yes, to answer your question, definitely staging is a mandatory before proceeding for the resection part.
Very good. So the reason I ask again is mediastinoscopy is actually not being, the use is coming down, especially even intra-op, people are kind of going with an EUS before, and with the negative EUS, you can omit mediastinoscopy. So Dr. Sandeep and Dr. Prakash, what's your thought on that? Would you omit a mediastinoscopy, or would you just leave it to the surgeons to decide?
We can go ahead with a mediastinoscopy, or better we can, if we have a endoscopy guided biopsy facility, we can avail that EBUS type biopsy or FNSC sampling.
Okay. Dr. Biswal has joined us. So Dr. Deva, just a quick case. There is a young, reasonably fit male with a complaint of a apical lobe lesion, 2 centimeter lesion, with a single prevascular lymph node, which is non-FDG avid. So we are just discussing the steps on how we will manage it in an MDD. So that's basically where we are. Okay. So one question is, do we really need a biopsy for all cases? And the tissue is small. Would you really need a biopsy? Dr. Chandrakant, would you want a biopsy in every case? And
yeah. So biopsy of the primary you're asking?
Yes.
Yes, I think histologically I would need a biopsy for all patients.
Very good. So again, is it a challenge in these early cases where you don't have a big tumor? I mean, we are of course used to these big metastatic tumors where you can pick up from wherever you want. In an early tumor, is there a real challenge in it? And are you happy with just an FNA, or would you want a biopsy?
I would need a biopsy.
You need a biopsy. Okay. So coming to the medical oncologists on the panel, do we, Dr. Devadila, first question for you. Do you want to do any test upfront? I mean, I have written some. I have written a EGFR, AL. Would you like to do that only? Would you like to do an NGS? Would you like a PDL1? Remember, I'm talking about a biopsy. Your surgeon has seen the case. He has done a biopsy because someone said, he said, I can operate. Would you still want to do any test beforehand?
So it is a 2 centimeter?
2.5 centimeter, single pre-mass node, which is non-FDG avid.
Okay. So NGS has been done, biopsy has been done?
No, NGS has not been done, only biopsy has been done. It has come as an adenocarcinoma. I am asking you, before you send for a surgery, or do you want to do something else, and when would you like to do these tests, if at all you want to do these tests?
Actually, the surgeon should be able to say that whether they can remove this.
Okay.
Also, the node is possible, or after the excisional biopsy or the lobectomy, we have everything.
All right.
And right
So
now,
you wait for the final report before you decide.
Recently, nivolumab got. Yeah.
Yeah. So that's exactly why I'm asking you. This is exactly the reason.
Nivolumab got.
Okay. Very good.
Nivolumab got approval in this year only for new.
Yes, nivolumab has been given approval for neoadjuvant lung. That's exactly where I'm coming to. That do we want to use that, or what we believe with that data?
Yeah.
Where I'm coming to. Dr. Pratik, are you there? Dr. Pratik Tiwari, have you joined?
Dr. Pratik has not joined.
So my next question is that only. Dr. Chandrakant, where would you want these tests done? Now this case is 2.5 centimeter. Single node negative, so your surgeon is confident that I can knock it off. It's just a stage 1 or maximum stage 1B. Where would you want these tests, or would you want to do these tests at all in your pre-operative period?
Up to now, we're not practicing neoadjuvant immunotherapy, so I would not go ahead with molecular tests before surgery.
Okay, so this patient, EUS was done, no mediastinal nodes. Medically fit, is operable. So what would be the next step? So I'll start with the surgeon, and you would say surgery for this patient.
So, I think this is the question for the surgical oncologist.
It's a question for everybody in the panel, one after other.
So if no nodes are there and 2.5 centimeter upper lobe lesion, it's a clear-cut case of doing an upper lobectomy with an N1 nodal dissection completely and sampling of the N2, and definitely it's a curative surgery.
Okay, we'll come to whether curative or not later, but okay, perfect surgery is what you suggest. Great. Dr. Sushant Paikre, would you agree with this? And you know, I have given you these options of surgery or SBRT. Now, let's forget this case, but where would you want to do, let's say, the bottom two things? Would you have any area where you want to do an NACT followed by a surgery, or even an NACT RT followed by surgery?
No. Here it is, if you stage this, if the mediastinal node...
Yeah, not this case. And I agree. With this case, it is 2.5, it will go for lobectomy. I'm asking, where would you want to do NACT?
No, here we will not give NACT. We will go ahead with surgery.
Yeah, but where would you want to do NACT? In which condition would you like to do NACT is what I'm asking.
If the patient have upfront is not operable, if they have some medical condition at that time for the breathing process to take some time, then we can add some chemotherapy before surgery. But frankly speaking, I am not using any sort of NACT for this patient, and till now I am okay with surgery.
Okay. Dr. Biswal and then Dr. Chandrakant. Where would you want to do the NACT? Again, I agree in this case probably all of us would say. Yeah.
Advanced stage 3.
What stage? So exact 2A, 2B, 3A? Where would you see that?
3B.
3B. Okay. So anything less than 3B, you would want to go for a surgery, if I understand you correctly.
Yeah.
Okay. Chandrakant, we are making inroads in 2A, 2B with all the NACT trials. We have neoadjuvant. You have the keynote, the checkmate 816 with you. Would you still want to give everything to the surgeon, or would you want to give the NACT first?
Yeah, I think if you have a single station N2, or if you have a tumor that is close to a main artery where you need shrinkage, in these select situations, you may consider neoadjuvant chemotherapy.
Okay. So Dr. Amish Vora has just put a group message. He says only in 3A. He doesn't want to do it anywhere else. So interesting.
Vamsi, Dr. Ramakant sir is there as a chairperson. So we have the greatest thoracic surgeons.
Okay. I didn't know, sir. If Dr. Ramakant is there, I must be laughing. Okay, surgeons are there to cut. Why are these people trying to butt in and do things unnecessarily? Dr. Ramakant sir, what's your thought on this? Can I hear Dr. Ramakant, if you can hear me? Or... Okay, till then, Dr. Vijay Patil has raised his hand. Does he want to join in? Dr. Vijay?
Vamshi, I'm surprised. Why are the panelists not interested in the checkmate 816 data? It was for 1B to 3A.
Absolutely.
That is a survival benefit. And the OS events were not matured, so we don't know about the OS, but it's a pretty good data. Why is no one interested in doing neoadjuvant nivolumab in this patient?
Chandrakant, you want to take that?
Yes, sir.
You have said
Sir, this has recently come, and we are in India, so we are skeptic about those things. And right now, you have only said that the dose of nivolumab is you have changed the scenario. It's from 240 to 140 to 20, as low as 10. So we are still recovering from those shocks. So please guide us. If we follow that one, can we use your dose, 20 mg?
I think, sir, let's still not jump into the 20 mg until TMS brings out its next paper whenever Vijay Patil decides to do that. But seriously, for me, this is an interesting question which he's raising. Chandrakant, is PAT-CR the right marker there? No, that's what really strikes me about this 816. You're saying EFS and you're saying PAT-CR. And PAT-CR jumping up and then saying, look, PAT-CR is better. When did you ever look at PAT-CR in lung? NACT gives you 2%, this is 16%. Is that the right marker? Is that why we should be a bit skeptical about the NAIT, if I can put it?
No, true, the endpoint is PAT-CR, And even the event-free survival also is impressive. You know, it looks practice changing, but you know, I would still wait unless it is replicated in multiple mode trials. But I agree, it's a very impressive data, and there is a time where it will be practice changing.
I think Vijay, that kind of answers your question. I think we are still not very confident of whether we should talk of only the EFS and the fact that we are looking at a PATS here. So anyway, let's just go a little faster. We have only 10 minutes, less than 10 minutes left. So in this patient, we did undergo a surgery. It was a 2.9 centimeter single tumor, moderately differentiated. Now, interestingly, patient had 2 lymph nodes in the hilar region in the station 10 and 11. So it was actually a node positive disease which was not picked up on the PET CT. So it's a T2N1. Okay, so it's stage 2 and above now. It's not a 1B anymore, it's a stage 2. So if I can just start off, any role for radiotherapy here? If I can ask the radiation oncologist on stage. Post-operative radiation, any role?
Yes, in this case, early stage lung cancer, which is margin negative T2N1, definitely there is no role of post-operative RT here. Only if there would have been a margin compromise, margin positive, we would have thought of a radiation there. Otherwise, there is no role.
Okay, very good. So, Dr. Dulal, what's your plan for the chemotherapy? Would you give it in all cases? Is chemotherapy still there with all the newer data that we are having?
So this is stage 3A, right?
Yes, I think 2B it will be, N2.
No, it is hilar nodes.
Yes.
So
3A.
Okay, so we will give.
You still want to give adjuvant chemo or not?
Yeah, we want to give adjuvant chemo. There is survival data.
So this is where Dr. Amish is asking, and I'm going to answer him as well. Let the panelists answer. Dr. Chandrakant, would you routinely now test for EGFR? You said in upfront we're not testing. We don't do. Would you do a driver mutation testing? Would you do it with the baseline biopsy or the sample? Since your surgeon has given you a big sample, is that better?
I think either of them. You know, I will do a molecular test, at least an EGFR in this patient.
Okay. So can I have a show of hands from the audience, from the panel on stage? How many of you would order this patient is 2B? If supposing 1B to 3A, would you order a EGFR testing? How many would order a EGFR testing? Panel on stage, you can just show a raise of hands.
We will do NGS. NGS is now cheaper than EGFR. So
okay,
if we want to have some data, let's have some 12 gene panel.
Okay, the famous 12 gene panel. Fair enough. So that's what we will be possibly doing. The reason again is in our patient we did it, and patient had an EGFR L858R. He did have COVID-19. This was some months back. He recovered completely normal. So Chandrakant, EGFR positive, would you jump the gun? 2B, would you go for EGFR directed therapy or not?
So yes, if a patient qualifies for chemotherapy, I will give 4 cycles of platinum-based chemotherapy followed by osimertinib maintenance.
Okay. So what about the rest, Dr. Devadulal? Would you also plan?
Yeah. This is a bad mutation. So osimertinib has data. Adjuvant chemotherapy plus, yeah.
Okay, fantastic. What about the rest of the panel? Dr. Shaikh, sir, I'm sorry, I'm just missing the name. Yeah, Dr. Sushant Paikre, would you also agree with this? Would you give?
Yeah. So if EGFR detected and the similar patient, I also find this COVID-19 period, but many of patient also detected during that time because of COVID-19. During screening, we detected one bronchogenic carcinoma that patient have small lesion in bronchus. So I have that confidence with, if possible, in age patient, very old patient, more than 60 and 70-year-old, if it is EGFR positive, we can use osimertinib in this case.
Okay. So would you use only this thing? Would you be comfortable with only osimertinib, or do you want to use anything else? Because you know the ADAURA trial was for osimertinib only.
To me, this question to me?
Yes, I'm asking you only.
Yeah, definitely. If it is EGFR positive, I have my opinion. We have to use osimertinib as per the data. and to avoid the chemotherapy toxicity. We are initially we are not using this, but after this data, if patient have EGFR positive, we should definitely go for osimertinib.
Okay, excellent. So one thing which I think is what I was trying to bring out is that irrespective of the EGFR, you are going to give your adjuvant chemo any which way, because chemo showed you overall survival advantage of 5% in all cases, which ADAURA has still not shown. As Dr. Amish has put up, ADAURA has still not shown as an overall survival. It's shown as a benefit, but no overall survival benefit. Chandrakant, you know, the trial actually was for statistically to be 2 and 3A, and 1B was 30% of the patients, and in 1B there was no benefit. Would you still use it irrespective of 1B to 3A, or would you restrict your use to 2 and 3A?
I mean, I would stick to the inclusion criteria of ADAURA.
Okay. So this is the DFS in 2 and 3A, which is significantly better. Whether you would want to use it in this thing, well, I'm not very sure of what everyone would do. I would personally not use it in probably a 1B. I know Dr. Amish has said that he's going to use it everywhere, but that's fine. Everyone, like Chandrakant says, it's there in the study, so probably you can use it. And main thing, this is where these subsets are. So this is what I was saying, the 1B subset isn't done as well. EGFR in both the exon 19 and deletion 19, it has done well. So again, we are comfortable with this. Now, interestingly, you know, there is no OS data, and we have 2 PKIs negative data. But still, I mean, the ADAURA with such a huge DFS HR, can we just ignore these HRs? I mean, Chandrakant, you have said that you would be comfortable in giving off osimertinib in all these patients. You are okay with this, you don't want to wait for the HR, the overall survival.
True, sir. True. I would like to give osimertinib and even probably beyond 3 years as of now.
Beyond 3, okay. Now you are really, you know, pushing the boundaries. Huh? Beyond 3 years also you want to give. Excellent. Great. So at least this is what I think the major takeaway for us has been. As you have also messaged, the NIVO probably is going to come into the NCCN guidelines if you want to follow the NCCN guidelines and believe it as much. So for me, at least, this question has been answered in the ADAURA trial. It is a practice-changing trial. There is really no doubt about it. It's a practice-changing trial. We are offering it to patients. Again, for various reasons that we are all aware of, we may not be able to give it to all patients. Cost being a definite hindrance to us, but certainly it is right now practice-changing and something we should offer. And this is what the NCCN says. So it does say that you should be offering them chemotherapy plus osimertinib for anywhere above 1B onwards. So wherever EGFR positive, you should do. So for me, the basic take home from the whole last 1 year has been, even in adjuvant, do the EGFR test. This is something we were not doing. Do it. I'm not sure if we find an ALK, whether we can still be justified in using an ALK inhibitor, with the data is still awaited from Alchemist. But otherwise, EGFR wise, at least we know that we should use osimertinib, and I think that's pretty much become a standard of care. So thank you everyone. And
Vamsi, I think Vijay has a question.
Vijay has kept his hand up, so yeah, Vijay, you can go ahead.
My question was same, Vamsi, what Dr. Amish had put. We didn't have OS data for osimertinib, but still we want to give it. But the same situation is with nivolumab. We don't have OS data. So what stops us from giving, what hampers the people from giving nivolumab?
I think we need somebody to come into the NCCN panel and write it. I think half the people will be convinced after that. Dr. Amish, last point for you.
Yeah, so the 3-year PFS with neoadjuvant, if you see the hazard ratio, there's a 37% difference. But if you see the hazard ratio 0.21 in ADAURA trial and 0.12 for CNS. And as Chandrakant said, that I am also tempted to give beyond 3 years because I definitely feel that osimertinib will help. And I think that because of this huge difference, and that's why NCCN, in spite of OS data not being mature, have still incorporated in guidelines. While neoadjuvant has still not been incorporated, I think they are also waiting for OS data to mature there. But Vijay, your point is absolutely right. Dono mein OS data mature nahi hai. I agree with you on that point.
Dr. Amish, जिस दिन NCCN में आएगा, उस दिन विजय आपको याद रखेगा. Okay, thank you everyone, and thanks for patiently.
Thank you.
So Dr. Hemendra Mode, so he is the chairperson. So Dr. Hemendra, any comments on early lung cancer?
Yeah, I think it was beautifully covered. The restricted role, only if it is medically inoperable, then I think the role of SBRT would have stepped in. Otherwise, yes, perfectly done.
Right. Thank you so much. So now we move.
Sir, one comment.
Yeah. So thank you, chairpersons.
Sir,
Thank you, Dr. Sunil,
So,
Dr. Prakash, Dr. Sushant, Dr. Sandeep, and Dr. Devdulla. So there is a change in a schedule. So Dr. Vivek Agarwala, the next one, the Vivek Agarwala has some emergency, so he wants to present first.
So with the slight change, we've now proceed towards the topic extending life for the journey ahead, dabrafenib plus tamitinib in BRAF mutated adjuvant melanoma, being presented by Dr. Vivek Agarwal, medical oncologist, on the virtual platform.
Yeah,
I request you to...
Yeah, very good afternoon to all of you. I hope the slides are visible and I am well heard. And first of all, I would want to thank the organizers, Gancham sir, for allowing this small change. And thanks again to Novartis also for giving me this opportunity. So I would be speaking upon the adjuvant melanoma setting, a slight, change from the thoracic session, and talk about the role of dabrafenib and trametinib combination in BRAF mutated melanomas as adjuvant therapy. So the slides have been provided by Novartis, and this is an approved indication in India. So we will go ahead with the detection and diagnosis of melanomas and the importance of BRAF testing, some surgical considerations, systemic therapy options, then the evidence for Rafinlar Mexel, that is dabrafenib, trametinib, the side effect profile and its management, and potential long-term outcomes. So this describes a very typical patient that we might be getting in our clinic, 51-year-old middle-aged female, presenting suddenly with a suspicious lesion on her lower limbs, and the lesion is pigmented, slowly growing, changing in character and surface since last 6 months, and then this patient is worried, goes to a surgeon and gets an excision done. And the excision biopsy now shows that it is a malignant melanoma, breast flows thickness of around 2 to 3 millimeters, Clark's level 4, absent ulceration with a mitotic rate of 3 per millimeter square, and a margin of around 0.7 millimeter and 2 millimeter to the nearest invasive disease. Now, a molecular testing that we all know needs to be done in an adjuvant setting is BRAF testing, and this patient was BRAF V600K mutation positive, and the T stage is diagnosed as 3A. So we all know, this is not the complete treatment, because this patient qualifies for lymph nodal dissection based on her Clark's level and breast flows thickness, and obviously they have to go for a complete excision biopsy. Now, these surgical considerations are really important when we look into how to take a biopsy, and an elliptical excision biopsy in primary closure is the ideal method for skin biopsy, because this ensures a good complete excision with a relatively safe margin without transection of the tumor, boundaries, without the transection of tumor base. Now, there are other methods that are there used by several surgeons, which are not really the ideal. For example, the deep shave excision and punch excision method. So, saucerization and punch excision, they are more commonly associated with positive margins. A deep shave excision, it aims to completely remove the lesions both peripherally and in depth, but again it leads to transection of the tumor base, which has an inaccurate assessment of tumor depth for prognostication and treatment planning. So this is not recommended, and what is recommended is the elliptical excision and primary closure. Also, partial punch biopsies are being done, but again it upgrades T staging around 18% of cases, so it is inappropriate. Incisional biopsy may be done for very large tumors where it can provide you a good biopsy without providing an excision. and should be done for large lesions only. And superficial shave biopsy again leads to transection. So this is something that we need to discuss with our surgeons, or is that whenever they get such a suspicion lesion which they suspect melanoma, then they should go for an excision, elliptical excision biopsy with primary closure. Now, talking about the BRAF testing, so we all know that BRAF positivity in melanomas is a poor prognostic factor. And if BRAF positive tumors, they are oncogenic drivers, and they are present in nearly 40 to 50% of patients with melanoma. And if BRAF positive patients have a much lower survival as compared to BRAF wild type, and their relapse rate is high, with almost 44% patients go on to relapse without treatment if they are BRAF positive. So definitely BRAF is approved and very commonly done biomarker for melanomas, and we need to do it. Talking about excision, so obviously a complete resection surgery has to be done with a wide local excision where at least a 10 millimeter margin is aimed, and more so there are surgeons who aim for a 2 centimeter margin also. And a sentinel lymph node biopsy is something that needs to be done. This is very important because many of the surgeons think that if an excision biopsy has already been done or a wide local excision is being done, then a sentinel node biopsy cannot be done. But this is not the case, and sentinel lymph node biopsy needs to be done to whatever lymph nodes we can see which are draining the site, whether they are involved or not. So obviously in this case a sentinel lymph node biopsy was done which showed that 1 out of the 2 right inguinal lymph nodes were positive. Post-operatively, because it was end stage, a PET CT scan was done and an MRI brain imaging was done, which did not show any metastasis. So the final stage is stage 3B, node positive melanoma is an ideal case for adjuvant therapy. Now, in node positive stage 3 melanomas, we have currently 3 treatment options. Obviously, if they are BRAF positive, the best treatment option is Refinlar plus Mexel. And irrespective of BRAF, we also have option of treating them with nivolumab and pembrolizumab. Of course, if there are metastatic disease which are resected, then nivolumab also remains as a very important choice, which is different from Refinlar, Mexel and pembrolizumab, because they are only approved in stage 3. But stage 4 melanomas resected, nivolumab is the treatment which is recommended. So going ahead with BRAF V600E and K mutations. So we all know the BRAF mutations causes the activation of the MAP kinase pathway, and this constitutive activation leads to further development of melanoma and tumor progression. Now, if you only block the BRAF, then MEK is the escape pathway by which this constitutional activation will go on, and that is the reason why we all know that we must block both BRAF as well as MEK in order to have a sustained blockade of this MAP kinase pathway. So talking about the evidence for Refinlar Mexel, straight ahead going with the Combi-Ad study. So this study was published in NEJM in 2020, and it included stage 3A resected melanomas or stage 3B or 3C cutaneous melanomas with BRAF V600E as well as K mutations. All the patients needed to have a complete resection with complete lymphadenectomy, and within 3 months before randomization, they had to have good PS and no prior anti-cancer systemic therapy or radiotherapy. The primary endpoint of this study was recurrence-free survival, and the secondary endpoints were overall survival, metastasis-free, distant metastasis-free survival, and safety, as well as the failure for first treatment. And patients were all randomized 1:1 to the combination of Refinlar plus Mexel versus placebo, and the treatment with Refinlar Mexel was to be continued for 12 months. The median duration of follow-up in this updated analysis was 60 months for the Refinlar Mexel arm and the 58 months for placebo arm. So this is the primary analysis after nearly 5 years of follow-up, which showed that 58% of the patients in Refinlar Mexel arm were relapse-free as against 39%. So there was a 19% stupendous improvement in recurrence-free survival in patients of Refinlar-Mexel with a hazard of 0.47, which was a consistent benefit seen across all patients and disease characteristics. The patients at 5 years, nearly 52% of the patients were relapse-free, whereas this was 36% in patients of which were on the placebo arm. If you look at the different stages of disease, we can see that whether the disease was stage 3A, B, C or D, the benefit was consistent in all the stages with a hazard around 0.5, with even improved hazard of 0.38 in stage 3D. So the post hoc analysis showed that the benefit was consistent across all stages. If you look at the overall survival data, so at 3 years, the overall survival was improved by 11%, 86% versus 77%. And this did not meet the pre-specified statistical significance. And the further data is required for more OS data is required to be more matured now to know what is the exact OS benefit. But the preliminary results do show that there is a good 11% benefit, although it did not reach significance level. What we see is that the benefit of Refinlar-Mexel was throughout the adjuvant treatment journey, and in the first year there were only 5% patients who had relapsed, and by 5th year there were 65% of patients who were alive and distant metastasis free with this treatment. Now talking about the adverse events, so what we can see clearly from this data is that the grade 3 side effects were all 5% or less, and the most common grade 3 side effects were pyrexia and fatigue, which were due to dabrafenib, and rest all the side effects were mostly grade 2 or grade 1, and fever and pyrexia were only the most common adverse events. Apart from that, there were mild nausea, headache, chills, diarrhea, vomiting, arthralgia. So most of the side effects was grade 1 and grade 2, and grade 3 side effects were 5% or less, and the discontinuation rate due to adverse events was around 26%, which was quite acceptable, and patients most patients were able to complete the scheduled 12 months of Refinlar-Mexel at the intended daily dose. If we talk about the side effect profile, what we see that at beginning 50% of the patients were having pyrexia, but as the time went on and patients continued to take the medicines, what we saw after 3 months is that only 8% of the patients were having pyrexia, and rest of the patients the pyrexia had resolved. And of course, dose reductions and interruptions peaked during the first 2 months, after which these dose interruptions and reductions decreased substantially as the treatment continued. Talking about management of the side effects and the dose, so obviously for better tolerability, you need to take the doses on time with a 12-hour interval between the 2 doses of dabrafenib. So dabrafenib comes as 75 milligram tablet, and you need to take 2 tablets twice daily in empty stomach, either 2 hours after a meal or 1 hour before. And if you are missing a dose, then you should not take the next dose, the missed dose within 6 hours of the next dose. Similar with Mexel, so it is given as a 2 milligram once daily dose, and if you are missing a dose, you should not take the dose within 12 hours of the second dose. And regarding Mexel, one important point is that it needs to be stored at a cold temperature of 2 degrees to 8 degrees centigrade, away from light and moisture, whereas dabrafenib doesn't have any storage requirements. Talking about pyrexia, so obviously when there is fever, you need to hold dabrafenib, and you can continue with Mexel at the same dose. You manage the fever with antipyretics like ibuprofen or paracetamol, evaluate and treat infection if it is there clinically, and then you restart Refinlar at the same dose. Now, if there is a recurrent fever, then obviously you can reduce the dose and then continue the treatment with appropriate antipyretic prophylaxis. And with this, you are able to manage fever in almost nearly 80% of the patients, and you don't have to withhold the drug permanently. So with this, I would conclude by saying that the Rafinlar plus Mexel combination, dabrafenib trametinib combination significantly improved the relapse-free survival for adjuvant treatment in melanomas. This is for BRAF V600E or 600K positive stage 3 melanomas. The benefit was consistent across all subgroups. The clinical benefit of this combination was, there, and it was regardless of the primary tumor ulceration was present or not, or what was the number of lymph nodes involved. If you look at the key results from the 5-year follow-up of the CombiAD data, what we see is that 52% of the patients were alive without relapse in the combination arm, as against only 36% with placebo. And the percent of patients who were alive without distant metastasis was 65% with this combination, as against only 54% with placebo. There was an acceptable side effect profile with this combination of Rafinlar plus Mexel as adjuvant therapy, with grade 1 and grade 2 pyrexia and fatigue being the most common adverse events, which were quite manageable. So with this, I thank you all again for patient listening, and I thank the organizers and Novartis once again for giving me this opportunity. Thank you.
Thank you, Dr. Vivek Agarwal. We now proceed towards the vibrant debate, the next session, which I'm sure many of us would be waiting for. The topic of the debate is exon 21 metastatic non-small cell lung cancer. Should it be treated differently? In favor, Dr. Kripa Shankar would join, and against it, Dr. Vijay Patil would join us virtually. And at the end of the hot debate, we'll have expert comment from Dr. Amish Vora, who would again be available virtually. So, Dr. Kripa Shankar, can I please request?
I'm already here. Do you have it? Kirish.
So we start?
Yeah, I'm just waiting for the slide deck to be shared.
Sure.
Once that's done, I think we're good to go. Is it? Yeah.
It was for the short. Slides. Sorry,
No, that's
it's
all right.
taking a little bit more long.
Anyway, I think before we have the time to slide the share deck, I think, a very good afternoon to everyone. And at the outset, I'm going to take this opportunity to congratulate the organizers and also thank them for the opportunity. So I think we have quite an interesting debate up for today, which is on exon 21 mutated non-small cell lung cancer, especially a late phase R, and should it be treated differently? And I'm up against my good friend Dr. Vijay. So I think he's joining us virtually. I'm sure at the end of the debate, even he would agree that he would definitely want to treat his patients differently, but for the sake of the debate, he's got to put up a brave face. So Vijay, if you're hearing that, that's for you. Yeah.
So we start.
I'm just waiting for the slide deck.
Slides are not ready yet?
I'm not able to view it on my screen though. this laptop?
There's the pointer, I think. How does it change?
No. It's not up for display on this laptop, so that's what I was wondering.
This laptop, okay, it's not connected. Directly on the screen, maybe, if it helps.
Okay. All right. So it would have been actually far more easier for me to do it because it's on the screen, not on this side, so that's why. Is there any way you could do it? No. All right, fine. That's fine. No problem. So I think that's the context, and I've already said the context for this, and I'm sure Vijay is watching. So Vijay, I'm sure you'd agree that not all mutations are actually equal. All right. So there's a look at the EGFR mutation epidemiology, and we know that the most common mutations happen from exon 18 to 21. And even as I'm sure all of us would agree that we don't end up treating all of them the same way. For example, exon 20 insertions, we know we don't use our conventional TKIs, they don't work. And likewise, when we talk about the atypical mutations like exon 21 L861Q, we know again that we don't treat them with the conventional TKIs because they don't work as well. So I think that's very key for us to understand that each of these mutations are very specific as far as a specific subtype of mutation is concerned as well. So I think we're going to focus on the key debate for today because we know that the most commonest mutations happen in either exon 19 and exon 21, which is around 45% and 40% respectively. So, we're looking at exon 21, which is the hotly contested topic for today's debate. So, to Vijay again, don't try and do this. There's no one size fits all. You really have to look at finding the perfect fit for each mutation. So let me take you to a little bit of the basics. So this is how, the particular mutations actually happen. So when we talk about an exon 19 mutation, we know it's only a deletion mutation, whereas exon 21 L858R is actually a substitution mutation or a point mutation that happens at exon 21. And thereby, you can see that I've put it up, the ATP binding sites of these EGFR TKIs are different, which is why there is an inherent resistance to EGFR TKIs as far as exon 21 L858R is concerned, and probably another reason as to why it doesn't work as well. So it's a question of going back to the basics. And again, this is interesting data as well, which tells us that the exon 21 L858R is much more commoner in the Asian population as opposed to in the Western or the European population. And again, if you look at this slide as well, look at the biochemical properties and look at the the Vmax or the enzymatic catalytic activity of these particular TKIs. And well, what you can see clearly is that exon 21 mutations, they seem to be much more susceptible to the first generation EGFR TKIs as opposed to an exon 21 L858R. And that's the reason why we're having this debate in the first place. So, Vijay, you better keep that in mind before we move on. So again, we already have this. When you have somebody with an EGFR exon 21, L861Q, we know we already treat them differently. We don't use our conventional TKIs. We don't end up using just Geftinib. We know that the data here for afatinib is much more stronger. So we tend to use afatinib in those atypical mutations. So I'm sorry, Vijay, but you may not have a choice. So again, this is across the board data that we've seen from all trials up until now, where the response to TKIs who have an exon 19 deletion is far much more better. The magnitude of benefit is higher as well, as opposed to patients who have an L858 or exon 21 mutation. So that's there, and that's the proof of the pudding. But that's probably my reaction when you say, it's all FDA approved, and you really don't have to use different TKIs. So it's a big joke to me. And and this is something, proof of concept, where I maybe you're not a huge believer in Chinese data, but I guess this is Asian data as well, Vijay. So there are trials that have looked at increasing the dose of these TKIs as well, and this is icotinib, a molecule which is not available to us but is approved in China, and they've looked at doubling on the dose of icotinib, and that has actually shown an improved PFS and overall response rate, especially in L858R mutation. So let me get back to the crux of the issue. Why is it that we're getting to see poorer outcomes with exon 21 L858R mutation? And the key reason being that obviously the presence of co-mutations. It's around to the tune of around 70% with an exon 21 mutation as opposed to only 40% with an exon 19. And that's and as you can see here that the curves are absolutely splitting wide apart when you have a concomitant mutation or a co-mutation as we would call it. So I know it's a very groovy mutation. So Let's change. All right. So, when we talk about concomitant mutations, it's not just about a P53 mutation alone, because as I've just shown you here, there are a host of other mutations that can happen concurrently. And this happens in about 70% of the patients who have an exon 21 mutation as opposed to an exon 19 mutation. And also another reason as to why you don't get to see as much of a magnitude of benefit in patients who have an exon 21 mutation. So let's look at the most commonest co-mutation that happens, which is the P53 mutation. And that's a marker of resistance to these EGFR TKIs. So how do you actually look at overcoming the resistance? One way of doing that is by looking at adding a VEGF inhibitor. And remember, Vijay, we're not going to be debating on what the best ideal treatment option should be, whether it should be chemo plus TKIs or IO or your VEGF plus TKIs. We're only going to debate on whether it should be treated differently, yes or no. So this is just proof of a concept. That's a theory. So, and interestingly, this was a subgroup analysis from the relay data, which looked at patients particularly who had a P53 mutation, and the magnitude of benefit was higher in those patients if you used ramucirumab along with erlotinib. So I'm not here pushing for any particular drug, but then the rationale seems to be interesting because you're looking at adding a VEGF inhibition, and that seems to be really providing a benefit, even in exon 21 L858R, and there you have your hypothesis to be confirmed. So what are the other reasons? So again, if you look at the TMB or the tumor mutational burden, that also seemed to be higher in patients who had an exon 21 mutation as opposed to an exon 19 deletion. So across the board, look at first generation TKIs, second generation TKIs, and third generation TKIs. None of them have gone beyond 14 months. So I think that's where, I'm sure Vijay, probably your expression is changing and that's how you're looking at it now. But Vijay, let me tell you, it's the best PFS that we have for exon 21 is only 14 months up until now. And this is the most recent data that we have on ANAS, which is aumolertinib, yet another Chinese molecule. But interestingly, look at the look at the PFS, very impressive, 20 versus 10 months. But Vijay, there's more. I'm not done yet. So if you look at the efficacy across subgroups, look at it. Exon 21 mutations don't seem to benefit as much. And this is very recent data, again, Chinese data, phase 3 randomized evidence as well. Yet another data, furmonertinib, again, yet another Chinese molecule, again, no magnitude of benefit in exon 21 mutations. So I'm not done yet. So this is interestingly the hypothesis behind why, adding a VEGF inhibition could actually look at improving your outcomes, because there is a lot of crosstalk between the VEGF and the EGFR pathways, which happens via the HIF1 or the hypoxemia inducible factor 1 alpha. And remember that we have drugs now that we can use to target the HIF alpha, which are like belzutifan, which is an oral HIF1 alpha inhibitor. So look at it, this is one data where you have consistent results in both exon 19 as well as in 21, and the magnitude of benefit seems to be the same. So, I know that's probably your reaction now, Vijay. But look at the summary of studies, all of them looking at even combining VEGF inhibition with third generation TKIs, and thereby going to show that there is an unmet need, and we would look at needing to address that.
Another 30 seconds.
Sure, sir. I'm done. Last slide. So and another key reason here is that if you start off with a third generation EGFR TKI, it's somebody who's got an exon 21 mutation, and then you move on. So the resistance patterns are much more different. You don't get to see that many T790M mutations actually happening. So, and again, thereby leading on to a shortened survival as well. So yet another nail in the coffin. So, I know you're going to stick to saying that, okay, but the guidelines and recommendations don't ask us to treat it differently. But let's just look beyond it and say, this is my last slide to you, Vijay. What would you do if you had all these scenarios? Would you use the same drug for all these scenarios? I don't think so. And that's where I believe that this is an idea whose time has come, and the time is now. And this is from Victor Hugo, a French poet. With that, I'm going to conclude and say thank you all and hand it over back to Vijay. Vijay, all the best.
Thank you, Kripa. So now it's Vijay's turn. So Vijay, you want to speak or you want to play the recorded one? Recorded one? Please.
तुमको दिक्कत नहीं है पेट पर लगवाने के लिए
recorded one.
conflict I have is that heavy bias towards the regimen.
Kancham is not playing there.
Now, the only conflict I have is that I have heavy bias towards the regimen which was devised in Ghana. That is my assumptions while I'm putting this debate is that we are talking about exon 21 deletion and with respect to all lines of treatment, mostly first line, second line, third line, and with respect to whatever agents. Issue is what you can see.
बुखार तो है ही नहीं महीने अंदर उनके भूख कहाँ जा रही है
Good afternoon. First of all, apologies I couldn't be there physically. Shankar has made it his points very clear about why exon 20 mutation should be treated differently. I'll put my point of view in the upcoming slides. Now, the only conflict I have is that I have heavy bias towards the regimen which was devised that is with carboplatin, and views would be influenced by it. Now, my assumptions while I'm putting this debate is that we are talking about the exon 21 deletion, and with respect to all lines of treatment, most of the first line, second line, third line, and with respect to whatever agents you're going to use. So what is the issue? The issue is what you can see it here, that in quite a few studies, especially in the FLORA studies, consistently what has been shown is that the patient with exon 21 behave not so well when you see it with as opposed to exon 19. So whether patient with exon 21 seems to be a poor prognostic marker with respect to exon 19, it definitely seems to be. The question is whether changing the treatment is going to help or not. So the debate is not about whether exon 21 behaves badly. It seems that it behaves badly. The debate is whether changing the treatment or having a different kind of treatment can overcome this prognostic factors. Now the issue is, but when you look at these assumptions that exon 21 does bad, it's most of the time not supported statistically by the interaction testing, which means that there's a differential impact of the drugs in, and how do you know that? You do something called the interaction test. So for example, in some, for some drug, as let's take in FLORA study, the hazard ratio for osimertinib for exon 19 is 0.6.7, while that
Amish, so I don't know, so since Bijay's talk was actually a recorded one. Amish, if you are there, please chip in for an expert comment.
Ghanshyam, you want me to do it live?
Hello.
Yeah, Amish, please.
Yeah, hi. Sorry, I couldn't hear Vijay's last few slides. So I will, whatever I have heard, and I have just 2 minutes. So first of all, congratulations, Ghanshyam, for such an amazing, wonderful virtual platform, which is going to be reality. Now, I have exactly the same questions when we look at exon 19 versus exon 21. Can we ask Mr. Dr. Chaurasia to mute, please? Uh, so, I think the same questions come in my mind also. One, yes, consistently they have shown that exon 21 develops resistance faster to the current existing drugs. And how do we do it differently? So yes, Kripa Shankar is right that we need something more than what we have right now. At the same time, Vijay Patil is also right that whatever we have right now seems to be working well. So for example, in relay trial, addition of ramucirumab added from 8 months to 15 months, even in L858R also, though it was not as good as 20 months with exon 19, but still it was better. I had personally had a chat with Dr. Vanita Narona also about Jeftinib plus chemotherapy versus Jeftinib. And she said that in our subset analysis, we didn't find much of a difference. Both of them did well. So expectation wise, we want something more in L858R for them to do better. But till the time we have a phase 3 data, I think the current way we are treating seems to be the best possible way we have. You know, this reminds me of corollary of BRCA positive versus HRR positive, Kripa Shankar. We all know that BRCA positive 1 and 2 do better compared to PARP inhibitor as compared to only HRR without them. But right now, for both of them, we have the same drug. But yes, I agree with both of them. I agree with Kripa Shankar. We need to look at them differently. And I agree with Vijay Patil also that right now, this is the best options what we have. And I think chemo plus TKI seems to be working quite well in L858R. Though TKI alone is not a bad option in these patients. I personally like to add VEGF inhibitor in L858R because that is the best PFS so far shown by any other combination. Thank you so much, Dr. Ghanshyam, for giving me this opportunity. Over back to organizers.
Thank you, Amish. Thank you, Kripa. Thank you, Vijay. So before we move to the next session, so we have a rapid questions, 3 questions. So there will be an instant prize. So it can be a medico, non-medico, doesn't matter. So we have choices. But somebody will raise hands. So please, first question, please. So these are prepared by Dr. Ajay. The first question is, what was the dose of nivolumab in TMH study, which is making roaring in the whole world today? Head and neck cancer presented in this ASCO. 20 milligram flat dose every 2 weeks, 20 milligram flat dose every 3 weeks, 40 milligram flat dose every 2 weeks, 40 milligram flat dose once every 3 weeks. From the left hand side. Yes, Lalmohan? 20 milligram every? Anyone else from the middle one? Subhashish?
1 mg per kg, 3 mg per kg. Oh.
So he is right, 20 milligram every 3 weeks. The first prize? So Suhashish from Merck. So he has another immunotherapy, that is avelumab. So go to the next question. So we have to name the trial. So there are randomization, so you can see this belongs to a prostate cancer. So there are background noises. You see the arms. So tell us the name of the trial in between. So anyone on the middle row, backbenchers. Tell the name of the trial. Ganesh. No? Bhavesh? Stampede trial. So Bhavesh, give a big clap. So coming to the third question. So keynote 426, very famous. I think Kripa and Bhavesh must be giving on a regular basis. So pembrolizumab plus, you have to name the TKI. It was compared against sunitinib. So anybody? I know, Kripa Shankar. Yes, tell me. Right, axitinib. Sorry, Kripa. Thank you so much. So I move to the next session. Dr. Romila, please.
The next session is Emerging Evidence of Immunomodulators in Management of Non-Small Cell Lung Cancer. Can I please request Dr. Bakulesh Kamar, Head Radiation Department. Please come. Thank you.
Good afternoon, everybody. Okay. Good afternoon, everybody. At the outset, I would like to thank organizer and Dr. Biswas in particular for inviting me to grace this occasion and share my thoughts on emerging evidence of immunomodulators in management of NSCLC. Working? Oh, okay, so immunomodulators are generally described or defined as substances that stimulate or suppress the immune system and may help body fight cancer, infection or other diseases. Immunomodulators for lung cancer approved in India include Keytruda, Nivolumab, Tecentriq, Immunzi, and Mycidex-C. First four are checkpoint inhibitors. Two of them are anti-PD-1 antibody. Next two are anti-PD-L1 antibody. While Mycidex-C is a TLR2 agonist with a capacity to modulate checkpoint. Cancer is essentially, from an immune perspective, a disease where cell-mediated immunity is evaded. And there is a constant tug of war between immune mechanism to fight cancer or cancer-like cells, mutated cells, and cancer-promoting mechanisms. And as per immune mechanism, cancer can be defined, or immune status can be defined as a status of elimination, where each new cancer cell is eliminated and we don't get a cancer, which typically happens in all healthy individuals. Or cancer is dormant, where the immune system and the cancer promoting agents are in a balance and is equilibrium, and cancer starts progressing as soon as cancer mediated immune evasion overcomes immunity. And then, unlike other diseases in cancer, it is mainly a cell mediated disease, and there is a anti-tumor immunity provided by cells and immune suppression provided by cells. For elimination of a cancer cell need to be killed, and for killing of a cancer cell has to be detected by CD8 cells, and once it is detected by activated CD8 cells, it gets killed and cancer cell is destroyed. For killing of a cancer cell within the cancer, there are so many cells. I mean, CTL is responsible for killing of a cancer cells, and there are so many cells and cell-mediated event which works on it to suppress it. Essentially, all those factors can be divided into positive signal and a negative signal. So positive signal tries to kill a cancer cell, negative signals try to evade the cancer cell from killing. If you want to change this cancer progression to cancer removal or escape to elimination, you need two signals to be controlled. And if you don't do two signal control, then you can't eliminate cancer or control cancer. So you need to control negative signal and you need to provide or activate positive signal. And this is what the approved drugs do. Checkpoint inhibitors try to control negative signal and activate positive signal, which was pre-existing. Mycidex-C while trying to control negative signal, it also provides a de novo positive signal. And important of this is in understanding what are the stages and how it works. A small tumor or an immune desert tumor where there is no pre-existing checkpoint inhibitors don't work, while in a large advanced tumor, checkpoint inhibitors will work, while product like mycelium C, which provides negative and positive signal, will work across the tumor. When you look at a data generated for checkpoint inhibitors, it clearly shows that it works on both the arms. Generally, we believe that it works only on immunosuppression, but it also provides positive signal in terms of tumor mutation burden or mismatch repair efficiency or neoantigen. When you provide checkpoint inhibitors, there's a CD8 cells proliferation. This CD8 cells proliferate, also express PD1 and also express CD28, and these are all necessary for killing of the cancer cells. Any one of these absent, cancer cell cannot be killed. And these cells need to be infiltrate the tumor. If they don't infiltrate the tumor, you don't have a response or a survival benefit. Generally, we believe chemotherapy is immunosuppressive, but in reality, chemotherapy also provides support to the immunotherapy. All conventional chemotherapy which are used for non-small cell lung cancer treatment reduces the negative signal by reducing immunosuppression, while gemcitabine also provides positive signal. And from escape to elimination, if we want to control the tumor, we need to control negative signal, provide positive signal in terms of infiltration of CD8 cells, and chemotherapy works as an immunomodulator. Now we come to the mycelium, which is originally Indian product. Mycelium, like checkpoint inhibitor, also increases CD8 cells. It also increases infiltrating CD8 cells, and on the top of it, it also provides a positive signal which is different, which is desmocollin 3. It increases CD8 cells infiltrating tumor, expressing desmocollin 3, but it also decreases PD1 and it also decreases FOXP3, which are immunosuppressive. FOXP3 is not affected by checkpoint inhibitors. And this is a data of a trial which was conducted under the IND approved by US FDA. It was a controlled trial, and there was both arms were identical, but it led to increased response rate by 10%, and you see complete response only in the treatment arm which received mycelium. And it led to improvement in median survival of 9.5 weeks compared to chemotherapy alone. And this advantage was significant when it comes to the squamous cell carcinoma. This was achieved without any addition of the side effects. Only side effect which is seen is local injection site reaction. If it happens if it is not given properly, or when there is a significant accumulation of desmocollin 3 positive immune cells at the site of injections. So to prevent it, first is a proper injection site, second is rotate the site of injections so that they are not in the proximity of each other, and if it happens, delay the subsequent administration because it has achieved the significant immune activation, and when you repeat, you start with a diluted dose. In conclusion, it says that mycelium when added to the chemotherapy improves survival, hazard ratio 0.64, PFS 0.43, and benefit in squamous cell is maximum with HR ratio of 0.4. And this is achieved without any significant side effect. So mechanistically, it controls negative signal in form of Treg or FOXP3 or PD1. It provides positive signal by expansion of desmocollin 3 expressing CD8 cells, which infiltrate the tumors and improves outcome. And when you compare the squamous NSCLC first line data with all immunomodulator, it stands out significantly better. If you look at a Pembro data with chemotherapy, without chemotherapy, hazard ratio is significantly higher with mycelic compared to the other immunomodulator. And I will now take you to mycelic as a monotherapy in a non-small cell lung cancer. This is a case of a 65-year-old man who had ECOG2 and diagnosed to have poorly differentiated squamous cell carcinoma. He was, this is a lung lesion and a liver lesion, and he also had a lesion in the adrenaline. He was put on a nab-paclitaxel with carboplatin, and he developed severe neuropathy. So he was discontinued, and subsequently he was put on a mycelic 0.1 ml intradermal every week for 10 weeks, followed by 0.1 ml intradermal every month. And to everybody's surprise, this patient had a complete remission. 8 months later, CT scan, if you look at it, there is no evidence of disease either in liver, lung, or adrenal. And performance status from 2 became 0. And he's maintaining that status till today, which is 30 months from the start of the treatment. And if you look at his histopathology, this patient is a PD-L1 negative and desmocollin 3 positive. And if you look at his immune phenotype is belonging to immune desert. And if you know, in the immune desert phenotype of cancer, checkpoint inhibitors are not indicated. So, its summary, it was well tolerated, it improved performance, it provided complete durable response. And if you look at a PD-L1 expression where checkpoint inhibitors are approved and indicated as a first-line therapy, majority of the lung cancer do not express PD-L1. Even if you look at it overall, 60% plus will not have a PD-L1 expression. And subgroup analysis also suggests that PD-L1 is absent in significantly large number of patients with non-small cell lung cancer. And this is a new algorithm based on immune phenotype, whether you are PD-L1 positive, PD-L1 negative, and the tumor has infiltrating immune cells, or tumor does not have any infiltrating immune cells, or infiltrating immune cells are only at the margin and not invading the tumor. So this is a new classification. And if you look between the two, immune profiling, those who are immune inflamed, they have an anti-tumor T-cell immunity, tumor antigenicity, T-cell priming, activation, trafficking, and infiltration of T-cells. They recognize, T-cells recognize the immune cells, but they are immunosuppressed and can't kill the cancer cells, and their checkpoint inhibitors work. If you look at immune desert, there's hardly any immune cells present. They have a capacity to kill the cells, but they are absent and they don't express any checkpoint inhibitors. So this is the final slide where you look at it. If you divide them into inflamed, excluded, desert, and if you want to achieve best result, according to new classification algorithm, you start using checkpoint inhibitors when you have a PD-L1 positive, irrespective of the immune status, but when it is negative, you don't use it and start to treat them with conventional therapy. When PD-L1 is less than 50%, you start combining with chemotherapy for additional immune benefit. Mycelic plus chemotherapy can be used across, and mycelic is likely to give better results in immune desert type of tumor compared to immune inflamed type of tumor. So in summary, checkpoint inhibitors can be used single monotherapy if PD-L1 is more than 50%. If it is 1 to 49%, it needs to be combined with chemotherapy. Mycelic in all cases with chemotherapy, maybe it can be used as a monotherapy in a situation where there is a PD-L1 absent, desmocollin 3 present, and patient has poor performance status. Squamous NSCLC, DSC3 positive is likely to be immune inflamed or desert type, and the mycelic works best. Thank you.
Thank you, sir. So, to some extent, I have been involved with Dr. Bakulesh. So we say that a PDL1 negative but desmoglein 3 positive, so this may be a better candidates for the mycidex C. So in other sense, we talk about mycidex C as a immunotherapy, right? But if desmocolin 3 is a receptor, then these drugs more of targeted therapy rather than an immunotherapy. So what is your take on that?
As science evolves and our knowledge evolves, things change. Mycidex C is essentially an immunomodulator. So in that form, it is immunomodulator. But as we learned more, we did more lab work, more animal studies, more human studies, we realized that for a cancer, it's an immunomodulator for a cancer, it preferentially kills desmocolin 3 expressing cells. And from that perspective, if you want to relabel it, you can relabel it as a therapeutic cancer vaccine. Okay? But there's the other side of the story. Desmocolin 3, when it is absent and when you treat with any effective therapy, there is a chemotherapy, targeted therapy or a radiotherapy, those cancer cells transiently express desmocolin 3, and this happens even when the cells do not die with that therapy. So it's a subtherapeutic dose, cells will express desmocolin 3 and will become amenable to killing by desmocolin 3 targeting immunotherapy.
Thank you, sir. Thank you so much. Yeah, over to Ramila.
Thank you, sir. We quickly next take you to the next virtual session being presented by Dr. Vidya Vedlore, pathologist. The topic is application of comprehensive genomic profiling in cancer management, 4-base care experience, a single center experience.
Thank you so much to Dr. Ghanshyam sir and the other organizers here. And I will quickly start my presentation. Should I start or is it being presented? I will start, right?
I think so. Yeah, she starts, right? Yeah. Yes, ma'am. Dr. Vidya, I think you are muted. Please unmute yourself. Yeah.
Oh, yes.
Yeah.
Yes.
Now you are.
So, my screen is visible, right?
Yes, it is.
So 4-base care is a young company. We are into cancer research as well as diagnostics. Started in the year 2018. And from 2018 till 2020, we worked primarily in cancer research, collaborating with some of the India's premier institutes like AIMS, TMH and all. And our vision was to develop a India-specific or a population-specific cancer gene panel, because as we started learning more and more about cancer, we realized that the geographic diversity and the ethnic variation has a significant role in the response to therapy in different biomarker-driven therapies. So that was the goal behind it. And this is the journey through our research. And the outcome of the research is one of the first products. It is the comprehensive cancer gene panel. We call this as India's first population-specific cancer gene panel, the target indigene that constitutes 1,200 genes. So this was developed, validated as per the NABL and CAP requirements in our laboratory, and it is 1,200 plus genes. And since it is developed in-house, we are able to provide it at a very highly cost-effective pricing as compared to FDA-approved methodologies. Next slide. I'm moving, so not moving. What's happening? Yeah. So I'll move quickly. So as I mentioned to you earlier, beyond just the target indigen, we also looked into those patients who cannot afford to go for 1,200 genes, and also those clinical conditions where other prognostic markers may not be required, where we have a again, sorry. So can you hear me? I think I got muted again. I'm sorry. Yeah. So this target first is a smallest 53 gene panel where we have almost all the genes are associated with therapy. We do not have any prognostic biomarkers. Then we slowly increased the gene list and made it to 190, and based on the patient's affordability, complexity of the disease, we have a different range of NGS panels that we have developed, validated in-house, and we offer to the patients through the doctors. Why it is not moving? Yeah. So a little bit of a background about why we developed the population-specific cancer gene panel. As we know, let's say cancer varies across different population in terms of its incident rate and the rarity for different cancers. And if you look at Asia, it constitutes nearly 50% of the global burden. On the other hand, if you look at the databases and the clinical trials and the genomic contribution that has come from Asia, Asia contributes very minor proportion, about 4% of the total clinical data that is available today in terms of genomic data that is helping to understand the cancer as a molecular disease, which can help in precision oncology. So that was the basis, and this is the outcome as I mentioned before. And this target absolute plus basically is another test where what we are essentially trying to do here is certain patients would have crossed all the lines of therapy and would have reached a end of the road, but the ECOG score would be good. And in those scenarios, when we want to look at the molecular basis of the disease to understand the complex biology and the network of interactions, sometimes it is always better to go back to the basics and look at crosstalks between the pathways. And that is where the evidence-based model which is being developed for a cancer cell is being used. We collaborate with Cellworks and we provide the advanced analysis on an exome data for the patient. I'll now quickly move on. This slide just gives us an idea about the journey where we started off, not just in technology, but also how we started using DNA-based technology as it moved, starting from the development or the discovery of Sanger sequencing all the way to where we are today. Of course, this this is not quite an old one, but today we are farther more here in terms of 2022 right now. So what I am trying to say here essentially is somewhere between 2003 to 2005, NGS started getting adopted in many laboratories, and 2009-10, it became part of some of the NCCN guidelines for lung cancer management using small targeted hotspot panels. And today we are here using comprehensive genomic panel and whole exome sequencing to look at cancer genomes and cancer exomes to understand how the disease behaves and how it can help in the better management of the patient. So this is another roadmap to show where we stand in the year 2022 and what will be the future in terms of understanding the tumor biology. Since recently, Illumina has launched another instrument where the cost of sequencing has come down very significantly. This enables many laboratories to, adopt this technology and do much more of these tests in order to provide cost-effective and highly sensitive testing for cancer patients. So this is a quick slide which we all know. Basically, although all cancers, all colon cancers might be having the same histopathology, underlying molecular alterations would vary between individuals. Therefore, one group of a hotspot panel or a small multigene panel may not be sufficient. One has to look beyond the small panels in order to address the genetic heterogeneity that is present in this disease. And this concept holds good across cancers. And we have multiple ways of using the primary material, particularly when we are using beyond tissue. We have blood-based, that is plasma cell-free DNA-based, and urine also has been tested and tried, but it is not well validated to reach the clinic. This is what is the scope of comprehensive genomic profiling. This slide essentially describes the possible genomic alterations that one can decipher using comprehensive genomic profiling, both on the DNA variants as well as on the RNA variants, and then you have the genomic signatures, which cannot be done by single gene testing. It has to be done on a large panel, molecular tumor mutation burden and the microsatellite instability. What are the major advantages? It saves tissue, it saves time, and it is highly cost effective. And at the same time, it provides information on the tumor heterogeneity. So this is another comparative slide which gives us an idea about how NGS could outperform single gene tests in terms of what kind of information that you can gather about the cancer. So I quickly move on to, because this is a thorax session, I will just give you the, this is what the method which was adopted in the year 2008 when 2008 to 2009 when EGFR testing came into routine clinical practice in India, where IHC by ALK and ROS1, then reflex testing by FISH was advised. And then we also had EGFR being done by Sanger sequencing, or if patient is affordable, they would do a real-time PCR. Then we got ddPCR for monitoring. And today, most of the lung cancer patients are being advised to go with a targeted gene panel to understand the molecular makeup. So this is a comprehensive slide that talks about what kind of heterogeneity we see in non-small cell lung cancer. This is from one of the studies. At the end of the study, I have what we have seen in terms of heterogeneity. I will be showing that from 4-Base Care's experience. This is a few studies where it talks about how comprehensive genomic profiling adds value for matched biomarker-driven therapy selection. It's one of the meta-analysis where we see a significant change in PFS between the matched therapy versus the conventional therapy group. And this is another study again, which talks about how precision oncology can be applied using CGP, and it has seen a significant change in PFS. There is another study. This is a very large study on non-small cell lung cancer, where out of 1,000 plus patients, 700 plus patients had actionable alterations. And there they saw a very significant change in terms of outcome, treatment outcome between matched therapy versus not matched therapy. A few case studies, we all know about how EGFR could, when EGFR-based therapy is given, one of the classical mechanisms is T790M, then you have meta-amplification. And this is another study. Here is where we have the role of CGP that comes in. This was a lung cancer, adenocarcinoma. However, when they started off with chemotherapy, which is the standard line because it was EGFR negative, patient was not showing response. And hence, they suggested to go with molecular profiling. And we found a underlying molecular driver, which is a EWSR1 fusion. So sometimes we get this kind of surprises. What remains as an underlying molecular driver is not the same as we always intend to see. And another example here where we all know meta-amplification is one of the mechanisms of resistance. Sometimes you get a co-amplification of EGFR also significantly as part of mechanism of resistance. Then the strategy of tailoring therapy should change. And this is another example where always we don't see classical drivers. We might see co-mutations in the neighboring exons of the kinase domain. This is in exon 20, this is in exon 19. Together are mutated in this patient at the first place, and the mechanism of resistance varies actually. And here is another example where we see very rare mutation coexisting with the primary driver mutation. And in that case, again, the efficacy may not be the same as we would expect with the primary driver mutation. This is a syndromic presentation of non-small cell lung cancer. It was a incidental finding. Patient's blood sample was also tested along with the tissue sample. And there was some remote family history, but it never had any kind of a classical picture of syndromic presentation. However, the patient had a heterozygous mutation in MUT-YH. This is an autosomal recessive mode of inheritance. However, we often started seeing this in some families where there's a group of cancers existing. Some autosomal recessive genes seems to be having, following this path of heterozygous nature. At the same time, some underlying biology and its impact seems to be there, which is yet to be discovered. And this is a young child, 11-year-old child with non-small cell lung cancer. We found some rare mutations in PALB2 and ERCC4, indirectly literature suggesting predisposition to lung cancer. And this is another rare case of a non-small cell lung cancer on disease progression after gefitinib and erlotinib. And what we found out was a very rare TERT gene fusion. So, how do we go about when we see such molecular alterations? Literature gives some evidence that there is a possibility of combination of immune checkpoint inhibitors with personalized immunotherapy for such patients, but not in lung cancer. So therefore, it remains in clinical trial mode. So this is just to summarize 4BaseCare's experience in the last couple of years, I would say. On the left-hand side, we put up the presentation of about 324 patients so far. Most of the patients metastatic after they have crossed multiple lines of therapy. Their ECOG status is good, and hence the clinician wants to see what best they can do. And we looked into our data. This is our statistics. EGFR being 37%, it agrees very well with what we have seen in the past in Indian studies, North, East, South, and West. South being the highest in terms of its representation. And when it comes to the other alterations also, again, I see that we are in par with what has been reported in literature. Now, the interesting part is what different types of copy number gains we know in general in literature in lung cancer. We see a significant number of genes being amplified as part of mechanism of resistance or during disease progression, where there is a role for potential targeted therapy options. So this is something I just wanted to bring it to all of your attention. There is this again suggests that there is a lot more to learn about this disease and its heterogeneity, and definitely there is much more. There is much more to do in terms of understanding the evolving nature of this disease and many more possible targeted therapy options that can be addressed to this heterogeneous disease. On this last table, so far based on what we have experienced in terms of molecular testing, we find that this list of genes which I have put up here on the table are the most commonly mutated genes which are potentially pathogenic. So these genes often had shown pathogenic alterations in non-small cell lung cancer. And when you go by what is available as therapy options based on these genes, looking at other cancers, we see that there is a role for PARP, IDH, ATRX, HTSC, FGFR, CDK, and TP53 based immune modulation and immune checkpoint inhibitors. So with this, I would just have one last slide just to show the impact of tumor mutation burden when it is calculated using exome data. So this is a pancreatic adenosquamous carcinoma detected very early, and then it had a very high tumor mutation burden, and however it did not have high MSI, and there was one MSH2 mutation which was again a variant of uncertain significance, and this patient was treated with pembrolizumab based on the TMB score. There seems to be a significant response in this patient over a period of 1 year, and following that the patient was again advised for a proton therapy. And these are the few images that show that there has been a significant disease reduction. So take home message, NGS remains one of the high throughput technologies which can be used in the clinic for understanding cancer genomes, and comprehensive genomic profiling provides options across all cancers, and it can replace a single gene assay for multiple reasons in terms of reducing cost and saving the precious tissue as well as the time. With this, I would like to stop here. Thank you for all your attention, and I will be happy to take questions.
Any questions for Dr. Vidya? So I believe there is none. So Dr. Vidya, we really thank you for throwing light on this important aspect of comprehensive genomic profiling. I would request Dr. Kripa Shankar to kindly come on the stage to present our next topic, that is Siramza's clinical evidence in second-line non-small cell lung cancer.
So a very good afternoon again, and I'm back. So this time I'm going to be talking on the sponsored symposium, which is an Eli Lilly sponsored symposium on the data for ramucirumab plus docetaxel in the second-line non-small cell lung carcinoma. I think it's a PDF. You don't have a PPT? Okay, thanks. Okay. So those are my disclaimers, and I've been contracted by Eli Lilly for this talk. So I'm just going to briefly take you through a clinical case presentation. This is a 59-year-old male who's very symptomatic and has been diagnosed to have stage 4 metastatic non-small cell lung carcinoma. And the primary is around 4 centimeters, multiple mediastinal lymph nodes, and bone metastasis. So he was treated initially with pemetrexed and cisplatin. And remember that this was probably in the pre-immunotherapy era, because right now you'd probably want to do IO plus chemotherapy, or just IO and IO as well. But so this was probably in the prior era. And after 12 weeks, this patient had progressive disease. So what you would probably call him as an early progressor. And he was completely wild type, did not have any driver mutation, and the PD-L1 expression was less than 50%. He had a PS, which was worsening, performance status was worsening as well at 12 weeks. And he's an electrician, married, he's a current smoker, and he was very motivated as far as, taking treatment was concerned. So, well, how do you look at defining this subgroup, which is somebody with an aggressive disease? So you look at looking at this particular subset of interest, because let's say if you're treating around 100 patients with non-small cell lung carcinoma, be it both adeno and squamous cell carcinoma, around 15 to 20% would actually fall into this subgroup of rapid progressors, which is about 1 in 6 patients. So, and that's probably an unmet need, because we know that those patients then don't tend to do as well. They have a very poor prognosis. So what can you do to actually improve on their prognosis? And that's where probably this VEGF inhibition comes into its own. So, this is the data that I'm just going to be discussing about today, which is the REVEL data, which is looking at a combination of ramucirumab with docetaxel as opposed to a standard of care. alone. So if you look at it across the group, and particularly this was only a post hoc analysis or an exploratory subgroup analysis looking at these two subsets, and only in the patients who had rapid progression, you can see here that there was an improvement in the survival of absolute improvement of more than 3 months, 9 versus 6 months to be exact. So I think, this is something that I've already spoken about. So what percentage of your patients in practice with metastatic non-small lung carcinoma have an aggressive course of disease? Meaning how many of them have rapid progression? I can probably bring in Dr. Bhavesh and probably asking Dr. Romila as well. In your practice, just choose one out of that. Okay, you're going with option B. All right, Bhavesh? Option A. All right, fine. So I think both of you are absolutely right in that sense. But the ballpark figures here around 17% to be exact. Between 15 to 20% is actually how you would look at putting it. So 1 and 6. So let's just have a brief look at understanding the mechanism of ramucirumab and how it's probably slightly different from the other VEGF inhibitors. So we know we've all used a lot of bevacizumab, which is also another drug which targets the VEGF. But the difference is that in the mechanism of action, bevacizumab we know acts only on the ligand. It blocks the VEGF ligand A, whereas ramucirumab has an activity, the mechanism of action is slightly different. It acts at the receptor level and binds and blocks the VEGF receptor 2, thereby blocking the binding of VEGF A, C and D, whereas with bevacizumab it's only VEGF A, the ligand, whereas here we're talking about blocking the receptor. And we know that you need a ligand to activate any receptor. So that's how it goes. So this was the study design. This was a large phase 3 randomized RCT. And you're looking at both histologies together, which was again another interesting thing about this study, because we conventionally have had this belief that you don't use VEGF inhibitors in patients who have squamous cell carcinoma. But let me tell you that this trial included around 1/4 of patients or 25% of patients who had a squamous cell histology as well. Given that we've always known that the risk of bleeding is probably higher in that subset of patients, and that's why it becomes interesting. I'll run you through the data on that as well. So this was the key exclusion criteria. So if you had a major blood vessel involvement or uncontrolled hypertension, GI perforation or fistula, or any arterial thromboembolic event or grease hemoptysis, majority of them were bleeding manifestations. So those patients ideally were excluded from the trial. And and again, if you look at the response rates, as far as the best response for all these patients were concerned, here we're talking about a clinical benefit rate, because you're looking at, including patients who had a stable disease as well. You're not talking only about ORR. So around 60% to 65% had actually responded, or at least had a clinical benefit rate, including stable disease. So, and this is something that, I just put up on as a questionnaire, and option A would probably be the right option, as well as option B as well. So we had around 15 to 20% who actually qualify as rapid progressors, meaning they could progress rapidly on treatment within 3 months. So, that's probably, like I said, an unmet need, and you look at identifying what the best way forward is for that subset. So, this was the baseline characteristics, and they were pretty evenly matched as far as the placebo plus docetaxel, and both the arms with the ramucirumab and docetaxel as well. And an equal proportion of patients had a prior taxane, bevacizumab. And interestingly enough, there were a few patients who had actually been on prior VEGF inhibition as well with bevacizumab. And we know we have proof of principle from colon cancer, where ramucirumab is actually approved post-progression on bevacizumab as well. So I know that's probably what makes this more interesting. And this is the data that I was showing you earlier, that the absolute improvement in survival was more than 3 months in this clinically unmet need. So you're talking about a relative risk reduction of 34%. So that's probably very interesting and probably very impressive data in this subset. So if you look at it, when you compare it with the overall intention to treat population versus the rapid progressors or patients who had progressed within the first 3 months, we know that this was strikingly more impressive data. And like I said earlier, this was only an exploratory subgroup analysis, a post hoc analysis, but nevertheless very impressive data, because you're talking about an improvement in overall survival to the tune of more than 3 months. So this was again in the overall intention to treat population. So this was also consistent, albeit the hazard ratios were slightly higher as opposed to patients who had progressed rapidly. But nevertheless, the primary endpoint of the study was met, and that's why it's a positive trial. So, this is again to show that, it did improve on the median overall survival by around 57%. So that is why we talk about the 9 versus 6 months coming in. So especially in patients who have rapidly progressive disease. And when you look at the PFS, yeah, that was also definitely in the favor of the ramucirumab arm. It was around 3.5 versus 1.5 months in the rapid progressor subgroup, and also in the overall intention to treat population as well. You had an absolute benefit of close to 1.5 months, which is 4.5 versus 3 months. And if even going by the response rates, that was doubled as well, especially in the rapidly progressors. It was 20 versus 10%. It was doubled with ramucirumab plus docetaxel, especially in patients who progressed rapidly within 3 months. And so looking at the adverse effect profile, this is probably consistent with what we have seen with ramucirumab from the earlier data as well. And let's look at only the grade 3-4 adverse events, because that's what we are actually worried about in practice. We're not worried about all grade adverse events. Grade 1, we know we could easily manage them. So again, when you look at the comparison between both the arms, myelosuppression only marginally higher, 16 versus 10%, 50 versus 40%. And again, even if when you talk about hypertension, grade 3 and 4, we're only around 6%, which is less than 10%, and probably, and that's another reason why I believe that this drug is probably better tolerated as well, even in the second line setting. And again, when you look at the adverse event profile in the rapid progressors as well, look at the grade 3 adverse events. And especially in the rapid progressor subgroups, it was 73 versus 71, so nothing much to choose from there. And leading to dose adjustment and discontinuation also, if you look at grade 3 adverse events, only around 5% had actually, less than 5% had to discontinue the drug because of a treatment emergent adverse event. So what then are the additional adverse events that you would probably want to look at or factor in? Like I said earlier, all these bleeding manifestations or related complications, something which you need to look at. It could be epistaxis, GI hemorrhage or pulmonary hemorrhage, and then hypertension, proteinuria, and renal failure as well. So I think, like I mentioned earlier, if you talk about treatment discontinuation rates, especially grade 3-4, it was less than 5%. And to summarize again, this was a patient who qualifies to be a rapid progressor, progressed within 3 months of treatment, and all the driver mutations were negative, and a PD-L1 of less than 50%. And probably, this is probably an ideal sort of a patient in your practice where you would want to look at using VEGF inhibition, especially ramucirumab with docetaxel in this setting, where it's already approved as well. It's both an FDA approved and a DCGI approved option as well. So interestingly, the dose, and this is something where even I have a bit of a query, because this is one of those indications where it is used as 10 milligram per kilogram. Whereas if you look at all the other approved indications, it's only 8 milligram per kilogram. And here you have the, it's given once in 3 weeks. Whereas if you look at the relay data, it's given once in 2 weeks. So, you have a bit of contrast there and conflicting studies. But then again, I can tell you that all the, the preclinical work that was done here looked at this specific dose finding study in non-small cell lung cancer, which is why this dose was chosen particularly for the REVEL study, which is in the second line setting. So again, dose modifications, if you had infusion related reaction, you would have to reduce the infusion rate by 50% for grade 1 and 2. Grade 3 or 4, you'll have to look at permanently discontinuing it. Hypertension also, if it can't be controlled with antihypertensive therapy, that becomes a criteria for you to discontinue therapy. And if you have nephrotic range proteinuria or more than 3 grams per 24 hours, then you're looking at discontinuing the drug. Anything less than 2 grams, or if it's only nephritic range proteinuria, then you could still come down on the dosing and use it again. And again, just like we've seen with all the VEGF inhibitors, you will have to look at holding the drug prior to surgery. With bevacizumab, you'll have to hold it for at least 6 weeks prior to surgery, or if you go with the product insert, it's at least 4 weeks. So, with that, I'm just going to conclude by saying that, this is definitely one of those valid options, especially if you're looking at the rapid progressor subset, which qualifies for around 15 to 20% of your patients with metastatic non-small cell lung cancer. And histology should no longer be a hindrance. You can use it even in patients who have a squamous cell histology. Around 25% of patients in this trial had a squamous histology. And the only major contraindications would be somebody who's got an active bleeding risk. So with that, I'm going to conclude and say thank you all for your patient listening. I'll be happy to take any questions if there are any.
Thanks, Dr. Kripa. So I had an experience of 2 such patients. So, and one during COVID, so ultimately this patient died. So they are fitted into a rapid progressors. But that's 15% of subset patient actually, to my practice, they don't respond to anything, though that was a clinical trial. And these patients are so symptomatic, I don't understand how they are able to go into a clinical trial situation. So two patients, one male and another young lady, they did not have even they could not complete the free cycles of Syringa even.
Correct. So I think, this trial did not look at including only that subset of patients, sir. They only did a subgroup analysis looking at that particular subset of patients. But nevertheless, even in the entire intention to treat population, it was statistically significant, 1.5 month improvement in survival. But in this particular subset, the magnitude of benefit was higher, 9 versus 6 months.
Because
probably
another was combination of nintedanib and
nintedanib, correct.
docetaxel. So nintedanib was so costly during COVID, it became so cheaper. So that combination is not probably.
Absolutely. So you're talking about the LOOM study, which looked at nintedanib plus docetaxel as well. But unfortunately, that's not an FDA approved option as of yet now. And again, likewise, it's not even approved by DCGI as well. But like you rightly pointed out, the concept is that you could add VEGF inhibition, especially if you have given it. And this was done in the pre-immunotherapy era. So right now, I think in the first line, all of us would be jumping on the bandwagon and saying we'd give a combination of IO plus chemotherapy, or even do IO plus IO in the first line setting itself. So this trial was designed prior to the immunotherapy era, which is why they only gave chemotherapy in the first line setting and then had to do this, sir.
Absolutely, thank you. So before we go into the next session, so some housekeeping announcement. We are keeping the tea stall closed for half an hour. This is just because we have started the high tea on the lunch side. So there are pharmaceutical companies, so they have their displays. There is a poster competition going on. Those who are interested, they can go upstairs for the high tea also and come back, because if we just vacate the room and then the whole sessions get delayed. So we'll continue the scientific the part. So somebody who wants to go for the visits or the high tea, they can go up and come down. So till then we'll close this tea counter. Otherwise, upper tea counter won't work. So over to Romila.
So it's again you, sir. For the next session, Dr. Ghanshyam Vishwas, the organizing secretary himself, will present vision for METEX 14 skipping non-small cell lung cancer. So I would like to invite you to the stage, please.
So we are talking about skipping. So don't skip the scientific meeting and don't skip the high tea also. Next slide. तुम्हें कंट्रोल करियो था ना को रंजन okay. So looking like top of the world. So NSCLC vision for MET exon 14 skipping NSCLC patients. Okay. What is this, Tushar and Ranjan? So looking at the burden of this disease, so till 2020, so it used to be the topmost in the class. Now breast cancer has taken over. So we understand that 80-85% of them are NSCLC and the majority cohort are adenocarcinomas. And in India, it almost 8% cases in males and 3% in females. And that's a big quantity, and we see that certain parts of the country have a significant amount. So if you see these slides, so we have been focusing on the right side aspect of the lung cancer, which is to be the metastatic. And with the ADURA trial, so we have started focusing in the early lung cancer where there are genomic alterations that are being seen. So we are focusing on MET. So that constitutes again a good amount. So initially, if you talk about ALK, so something into that frequency. So this is what has happened during COVID pandemic. The science never stopped. You can see around 12 approvals only in the lung cancer space that came up during the peak of COVID. So all roads leads to NGS today. So if you talk about adenocarcinoma, especially lung cancer, stage 4, so you cannot get away without an NGS, especially if your patient is a female, non-smoker, and adenocarcinoma, there is a big chance that you are going to miss a druggable mutations and you probably denying a patient for a better survival. So this is NCCN 2022, so everybody's favorite guidelines. You can see, so there is a MET exon 14. You are going to evaluate patients. So we have moved from a sequential to a cohort of mutations from 5, 9, now 12. So most of our colleagues have moved on to a 12. So and now you are picking up more of druggable mutations. So these druggable mutations, be it a EGFR, be it a ALK, or be it a MET, this often comes with a high PDL1. And that's the problem. So the PDL1 reports are with you in the next 3-4 days because it's ISC based. But NGS will take 2 weeks, 3 weeks. So don't jump into any treatment if there is a high PDL1. Just wait for the NGS report to look if there are any druggable mutations. Because if there is a high PDL1 and if you start on immune checkpoint inhibitor, so probably you have put your foot into a wrong side and these patients are going to have a stormy course. So if there are druggable mutations, put the patient on a targeted therapy followed by again a repeat mutations, and probably in a later lines you can give an IO. So no IO in the first space. So lung cancer with driver mutation, targetability and immunogenicity. On the right hand side you can see if there are targets, so then probably immunotherapy is not is the choice. On the left hand side, so when you see the other mutations, so probably you can combine them with chemotherapy and that can be a space for that. So looking at the MET, the whole story started in 1980s, understanding of the MET gene, and then the MET and the HGF are overexpressed in lung cancer. Then we understood that there can be a de novo MET amplification, and most importantly, when the patients on anti-EGFR or anti-ALK, they progressed, so these MET mutations were more seen. So this was one of the mechanism for EGFR resistance or an ALK resistance. And then came the era of MET inhibitors, and the first drug was crizotinib, and normally we have been using this drug for other indications like ALK and Roche. And now post 2015, so we have good number of drugs coming into MET inhibitors, like initially we had the Novartis capmatinib, and now we have the Merck tepotinib. So the MET exon 14, which is the most commonly reported MET mutations in the non-small cell lung cancer, and the highest frequency is seen with a sarcomatoid. So if you have a good pathologist and they have reported as a sarcomatoid, then probably you should not miss out on MET. So MET is an independent oncogenic driver event like the EGFR Al-Qadda-Rosh. So the diverse molecular alteration leads to a MET exon 14 NSCLC. So there are 150 different MET mutations that is happening. So in the splice acceptor sites, in the splice donor site, but mostly in the splice donor site around 50%. So how do you detect MET? So biopsy block, tissue block, and even you can do it on a liquid biopsy on a ddPCR. So if you see a tissue biopsy, so don't forget to include an RNA. So because most of us are doing a DNA. So if you add a RNA component isolation, so probably your yield might go up. So there can be a genetic testing like the RT-PCR and the NGS, and the molecular testing like IC and FISH. On a liquid biopsy, the circulating DNA, you can still do a ddPCR and an NGS. So these are like on a molecular screening or skipping mutations of the exon 14 can be picked up. You can at times pick up MET amplifications, though MET amplification doesn't warrant a treatment with a MET inhibitor, but this can be of a prognostic importance. So you can also do a FISH, so where MET by 7 ratio people have tried with more than 2.2 versus more than 3. So this is a real life case because many of us are doing on one of those Dr. Lal's lab. So again a sponsored coupon. So this gentleman, a 65-year smoker, so came with a bone mets lung lesion. On a biopsy came to be adenocarcinoma a few months back, 4 months back, and adenocarcinoma. And you can see, so this was my first patient where we got a MET. You can see, so MET exon 14 skipping mutation is there in this gentleman. So it took time. By that time I have started on chemotherapy, and mind it, so this was not adenocarcinoma, it was a squamous cell carcinoma. So what is MET mutations and amplifications? So these are pathways, because in a short time, so you should understand that there are downstream, you can see, so this can, so once you activate or inhibit, then probably the cell survival, proliferation and the motility can go on. So MET 14 skipping mutations on the left hand side and the amplification on the right hand side. If you see the MET exon 14, so once there is a skipping, then there is a increased MET signaling, so which results in angiogenesis. So is there a clinical relevance of a mutation versus amplification? So mutations 3% NSCLC, whereas less than 1% of MET amplification, 15% co-occurring with the MET amplification. And as I said, so this is a resistance mechanism, so that's why patient on EGFR, anti-EGFR and anti-ALK, so your yield of MET on progression is going to be more. So on progression in lung cancer, breast cancer today, even in colon cancer, we need to have a repeat molecular studies. So the baseline molecular study may not be the same. So histology-wise adenocarcinoma, it can be a sarcomatide, even in a squamous or an adenocarcinoma. These tumors are usually a high PDL1 and a lower TMB, usually elderly patients, smokers, females, and a poor survival. So what about MET and survival? So you can see if somebody has a MET amplification, then it results in a short survival. On the left hand side, if you see the MET gene copy number is less than 5 versus more than 5, more than 5 has a lesser survival. Whereas you can see a MET positive and a MET negative, again, so MET positive has a lesser survival of 21 versus 47 months. So the MET amplification, as I said, EGFR TKI resistance or ALK TKI resistance, we are going to see more of a MET amplifications and a MET mutations. So MET exon 14 NSCLC prognosis, independent prognostic of a shorter OS. On the left hand side, if you see the NSCLC as a cohort, again the wild type MET versus a mutant, so the mutant has a poorer prognosis. Whereas if in adenocarcinoma, in particular, So you can see the prognosis is even more poor. So what happened to chemotherapy in this subset of patients? Doesn't work good. Only 1 out of 4 patients are going to respond. Median survival less than 9 months. What about immunotherapy in these patients? Still the target therapy. So not even 20% of the overall response rate. So PFA is hardly 2 months. What about crizotinib, got a profile trial? So this was used as a first MET inhibitor. And you can see overall response rate around 30% and median survival just crossing a half of a year. So it means crizotinib probably was not a very good MET inhibitor. So that warranted, that made more research to find more active drugs. So for the patients or MET exon skipping, MET exon 14 skipping, so MET inhibitors significantly improve survival outcomes compared with chemotherapy. So with chemotherapy, you have less than 10 months. So almost 3 times you have a survival. So once these patients are exposed to any of the MET inhibitors, active MET inhibitors. So despite high PD-L1, as I said, so these tumors are having a high PD-L1. So despite high PD-L1, so these patients, you can see from the graph, they don't respond to IO. So don't start IO if you get a 60, 70, 80% of a PD-L1. Wait for other druggable mutations. The same case where I discussed as a MET, you can see this gentleman had a 70% tumor cells, high PD-L1. So waited for the report, and ultimately this patient was started on one of the MET inhibitors, and the patient is absolutely doing good, hardly any toxicity. So despite high PD-L1 expression, so IO provided limited benefits in OS and the PFS outcomes. And what are the different MET targeted therapies? So these 2 figures for our students. So one is the geometry we have been doing in our school days, and this is a vision. So we talk about geometry of capmatinib and we have a vision for the tepotinib of Merck. So look at the NCCN guidelines, look at the ESMO guidelines. So they are top on the list with the category 1. So you can still, there are patients who can be on crizotinib. So that day Dr. Amit was saying, so probably this can be a case. Otherwise, the more active drugs are capmatinib and tepotinib. So this is the NCCN 2022, again that's showing the same. So the classification of MET tyrosine, so in one group is a type 1AB tyrosine kinase inhibitors, the second is type 2, and the third is a allosteric inhibition, that is pivantinib. So we are focusing on type 1B, 1A, 1B, so where crizotinib, where is tepotinib and capmatinib are all 3 as a type 1 and A and B. So usually B are more potent than the type A. So on the left hand side, MET targeted therapies, the group is a tyrosine kinase inhibitors, the drugs which we talked about. The other group, so which we'll see in future, so the future is bright for MET inhibitors, so monoclonal antibodies targeting these receptors. So looking at the efficacy of these drugs, so we talk about profile 1001 crizotinib, very small very small response rate, very less survival, and no CNS penetration. So now we have 2 phase 2 trials for tepotinib, that is vision, and capmatinib geometry. So around 200 patients, we can see an improved response rate. So whereas in the vision, tepotinib was a single day daily dose of 225 milligram, 2 tablets, whereas the capmatinib, we know that this is twice a day 400 BD. And you can see almost 15 to 20% brain metastasis patients were included in this both the trials. So as compared to capmatinib trial, where they had only enrolled patient based on a tissue biopsy. So whereas in the vision trial, they have included good amount of patients with a liquid biopsy having a MET. So both cohorts, and if you see, both these patients have benefited. The one thing came out of this vision trial, that patients who are a liquid biopsy, who are positive, so probably they were doing good. So that indicates that probably we have more circulating DNAs in the peripheral blood showing that they are more aggressive tumors. So 52 versus in the tissue of survival versus 68. So the load of tumor. So brain metastases were 10% in the tissue arm, whereas it was 1.5 times in the patients who were positive on a liquid. So probably liquid positive, so we cannot conclude, but this was just essence of the study. So there were cohort A and cohort B. This was all, you could look at the inclusion criteria. So around 150 patients. So tepotinib of 225, 2 tablets daily. So treatment name were 130 odd, and previously treated was again 130. And the primary endpoint was an overall response rate, because we did not get a much response in crizotinib. So that was the reason that ORR was taken as a primary endpoint, and definitely PFS, OS, and duration of response and safety of a new drug was a secondary endpoint. So this was the final essence of vision. So overall response rate 56.8%, median duration of response 46.4 months, median PFS just more than a year, and median overall survival is crossing 2 years. So this was that overall efficacy in patients with tissue and liquid biopsy was robust and durable across therapy lines. So if you see a tepotinib, which is your type 1 reversible, capmatinib type 1 reversible, but crizotinib is a multi-target inhibitors. So we talk about brain metastasis today in EGFR, AL, and that too in a MET also. So if you see on the left hand side of the geometry trial of capmatinib, so the patients, a good number of patients were included with a symptomatic or a stable brain mets, so as in the vision. And in both the trials you can see, so both the subsets of CNS disease has a good intracranial responses and also a good duration of response in the intracranial. There was also a RANO brain metastasis analysis for vision that also shows almost 88.4% of good intracranial control, and with the intracranial PFS of almost 21 months. So safety, because it is a new drug, so one of the class effect is a peripheral edema, and second is increase in creatinine. So we have seen in one of the CDK4s like abemaciclib, so this phenomenon is also seen in MET inhibitors. So edema and creatinine, so rest, asthenia, nausea, vomiting is always there. So probably we need to, this happens initial 2 to 3 weeks, and then you need to understand how to manage this. So edema is a class effect, and you can see, and in this trial it showed that as the age at advanced stage from 65 to more than 80, so as the age at advanced stage, so edema was more seen in a more elderly patients. So creatinine again, so this happens initially in the first few weeks, and then it is a transient phenomena. You may not have to do anything on that. So the dosing and dose reductions, so 225, 2 OD. If you need to reduce the dose, then you need to have 1 tablet per day. So conclude. So has our vision for MET exon 14 become a reality? Testing for MET alterations. So we have already moved into an NGS mode by the guidelines and should be incorporated in clinical practice. Patients with MET exon 14 skipping metastatic NSCLC preferred first line therapy are tepotinib and capmatinib. So NCC and ESMO category 1. So tepotinib offers a reliable response in patients with this group with or without brain metastasis, and has an additional dosing convenience of once a daily. So MET is an actionable target for NSCLC treatment, especially adenocarcinoma, though we see in the squamous like of my patient, important for cell proliferation and survival, dysregulated through overexpression, amplification and mutation. MET amplification is implicated in acquired resistance to EGFR and also ALK. So MET exon 14 alterations are detected in 3 to 4%, will go up. So from de novo to a resistant EGFR and ALK, and is found to be mutually exclusive with the other druggable mutations. A number of MET inhibitors, as I said, there are around 150 such drugs in the research. So strategies for MET inhibition includes targeting MET signaling drugs. So patients who have a diagnosis of a lung cancer are eager to get started on therapy, but diagnosis is not complete by the introduction of the histology. So whether it be a small cell or non-small cell don't stop at adenocarcinoma, so every patient has to be subjected to an NGS. Treatment is more guided by their molecular markers. So those are required, and there's no urgency in sense that an additional few weeks of testing makes a big impact. So obviously it's an additional stressor for patients, but the potential gains after 3 weeks when you get a PDL report or at least a 12 gene report, then you know so what to choose for your patients. So the last slide, the cancer miracle isn't a cure. We are talking about a lung cancer, so where more than 80% are tobacco related. So cure is an erroneous target. Cancer prevention is better than cancer cured. In the month of November, we know that this is again a lung cancer month. So thank you, friends, ladies and gentlemen, for a patient hearing.
Thank you, Dr. Biswas. Thank you for the wonderful talk.
So the next speaker is my co-host, Dr. Romila. So she will update us with stage 3 NSCLC and extensive small cell. So these are the two diseases which were, nothing was happening for last 5 years or so. So after IO like durvalumab, so the whole scenario has changed in regards to survival. So over to you, Romila.
Slides will change with this. Thank you. So as rightly said by Dr. Biswas, there was nothing much happening in the past few decades in stage 3 non-small cell lung cancer as well extensive stage small cell cancer. First we take up, we have already discussed the burden of lung cancer in India. Why are we discussing in particular is because of the heterogeneity of the lung cancer, particularly in lung cancer, and limited survival. So management of unresectable stage 3 non-small cell cancer. So whether the disease is resectable or non-resectable, it's basically a decision of a multidisciplinary team. And the current, not current, but the prior to the immuno-oncology era, the definitive concurrent chemoradiation therapy was the standard of care for stage 3 unresectable non-small cell cancer. And the concurrent chemotherapy regimens that were used were cisplatin etoposide, cisplatin vinblastine. The commonly used are usually the paclitaxel carboplatin combination and also cisplatin and etoposide. Now, after having done the upfront concurrent chemoradiation or sequential chemotherapy followed by radiation therapy, what happens next? The patient, we are waiting in 40% of the cases, the disease progresses with locoregional metastasis, or I'm using this. No. I'm not doing anything. Done? And we expect the disease to progress with distant metastasis in 50% of cases. So it used to be a median progression-free survival of 8 to 12 months and a 5 years survival of mere 15 to 25% cases. So various trials were conducted, but none of the phase 3 trial studies of consolidating this treatment with chemotherapy or target therapy or vaccines demonstrated any beneficial PFS or OS. Again, initial in late 60s and until 90s, it was radiotherapy either and followed by sequential chemoradiation or concurrent chemoradiation or radiation therapy alone. None of the treatment approaches really benefit, actually benefited the did not benefit the overall survival. So thus it becomes important to address this, and then comes the era of immunotherapy, which is being increasingly recognized as safe and effective option. And this is the study most talked about, the Pacific trial, and basically took up patients for the immunotherapy, that is with durvalumab, with a baseline of the adult patients PS1, and the durvalumab was started 42 days post the concurrent chemoradiation completion. And the primary endpoints were the PFS and the OS, along with the secondary endpoints of the overall response rate, the duration of response, safety and tolerability, and the patient-related outcomes. So the baseline characteristics were well balanced, and good point to note is this part especially. This doesn't seem to be working. In which you can see the disease stage 3A, 3B were included almost equally, along with other stages, that's 3C. The baseline characteristics, the PD-L1 positivity with TC less than 25%, more than equal to 25%, and also unknown. So, and also, if you can see the 1/4 of the patients have received an induction chemotherapy prior to the concurrent chemoradiation. All right? So, and this is the prior concurrent chemoradiation at baseline, in which about 191 patients have received the induction chemotherapy prior receiving concurrent chemoradiation. Now, this shows the updated 5 years overall survival, in which we clearly see the separation of graft with benefit on, achieved with durvalumab of 42.9% as compared to 33.4% in the placebo arm. It is the first and only approved immuno-oncological agent to demonstrate this level of 42.9% of overall survival at 5 years. Progression-free survival also, if you can see, there is clear separation in the graph with 33.1% in case of durvalumab as compared to mere 19% in the placebo arm. So it shows a sustained and durable progression-free survival of 33.1% at 5 years. Now, durvalumab improved the time to intrathoracic progression as when compared to the placebo. And running through the safety summary, the safety was acceptable, and 5-year survival is the important endpoint achieved. And the key takeaways are the durvalumab has demonstrated a statistically significant and clinically meaningful improvement in overall survival and progression-free survival versus placebo in this specific trial. And tolerability profile of durvalumab was acceptable. Now shifting towards the extensive stage small cell lung cancer. It comprises of almost 15% of the lung cancer in total, and the median age of presentation is approximately 70 years. 50% of the cases are found to have brain metastasis either at presentation or later on. So, and they are also associated with poor outcomes. So approximately 2 in 3 patients who have, approximately 2 of 3 patients have extensive stage small cell lung cancer at diagnosis, and their life expectancy is less than an year when treated alone with the etoposide and platinum regime only. So, like we can see in 1985, cisplatin and etoposide, and then in later 90s, we introduced radiation, but nothing seemed to work as much until 2015, when the first immunotherapy used, that is nivolumab, followed by currently 2018, carboplatin and etoposide was used with atezolizumab, and then in 2019, carboplatin or cisplatin along with etoposide with durvalumab was introduced. So this current advancement is of significance in our current clinical practice, and the immuno-oncology products have actually replaced the etoposide and cisplatin or carboplatin as the standard of care in the first line extensive stage small cell lung cancer. And so most of the patients respond to the first line etoposide and platinum combination, but they typically progress within few months and the life expectancy falls short of a year. This study, Caspian, is the first, comes up with the first and only approved immuno-oncological regimen in extensive small cell lung cancer to allow up to 6 cycles of etoposide and platinum in the control arm and use of either cisplatin or carboplatin. We'll compare it with the IMP-133 that uses atezolizumab, and like important part in this immuno-oncology agent is that you don't do a PD-L1, you don't need the tumor mutation burden, so both are included. And if you can see this particular, in the durvalumab arm, that the Caspian study uses up to 6 cycles of chemotherapy, and it doesn't exclude cisplatin. We can include cisplatin and carboplatin both, and that is how it is. It allowed treatment for either cisplatin or carboplatin. That is how it has an advantage over using its counterpart in the IMP-133 study, with optional preventive cranial irradiation. And again, as we can see, 3 times more patients were alive in the durvalumab plus etoposide platinum arm as compared to the only chemotherapy arm, the etoposide and platinum. And the sustained 3-year overall survival, sustained separation in the graph has been seen. That makes it superior, not exactly superior, but then better than its counterpart. So as you can see again, 52.8% 1-year overall survival rate, 22.9% 2 years, as compared, it's almost the same with atezo, but atezo has not yet come up with the 3-year survival rate, which is 17.6% in case of durvalumab. So it has basically tripled the survival at 36 months as compared to only chemotherapy of etoposide and platinum. So at 3 years, overall survival benefit consistently favored durvalumab, as you can see in this forest graph. It's shifted, it's favoring durvalumab, and also at 2 years, the response rate, overall response rate, is better in this arm of durvalumab along with, and it has also shown a sustained improvement in progression-free survival in nearly 4 times the number of patients as compared to only chemotherapy arm. And again, this is important. This study also includes baseline brain metastatic patients, patients having baseline brain metastasis, and again, it has shown response in this scenario as well. At 24 months or 2 years, the overall safety profile, including discontinuation rates, were comparable for durvalumab with etoposide and platinum versus only chemotherapy, and it is consistent with the safety profiles of each component. And at 36 months as well, there were no new safety signals. This is the current NCCN guidelines, the preferred regime. If you can see, carboplatin and etoposide with atezo, followed by, and 4 cycles only, followed by maintenance atezo every 3 weeks in a dose of 1200. If you have to use atezo at a gap of, in maintenance, at 4 weekly interval, we increase the dose to 1680. Whereas in the durvalumab, it's the either carboplatin or cisplatin with etoposide. It is used at 3 weekly intervals when given with chemotherapy, and when after the chemotherapy, when we start maintenance, it continues at the same dose but at an interval of 28 days. So the first line durvalumab along with the chemotherapy has shown sustained improvement in overall survival when compared with a robust control arm that is reflective of a real world scenario by allowing up to 6 cycles of etoposide and platinum and the use of prophylactic cranial irradiation as compared to the results from the atezolizumab plus carboplatin etoposide study of IM Power 133. I would like to end my session with this. Thank you so much.
Thank you, Romila. That was a colorful thank you slide. What would I name you? Thank you. So now we move to a panel discussion. So this will be a treatment paradigm in metastatic CRPC. So moderator being Dr. Ashish Bakshi, and so before that, the chairpersons are Dr. Chirag Desai and Dr. Kripa Shankar.
Hi, Ghanshyam.
Hi, sir. Chirag, sir. Thank you for joining.
Pleasure, yeah, always a pleasure.
Thank you.
I'm sorry
Thank
I
you
could
so
not
much.
join physically. I will catch up in near future.
Thank you, sir. Thank you so much.
So taking over from here, I request Dr. Ashish Bakshi, I think he is also joining virtually, to start the panel discussion, inviting his panelist and then going forward. Ashish Bakshi is a dear friend and he is a medical oncologist from Mumbai. So over to Dr. Bakshi.
And we have a panelist, Dr. Tarini, Dr. Saurabh Mishra, Dr. Ranjit Kar, Dr. Iftekhar Ali, Dr. Manas Pradhan. Please come up the stage. Saurabh, Ranjit, Iftekhar. Did Dr. Manas come? No. तुम्हारा एमडी वाला कहाँ गया?
So Ghanshyam, Vineet Govind Gupta is also not joining.
So he's not.
I'm there, Ashish boss, virtually. Tarini, it's Sau here.
Yeah, hi Tarini. No, I know you are there. I was asking about Vineet Gupta. Is he there or not there?
So Tarini is here, but he has joined virtually.
Oh, Vineet Gupta.
Something, and tomorrow I'll be there physical. Yeah.
So TP
No, is Vineet Gupta there?
TP Sahu is going to be fined for that.
Done, boss.
Done.
Vineet is there, Vineet Gupta.
What about Manas Pradhan? No.
Bhai Vineet Gupta is there or not? They're asking.
Okay. So before Ashish takes over, so we had good memories down the lane of TMH, those Golden Jubilee block. So Ashish, me, and both of our spouse and kids. So we grew up together. So thank you, Ashish, for joining. So we cannot say, so we are such a good friend, so we cannot say no. So at least he has joined virtually. So what do you, Ashish, please?
Thank you, Ghanshyam. So, Ghanshyam, can you hear me?
Yeah, please. Yeah, you are still.
So, I just wanted to know whether Vineet Govind Gupta is there or not.
No, he's not there. He's not there.
So, Tarini is there, Saurabh Mishra is there, Ranjit Kar is there, and
Iftekhar Ali
Manas
is there.
Pradhan is there.
Manas has not reached. He's not there.
Achha, okay, all right. So I think I will request the other panelists to please take over the questions. I had earmarked some questions for them. So let's move on with the panel discussion. So as all of us know, there have been a lot of advances that are happening in the field of prostate cancer. And today's discussion, we are going to restrict primarily to patients who are metastatic castration resistant. But I'm going to start my case with the patient, this patient's journey, and briefly we'll just discuss about metastatic hormone sensitive also, because what you choose in metastatic hormone sensitive decides your treatment in the metastatic hormone resistant state. So to begin with the case, this gentleman was a 67-year-old gentleman. He had a family history of breast, prostate, colon and uterine cancer in his family. He was diagnosed in 2015 as carcinoma of prostate localized disease, and he was operated with a robotic prostatectomy. Post-operatively, he received adjuvant radiation, and then after that, he was observed. Subsequently, in 2020, he presented with a rising PSA. So the question was for Dr. Manas Pradhan, but then anybody can take it. How will you work up this patient at this point of time?
Sauya. Yeah, so basically there are two ways to look at it. Already I have disseminated stage 4 cancer. The only point I would like to have is whether the patient is symptomatic or not. Point number 2, I would not hesitate to do a PSMA, but I just to look at whether the visceral disease or not. I'm not going to get any other additional benefit from my PSMA because already the PSA is high. I have a documented multiple disease. I normally reserve PSMA for the early disease, or I do it when there is a oligometastatic to rule out further disease. So here you already told it's a multiple disease, but yes, just to look at the visceral disease, I might ask for a PSMA, but I would not insist on that. That's my point.
Okay, all right. So, so this patient showed bone metastasis and small retroperitoneal nodes. There were no visceral metastasis. His PSA was 51 and testosterone levels were 20 at this point of time. Now the question is that how would you treat this patient? This is relation to castration sensitive disease, so it is not a castration resistant disease at this point of time. So what would be the treatment of choice? Anybody from the panel can take, Dr. Ranjit or Dr. Iftikhar. Dr. Saurav?
Yeah, sir, I am here.
Yeah. So how would you treat this patient now?
So, sir, basically for these patients, we have a plethora of options. So if is not very symptomatic, then probably I would go for a combination of either abiraterone, either abiraterone, combine it with abiraterone or enzalutamide. If is symptomatic and fit patient, probably chemotherapy is something which I give. Then I ask the patient whether they want infinite amount of treatment or they want short duration of treatment. So all of these would help me in guiding my therapy.
Okay. So I will just keep these slides and we will move on. But any quick comment, Tarini, on the Peace 1 trial? Do you think?
I think at this point I would not practice
following?
Yeah, I would not. I am not following it. I'm interested in it because of the benefit of the largest benefit of OS. So that is what is inspiring all of us. But I'm not still very convinced of the Peace data at this point. I would like to have a longer follow-up. That toxicity also has to be taken into mind. So I'll wait for 1-2 years before I jump into and disturb the peace of the patients.
And do you routinely add docetaxel to the patients who are hormone sensitive?
I do add to the hormone sensitive patients. I add 6 cycles of the same to the patients at this point of time.
Okay, all right. So I think
but the option of abiraterone and the enzalutamide should also be discussed.
Right. So,
can you go one slide back, Ashish boss? One slide back.
1 second. That is going to be somewhat difficult. Give me a
Okay,
chance.
just move on. The other two agents, we know one more.
This one you're talking about?
No, one more back. The options. Yeah,
right.
No, one more. The options which you showed, all the options.
Acha. Okay, the options.
Yeah, the treatment options. Okay, forget.
This one, right.
Yeah. So the only thing which I wanted to say, look at the option FNG. I think people have to remember all the data looks very good. These were actually for locally advanced N0 patients. So this is something that we all have to remember of the apalutamide and the darolutamide data. These were basically hormone castration refractory first of all and N0. So this is also something I think our colleagues have to remember.
Okay, all right. So moving on to the case, now in which patient, this is for the radiation oncologist, in which patient do you consider metastasis directed radiation therapy? There is something that we have not been really routinely following, but I think there is quite a bit of convincing data coming up now. So Dr. Ranjit or Dr. Iftikhar, can you please comment on that?
Sir, first of all, the patient is PSMA positive and his PSA is more than 50 and multiple bone mets are there. We have to take the history properly, whether he is symptomatic for bone mets, number one. Number two, whether is any weight bearing site like pelvis, right humerus, left humerus, or what I mean to say femur, the weight bearing site. If there is a weight bearing site and there is a PSMA PET positive, then definitely we have to radiate that patient. Some palliative putty of 30 grade 10 fraction over 2 weeks for this painful bone metastatic site.
Okay, all right.
So Ashish sir, can I just ask the question to the radiation oncologist if you allow me?
Yes, please.
So Ranjit bhai, recently in the Astro, there was one study in which they either went for prophylactic radiotherapy to asymptomatic bony metastasis, or they waited for the bony metastasis to become symptomatic and then they went for radiotherapy. So in the patients in whom they went for preemptive prophylactic radiotherapy, there was an improvement in outcome. What do you have to say on that? So both of you, I mean.
Asymptomatic bone metastasis, but there is a weight bearing bone.
Exactly. So if
definitely we have to radiate
high risk of fracture.
Regarding metastatic directed therapy, we generally consider metastatic directed therapy in oligometastasis disease or oligoprogressive disease, where the disease is non-visceral metastasis is there or only in the extranodal sites, or there is less than 3 bony metastasis. There we can treat both the primary site and your metastatic site both. And that is, I think, that is the metastatic directed therapy we should go for.
I think with careful selection, some patients do have a role of radiation. Now, moving on, one question quickly to the anyone can take this. How do you monitor patients while on therapy? Because are there any patients that you come across who exhibit a radiographic progression despite a PSA being normal? Do you come across such patients?
Yeah, rarely, Ashish. I have come across once or twice in my last 4-5 years, and not exactly this patient, but if there is a patient who is very symptomatic and the PSA is not rising, but there's a radiological progression also, I definitely insist on a biopsy on such patients because I found them to be a small cell or neuroendocrine transformation. So this is something that I have seen, although not common, but not uncommon. And especially that rings the bell is non-PSA rising, radio progression, and patient also clinically bad.
Okay, all right. So probably some sort of a intermittent radiologic imaging should be done in patients to look for such kind of patients.
But can we not do something like that? That just do a PSA every 3 months or 4 to 6 months, whatever patient or the doctor agrees on. And if the patient is not symptomatic, if the patient is asymptomatic, PSA is not rising, why do we need a radiological evaluation?
So I think this is something of an area of controversy now, and probably we'll have to wait for more clear answers on this. But I think we will have to kind of subjectively decide. Now coming back to this patient, he was started on, he was given ADT with Zoladex and he was started on abiraterone and Visolone. However, in a short period of time, he developed recurrence with a rising PSA in April 2020. Now, so Saurav, how will you approach this patient now?
So sir, now probably this is a metastatic castrate-resistant prostate cancer. As you told previously, we put our subsequent therapies based on what he has got previously. So here probably he has got abiraterone, and if abiraterone, now we may go for either chemotherapy. So I would rather prefer docetaxel here in this setting. And also we would like to do some of these mutations like HRR and MSI for these patients if we can plan subsequent therapies, BRCA and all.
Okay, so any role of giving a trial of enzalutamide or any other hormone therapy at this point of time?
So I mean, sir, post hormonal therapy, another line of therapy you were saying. So that is exactly, this patient has not done very good on hormonal therapy rather. So I would rather go for another form of therapy. Tomorrow we do not know if we at all would be able or fit to take chemotherapy subsequently. So definitely I would sequence chemotherapy preferably compared to enzalutamide at this point of time.
Okay.
Can I ask this, can I pitch in, boss? If you have such a patient, all of us have such a patient, if the PSA is just rising very marginally, not a very fast titer, patient is asymptomatic, do we need to change?
Yes, the other panelists can they answer that question?
So basically he is not responding. He is not responding to therapy, and if at all...
He did. The point is, the patient, we have a lot of patients like who is symptomatic. The PS is rising, maybe has was to 10, was become 14, and then 16. Asymptomatic, 1 or 2 metastatic deposits. I would rather continue give a radiotherapy to the oligo progression as was told, or just observe till the patient gets symptomatic. Will docetaxel not make the patient more sick?
So I think Tarini, in this situation, one would like to look at the PSA doubling time and see whether it is a short PSA doubling time, then probably it is better to change.
Okay.
And for this patient, he was not very keen for chemotherapy at that point of time, so he was started on enzalutamide. And however, he didn't respond to enzalutamide, and PSA again increased. So I think Saurav, your point is very well taken.
Did we do ARV7 or should we do?
No, we have not done. We have not done ARV7. So, but again, the point is well taken. One should know that there is a cross resistance between enzalutamide and abiraterone. And as far as the sequencing of the ARPI is considered, studies have shown that when you give abiraterone first, outcomes are better in terms of the time to second PSA progression and drop in PSA. As against that, if you give for today's topic, at what point of time in the patient journey will you consider genetic testing?
To me?
Hello. Yeah, anyone can take. Tarini, Saurav.
I would do it at any point when the patient develops a metastatic disease. I may, if the patient has the finances, I would love to do that. Maybe use it later on, but I would like to have the report. But yes, at the point of metastasis or on progression, I would love to do HRR if not done before.
So sir, this patient already has a strong family history also, you said. So many similar to the BRCA related cancers are there in this family. So definitely at this point we would do some of these mutational analysis, BRCA and HRR, because they have therapeutic implications.
So at what time do you do the testing?
So you are setting whether it's in upfront metastasis or at the time of castrate resistance, right sir? That's what you're saying.
Correct.
So as of now, sir, since data is there in the castrate resistant setting, so therapeutically it makes sense. But if you otherwise feel what is the implication for the family if we detect a BRCA mutation, then probably in any metastatic setting we would rather do it.
Okay. So, and when you order the genetic testing, what kind of testing you order? You order only BRCA 1 or 2, or you do an extended panel, or you do a comprehensive genomic testing?
So basically, sir, we go for this extended panel because we are getting the BRCA1, BRCA2 and also the MSI also. So in that reason we do, although we know that maximum benefit is mainly for the BRCA2 subset of patient, but we still go for extended panel usually.
Oh, okay. I agree completely with that. And so the recommendation is that an extended panel other than BRCA and BRCA 1 and 2, you should look for other alterations also. Now, coming back to the core question that in which patients will you consider PARP inhibitors? There are so many alterations as we have discussed that can be noted. So which are the patients in which you will consider PARP inhibitors?
So basically, if you look at the approvals across, it is for everyone who has this. But if I look into the details of it, and with the cost of the drug so much to the patient has spent, I would look at the BRCA2 more carefully. I would look at the non-ATMs group more carefully, because the ATM was the one which did not benefit. So although if the trial has to be read as an abstract for all, but I would be hesitating to give this for ATM1, ATM, and then BRCA1 did not do as good as BRCA2, but I will probably give it for BRCA1 and 2.
Okay. Between the two drugs that are currently available to us in India, any particular preference between olaparib and rucaparib, and any particular reason for that?
If I intend to use rucaparib, it's only approved for BRCA. There is no other approval for rucaparib for other HRR. That's point number one which I wanted to make. Point number two, even on liquid biopsies, you can pick up this and you can do the give the drug rucaparib. But if you're using a HRR panel, then the drug has to be olaparib alone. That's the normal thing. Although all of us would interchange.
Okay. So, Saurav, again back to you. So, for patients who have a pathogenic alteration in BRCA 1 or 2, when do you recommend PARP inhibitor? You recommend them upfront or after failure of the first line of androgen drugs or after one line of chemotherapy?
So, sir, so if you see the data, at least it is after prior exposure with androgen receptor pathway inhibitors. And anyways, I would like to incorporate in this second line setting in such patients, because these patients are likely to respond to the PARP inhibitors because of the mutations.
Okay. And your view on combining the, say for example, abiraterone with olaparib based on the PROPEL study, what are your comments on that?
So that's definitely a lucrative option, sir, but still as of now, I'm rather not combining, I'm rather using either after progression with androgen receptor single, either olaparib, but definitely that's a good data in there.
Okay, all right. Tarini, so for those patients, many patients we see who are not able to afford really olaparib or rucaparib, do you see any role of platinum agents in these patients?
One would expect that, but there is no level 1 evidence to suggest that that would be good enough at this point for prostate cancer. But yes, I would probably err towards it, but I don't have any level 1 evidence to support it. If there is one, I am not aware of.
So if you are, so there are a good number of kind of institutional studies that have been published, but I agree with you, there is no phase 1 data. So if you have to use it, you will use it as a single agent or a combination?
I'll use carboplatin probably as a single agent. I'll go towards that. The toxicity would be little much for elderly prostate cancer relapse patient.
Okay, I agree. So coming back to this patient, again, his germline testing we had done, considering his strong family history, but unfortunately no mutations were detected. So he was given continued on 3 monthly Zoladex and monthly denosumab. Now, what is the role of HRD testing in these patients? Do you see any role of, like this germline testing is negative, so do you see any role of doing an HRD score in patients with CRPC? Any of the panelists can take this.
So sir, in this HRD score, it is not validated in prostate cancer. As of now, it's only HRR mutations. So we would still, I mean, we would do the HRR mutations rather than the score.
Right. So I think as of now, there is no consensus on actually whether you should be doing that. In the advanced prostate cancer consensus conference, almost 47% of the people voted that HRD score should be done in the patients who have DDR gene alterations. In case if the DDR gene alterations are there and HRD score is high, then probably you get more confidence in prescribing the PARP inhibitor drugs in this patient. But your point is well taken. There is really no one answer to this question. Now, is there any benefit of doing somatic genetic testing? Is it mandatory to do that, or genetic testing, germline testing is good enough?
I think so. You can. The thing is for both. So germline and somatic. The rucaparib is for somatic. I think I would go for I'd go for one after the other. If you get a somatic, you have to anyway do the germline as we do it for ovary. So anyone positive in anyone, it's good enough for me to give that drug. That's my thought thinking about it. Anything more specific which you want, I just can.
So Saurav, any difference of opinion?
So somatic testing, sir, you are saying?
Yes.
So somatic testing, that is how we go about, because that's where the data is there for patients with metastatic castrate-resistant prostate cancer. But if we detect mutations in the BRCA, then I go back to the germline testing as well.
Okay. So it's advisable that actually both germline and somatic testing should be done. You may not do it simultaneously, but in case if the germline is negative, then it is advisable to do a somatic testing. Both the tests are complementary to each other. And again, in the advanced prostate cancer conference, the recommendation was that it should be done after failure of the first line ARPI. Now, what is the role of liquid biopsy in these patients? Any quick comments on that before we move on to the next question?
I think so. We can do it to pick up the BRCA, as I told before. If you are looking at some mutations, you can just do that. I don't think there is any other role for liquid at this point apart from these two situations. I'm not really aware of looking at anything else on liquid biopsy.
So, yes. And when you are doing, so another question is that when you are doing somatic testing, do you recommend a fresh biopsy or you do it on the archival tissue? What do you practice?
I would, if given a chance, it is a very easily accessible site. I do the fresh one, but archival tissues are good enough, and they should, at the point of problem when you are having difficulty, no, you should not hesitate to do on the archival tissue.
Ashish, last 2 minutes.
Yes. So, okay, fine. I think we will move on next to the next question. So now this patient has received docetaxel. So this patient was given docetaxel prednisolone as Saurav had selected. He had some partial response to this. However, within 2 months' time, actually he progressed with the lesion in the liver. So the question to the panelist is that in this patient, if who develops liver metastasis, has an elevated PSA, would you do a liver biopsy?
I normally do it. Raised PSA, single liver, I would preferably do it. If the PSA is not rising, I'll definitely do it. So that is how I do it.
Right. So I think it is important to do a biopsy to rule out a small cell component in such patients, particularly those who are behaving in an aggressive manner. Now, coming to the last part of our discussion. Now, after failure of docetaxel, what is the treatment preference that you have? There are so many options that I have listed here. What would you prefer? You will give cabaziraxel, you will give lutetium PSMA, or you will try an alternative ARPI or try mitoxantrone. What is your preference? So, Saurabh?
So, sir, basically I go for cabazitaxel based on whatever data is there. Docetaxel re-challenge, I don't know how much benefit, so cabazitaxel.
Okay, so I think as far as choice between cabazitaxel and AR inhibitor is considered, cabazitaxel has been shown to have better outcomes in terms of progression-free and overall survival. However, what about lutetium PSMA? Anybody has any experience of this?
So we have used, sir, at our center here, and mainly for the patients who have painful metastasis in the bone, this has really worked well.
So why do you choose cabazitaxel then? Why not lutetium PSMA? That is the question.
So, sir, basically that's what I'm saying. So, toxicity profiles are different. Not all the time they are available. So, I would rather choose like that. If very symptomatic bone metastasis, lutetium.
So, Tarini, any difference of opinion?
I think I recommend the same way. I do not have access to lutetium at this point, but yes, I recommend it the same way as Saurabh told.
So, the therapy trial actually showed that the PSA reduction is better with lutetium PSMA. As you can see here, 66% response rate versus 37%, and side effects were also less. But of course, I do understand your concerns that not all patients have access to this. Similarly,
none
the
of my
overall
patients have access, so that doesn't come to my mind only.
So I think, but again, for somebody who's affording, I think this is a good option before offering them cabazitaxel because the side effects are less. So I think for this patient, we also had done tumor mutational burden. As you can see here, he had just 6 mutations per database. Microsatellite stability was, MSI was stable, PDL1 was 0. So he was not a candidate for immunotherapy, but that would be an option. So, a last question: what is the role of bipolar androgen therapy? Any quick comment on that? Anybody wants to comment on that?
It's a new emerging thing, looking at the androgen receptors, this stimulation and then the deprivation of the androgen. I don't think it is prime time yet. We would need that bigger studies to prove it. But yes, I think the concept looks good.
Okay, all right. So I think we'll conclude our panel discussion here. Several treatment options have become available for the management of metastatic castration-resistant prostate cancer, as you can see here, and as we have discussed. The choice of treatment will depend upon several factors: the age, performance status, affordability, stage of the disease, life expectancy, comorbidities, and patient preferences. So I will thank all my panelists for a very insightful discussion and conclude my panel discussion, and back to the organized meeting.
Thank you, Ashish.
Thank you so much.
Thank you, panelists. Chirag sir, any closing comments?
Yeah, so one thing I would like to say is that usually it so happens that when the patient has the CRPC, it is 4 or 5 years down the line, and at that time the archival blocks are useless. We cannot test HRR on those blocks, and at the time of CRPC, most of the patients have sclerotic bone metastasis, so it is not possible to do the biopsy. So what I usually recommend is to do the HRR mutation at the time of primary diagnosis of metastatic disease, and then I go ahead. So that's my practical suggestion, rather than hardcore database suggestion. It is practical suggestion. Otherwise, we miss on HRR mutation somatic data. So that's it. Otherwise, excellent discussion, Ashish, and thank you very much.
Thank you. Thank you so much, sir.
Thank you, sir. And now, so now we move to optimal sequencing in metastatic CRPC by our dear friend, Dr. Jogmaya Patnaik. So this session will be sponsored by Dr. Reddy's, and the next session is also by Dr. Jogmaya. So over to you, Dr. Jogmaya.
Good evening. So, starting my talk on optimal sequencing of metastatic castrate-resistant prostate cancer. So, prostate cancer is one of the most important cancers we come across in our OPD or IPD in men. And most of the patients in Indian scenario, they present with advanced and castrate-resistant prostate cancer. In like many cancers where various treatment options are available, sequencing is often very essential, and the proper sequencing may get us better results compared to using the available treatment options very haphazardly. So therefore, let us know what optimal sequencing we can do for prostate cancer patients. So this is the second leading cause of cancer-related death among men in India and world. And as we know, the standard of care for prostate cancer is basically androgen deprivation. Along with that, some chemotherapy options are there, and other targeted or anti-androgenic drugs are there, radiation, and the radiopharmaceutical treatments are also there. So most of the patients initially respond well to ADT. Either it can be done in the form of surgical or medical castration. But most of the response to hormone therapy or the ADT lasts maximum up to 2 years. Following which again the disease progresses and the patient becomes castrate resistant. So because multiple FDA approved options are available, so optimal sequencing is very essential. So what is castrate resistant prostate cancer? It means disease progression despite castrate resistant level of testosterone, that is less than 50 nanogram per ml. Patient may be symptomatic or asymptomatic with or without metastasis, and it affects like 10 to 15% of the patients within 5 years of prostate cancer diagnosis may become castrate resistant. So progressive decline of health related quality of life also occurs with patient developing castration resistant. So this is the overview of advanced prostate cancer options in advanced prostate cancer. So like first, if there is local disease, then either the patient is treated with surgery or radiation. After that, there is biochemical recurrence or biochemical PSA elevation is there. Initially the patient is castrate sensitive, then radiographic or symptomatic metastasis disease develops and the patient becomes castrate resistant. So similarly, the surgical options or the treatment options changes from surgery to hormone therapy plus other options. We add other treatment options like chemotherapy, radiation, now newer options like PARP inhibitors and immunotherapy are also available. So FDA approved, these are the FDA approved agents for metastatic castrate resistant prostate cancer that we have already described and seen from the previous panel discussion. So taxanes are present in the metastatic CRPC like docetaxel, cabazitaxel, all these are there. So that we know until 2010 only approved drug was there, docetaxel. Later on cabazitaxel, the next generation taxane has taken over, which can be used after the use of docetaxel also. And it improves the overall survival in docetaxel pre-treated metastatic CRPC, improves the quality of life, and it is also approved in lower dosage, like it's the approved dose, the toxicities are more, so even 20 milligram per meter square lower dose also can be used. But anemia, cytopenias basically are the most important side effect related to docetaxel and cabazitaxel. So when the diagnosis of a locally advanced or localized prostate cancer is done, first treatment is done with curative intention. After that, if there is no relapse, then patient is followed up. If there is relapse, either it is rising PSA or local relapse or distant metastasis, accordingly the treatment options change from watchful ratings to ADT plus other treatment options. When the patient develops distant metastasis, related treatment options also change. Similarly, when the patient is not suitable for curative intention treatment, from the starting itself, we decide whether the patient needs chemotherapy plus hormone therapy. And again, if the patient develops further metastasis or progression, then accordingly the treatment as available treatment options, it is modified. So current therapeutic landscape is in metastatic prostate cancer is like androgen blockade by abiraterone or other androgen blockade, docetaxel, or if low volume disease is there, we can give radiotherapy also. Above, along the time, the further treatment options can be added. So how do we sequence these agents? So we decide, as the previous panel discussion we also saw, patient characteristics has to be taken into account. Like the patient, whether it is symptomatic or asymptomatic, whether visceral or non-visceral disease is there, docetaxel has been used previously or not, or what kind of previous treatments has been already used. Accordingly, we'll decide. Biological markers also now we take into account, like immune checkpoint related markers and androgen receptor related markers. Now currently we do the HRR panel, MSI, CPS scoring, all these things are carrying importance nowadays. So according to recent data, how to sequence whether enzalutamide, both are anti-androgenic drugs, whether enzalutamide to be followed by abiraterone or abiraterone to be followed by enzalutamide. So a Lancet publication from 2019 has tried to sort out this issue. So they have given in group A abiraterone plus prednisolone followed by enzalutamide, and group B patients they received enzalutamide followed by abiraterone. And the objective was to determine what is the best sequence, whether to use abiraterone first or to use enzalutamide first. So the patients were randomly assigned using a random number based table, computerized randomization to group A and group B. So this is a multi-center randomized trial, crossover trial, did in 6 centers and recruited patients over 18 years older who are diagnosed as metastatic CRPC without any neuroendocrine differentiation and good performance status. And the primary endpoints were to see what is the time to PSA progression, what is the time for PSA response. PSA response meant more than 30% decline from the baseline on second line therapy, and it was analyzed by intention to treat or intention to treat in all randomly assigned patients. So as we see, the patients who were the proportion of patients without the second PSA progression when they were compared between group A and group B, group A patients fared better compared to group B with an impressive hazard ratio. So group A means abiraterone followed by enza, group B means enza followed by abiraterone. So the time to second PSA progression was longer in group A, that is 19.3 months compared to 15.2 months in the group B. Similarly, the group A patients, the PSA respond to second line therapy. That means if there is PSA hike is there, those patients who progressed, they responded to a second line therapy because crossover was allowed. So those responded to second line therapy in 36% of the patients in enzalutamide compared to 4% patients for abiraterone. So that means enzalutamide showed activity as a second line agent or second line novel androgen receptor pathway inhibitor, whereas abiraterone did not. So leading to a longer time to second PSA progression for the sequence of abiraterone followed by enzalutamide than with opposite treatment sequence. So therefore the data suggested that using a sequencing strategy of abiraterone followed by enzalutamide provides better clinical response compared to enzalutamide followed by abiraterone, because enzalutamide showed better response in the second line and better PSA control in the second line rather than abiraterone. So there are other treatment options in the third line also, like in CARD trial they have seen whether cabazitaxel versus abiraterone or enzalutamide in previously treated CRPC patients. They took patients with CRPC treated with more than 3 cycles of docetaxel and disease progression after less than 12 months on abiraterone or enzalutamide, like with or without exposure to docetaxel. So patients were treated at least with 2 lines of treatment. At least one should be a docetaxel. After that enzalutamide or abiraterone also must have been used. So they randomized the patients into cabazitaxel 20 mg per meter square and enzalutamide or abiraterone. Primary endpoint was imaging based on imaging-based PFS. Secondary endpoints were OS, PFS, PSA response, etc. So when the imaging-based PFS was seen, cabazitaxel fared better compared to the androgen receptors. In the tune of the median PFS was 8 months in Cabazi arm and 3.7 months in AR inhibitor arm. That almost 4 months difference was there. Overall survival also was improved and it remains significant by the end of 30 months. So the trial concluded that patients treated with cabazitaxel had better radiographic progression-free survival, OS and PFS compared to androgen receptor inhibitors in docetaxel or abiraterone or enzalutamide pre-treated patients. Therefore, it is important to properly choose the drug. However, those amongst asymptomatic patients or slowly progressing patients, it is not completely wrong to consider AR inhibitor switch. Similarly, the PROFOUND trial showed that olaparib versus physician's choice treatment in patients who are progressing metastatic CRPC. In that, they have used in 2 cohorts, cohort E or cohort A and B, in which patients with metastatic CRPC and progression on prior treatment, and they have used 2:1 randomization as olaparib versus physician's choice treatment and olaparib versus physician's choice treatment in both the arms, that is cohort A and cohort B. Cohort A had basically BRCA and ATM mutations, common mutations. Cohort B had other uncommon mutations. Crossover was allowed and the responses were checked. Also, progressive disease was documented by independent review committee also. So the PROFOUND value have shown that the radiographic PFS and primary endpoints were in cohort A, that is BRCA 1, 2 or ATM mutation patients. The olaparib, the arm which has received olaparib fared better compared to the control arm, which received the other physician based choice. And OS also was initially improved, but almost later on similar. It was better in the olaparib arm compared to the control arm. So other trials who assess the combinational treatment strategies were like PROPEL trial. This is a first line olaparib plus abiraterone versus placebo plus abiraterone in metastatic CRPC. Patient in which in one arm they tried olaparib plus abiraterone, in another arm they tried placebo plus abiraterone in a multiply treated patients. And in this cohort, no prior abiraterone and no screening HRR mutation was required. These were multiply, these patients did not receive any prior treatment for CRPC, but ADT was allowed and docetaxel was allowed. No prior abiraterone or no screening for HRR mutation was allowed for this. So this was an unselected population. In this unselected population, they wanted to see whether olaparib plus abiraterone was better compared to abiraterone alone. So these were the characteristics of the patient. The median age were almost similar, and there were almost 25% symptomatic patients were there. Median PSA was 17 in these patients, and HRR mutant patients were almost 27%. Non-HRR patients were 70%. They assessed the HRR status by NGS, and HRR's mutation status was established for almost 97% patients. So they found that the outcome was the median radiographic progression-free survival in the olaparib plus abiraterone arm was 24 months compared to 16 months in the placebo arm, and in the 12 months and 24 months this benefit was sustained, and it was same, this benefit was sustained also in the radiographic PFS assessment by the independent committee also. The other efficacy outcomes were like the hazard ratio for overall survival was also better for olaparib and abiraterone, and PFS2 was also better, though both the arms they did not reach by the time of data cutoff, the PFS2. The hazard ratio was still better compared to olaparib and abiraterone. The overall response also improved by 10% with addition of olaparib compared to abiraterone alone. So the investigators concluded that addition of olaparib to the first line abiraterone significantly prolonged the radiographic PFS compared to abiraterone alone, and safety profile also consistent with the previously established profile of the drugs. And they concluded that olaparib and abiraterone is the first combination regimen to demonstrate clinical benefit of a hormonal agent and another DNA repair or target DNA repair targeting agent, PARP inhibitor. So another trial, that is magnitude trial, we showed a first line in niraparib and abiraterone acetate in the metastatic CRPC, and they also had HRR positive and HRR negative subgroup, and niraparib and abiraterone were compared with placebo in both the arms. So when they found the niraparib plus abiraterone and prednisolone, just I am going through the outcomes. The median PFS was better compared to the placebo, and the investigator assessment PFS also was better compared to the placebo plus abiraterone alone. In BRCA mutated patients, if we see all HRR mutated patients, in those also, like HRR or BRCA mutated patients, the niraparib and abiraterone combination was better compared to abiraterone alone. So they concluded that this was a multicenter phase 3 trial, and they concluded that the risk of progression or death was significantly reduced in BRCA mutated subgroup, and by 27% of the HRR positive metastatic CRPC patients by addition of niraparib to abiraterone. And it also improved the other clinical outcomes versus placebo: time to cytotoxic chemotherapy use, time to symptomatic progression, time to PSA progression, and overall response rate also improved by adding niraparib to the abiraterone. So no new safety signals were identified. So concluding my session, that though we have lot of new drugs in our basket, in a resource constrained country like India, our main treatment options still remain chemotherapy, androgen deprivation therapy, local therapies like radiotherapy in CRPC patients. So hormone therapy is the cornerstone. We should use it wisely and sequence it wisely. Thank you.
Thank you for the wonderful session, Dr. Jogmaya. I request you to continue with the next session, Achieving Longer Survival in Metastatic Urothelial Cancers.
So good evening. Thank you for bearing with me. So now coming to the after prostate cancer, continuing with the urothelial cancer discussion. How to achieve longer survival in metastatic urothelial cancers. So urothelial cancer actually is not a very common cancer like bladder cancer or the urethral cancer or upper urinary tract cancer. These are not very common cancers. We see these patients very rarely in our clinical practice. Therefore, much data is actually not available for these patients. But over the years, for last couple of years, there has been a lot of evolution in the treatment of this rare cancers, which usually present to very advanced stage to us. And treatment options also were very limited. So as we see in this picture, 1970s we discovered cisplatin which proved its efficacy in bladder cancer patients. Then MVAC came, then other platinum-based chemotherapies came, then gemcitabine, and then from 2017, immunotherapy entered in all our lives, actually. Immunotherapy entered in our lives. So, and later on the use expanded to almost all cancers, some or other way. So, now we have some options for cisplatin ineligible patients also. Previously, cisplatin ineligible patient, we give carboplatin, just gemcitabine and carboplatin, there is no other option. So in 2021, avelumab was approved as a monotherapy for first-line maintenance in adult patients with locally advanced or metastatic urothelial cancers. And those who were not eligible for platinum-based chemotherapy also, this drug could be used in those group of patients. So these are the options for showing any survival benefit among the patients of urothelial cancer. Either we give first line chemotherapy, which gives us a PFS benefit of 3 to 5 months, followed by we give maintenance avelumab, which gives us another 24 months. Total it gives us 30 months. Second option, we give first line chemotherapy, which again gives us around 6 to 8 months. Then we give another immunotherapy like pembrolizumab, which gives us 10 months. So total 16 to 18 months. Then we combine platinum-based chemotherapy with an immune checkpoint inhibitor like atezolizumab or pembrolizumab. This gives us around 16 to 17 months of estimated median OS. Then we give, other option is we give first line immunotherapy as a monotherapy in cisplatin ineligible patients, and this is for PD-L1 positive tumors only. This gives us around 12 to 18 months. Then we give only immunotherapy, no chemotherapy, nothing. That gives us around 15 months. So if we see in this category, best results are seen when a disease is controlled by platinum-based chemotherapy and we give maintenance avelumab, as has been shown in Javelin Bladder 100 trial. So, and there is a lot of attrition of patients when we see from first line chemotherapy to next second line chemotherapy or immunotherapy, there is a lot of attrition. So patient attrition between the first line therapy and later line therapy also has been almost around 50 to 60% in real world data. So in our clinical practice, when we see the patient, because urothelial malignancies may have some retroperitoneal lymph nodes or some infiltrations also. So because of that, some issues may be there, and these patients are mainly elderly also. So for this, some patients may be cisplatin eligible. Cisplatin is the drug which is the drug of platinum of choice in urothelial malignancies. But around 50 to 60% patients may not be eligible for cisplatin. Around 30 to 50% patients eligible will be around 50 to 70% and ineligible will be around 30 to 50% patients. So in those patients, around 75% cisplatin ineligible patients are offered carboplatin based treatment like gemcitabine, carboplatin, etc. Depending on the performance status, renal function, the neuropathy status like prior history of diabetes and other neuropathies may hamper or prevent us from giving cisplatin. So accordingly, the treatment patterns, what are the treatment patterns of cisplatin eligible patients? Almost ineligible patients, almost 94% of the patients will be given carboplatin. This is the real world data which was collected from various centers, and almost 60 genitourinary medical oncologists collaborated and gave their data for a consensus definition of cisplatin ineligibility. So they concluded that in any patients with metastatic urothelial cancers meeting one of these criteria should be concluded that they are cisplatin ineligible, like ECOG PS more than 3, creatinine clearance less than 30, peripheral neuropathy more than grade 2, NIHA heart failure class more than 3, ECOG PS2 and creatinine clearance less than 30 ml per minute. So if these criteria are there, at least 5 criteria are met, then the patient is cisplatin ineligible. So what they do with these patients, what they did with these patients actually, 94% of the patients preferred, 94% of the respondents or the medical or the oncologists, they preferred to give carboplatin followed by avelumab for cisplatin ineligible patients. 6% of respondents preferred carboplatin plus pembrolizumab. 28% of the respondents checked PD-L1 status, and 48% checked PD-L1 status prior to using atezolizumab. So these were the options given to those ineligible patients. So now, according to the recent data, the cisplatin eligible patients, their treatment options preferred regimen are gemcitabine cisplatin followed by avelumab maintenance, or the other option is dose dense MVAC with growth factor support followed by avelumab maintenance. If the patient is cisplatin ineligible, then carboplatin based treatment can be done and given avelumab maintenance therapy. Otherwise, atezolizumab and pembrolizumab can be given to cisplatin ineligible patients who express PD-L1. So in cisplatin eligible or carboplatin eligible patients, how to maximize the overall survival? There are 3 types of treatment options. One is after giving cisplatin or carboplatin, what you do? Wait and watch. Like first line chemotherapy is given, then you wait and watch. If disease progression is there, then you initiate the second line treatment. Switch maintenance. You give first line chemotherapy for 4 to 6 cycles. After that, response is there. Switch to IO maintenance, then initiate the second line therapy on progression. Third one, continuation maintenance. First line chemotherapy plus IO, follow the IO maintenance, then initiate the second line therapy when the patient progresses. So these are the 3 options to maximize the overall survival benefit. We will see one by one. For wait and watch approach, first line chemotherapy, almost 50 to 80% of the patients, they achieve good disease control with platinum based chemotherapy. However, the overall survival is limited by the chemotherapy resistance. Therefore, when the disease progression occurs, we initiate the second line chemotherapy. With second line chemotherapy, the median survival again is around 14 to 15 months. So how to do the continuation maintenance? Continuation maintenance, these are the trials which was used. Like I said, first you give chemotherapy plus IO, then you continue with an IO, and then on progression initiate the second line therapy. So 3 trials have been done in this. Pembro and Atezo, Durva, all these 3 immunotherapy drugs has been used in these 3 trials. InVigor 130, Keynote 361 and Donabet trial. In this 3 trials, first line IO plus chemotherapy or IO combination was used. So, but there was no benefit, but there was no significant difference in overall survival in any of these trials. That means all these 3 trials, they did not show any benefit compared to using chemotherapy followed by IO, maintenance. They did not show any extra benefit. So they did not meet their endpoints also. So now coming to switch maintenance. Switch maintenance, as we know, 50 to 80% patients achieve disease control with platinum based chemotherapy, but still within another 1 year, many patients will progress. Therefore, we can use a maintenance strategy which will not give more toxicity to the patients and can be given as a maintenance therapy. So this is the Javelin bladder hypothesis, which hypothesized that avelumab maintenance therapy can improve the outcome in these patients who responded to first line platinum based chemotherapy. So this is the Javelin bladder trial. They took unresectable or locally advanced metastatic urothelial carcinomas with measurable disease, those who have received either 4 to 6 cycles of cisplatin gemcitabine or cisplatin or gemcitabine carboplatin. Then within 4 to 10 weeks, radiographic assessment was done. If the patient has not responded, has not progressed, then the patient was again randomized to avelumab 10 mg per kg 2 weekly or base supportive care plus base supportive care or base supportive care alone. Primary endpoint was overall survival, and the secondary endpoints was PFS, overall response rate, etc. So median age of this population was 68 years, 70% were male. Good performance status patients were almost 60%. And location of metastasis, visceral was 55%, 45% was non-visceral. First line chemotherapy agents, gemcitabine and cisplatin were used in slightly more population compared to gemcitabine and carboplatin. So what is the outcome? The progression-free survival, overall survival in the overall population was 23.8 months in the avelumab arm compared to 15 months in the supportive care arm. The hazard ratio was 0.76, and if the progression-free survival we see, it was 5.5 months in the avelumab arm compared to 2 months in the best supportive care group. Compared to the PD-L1 population, PD-L1 positive population, in that population also those who were PD-L1 positive, the avelumab group was better compared to the best supportive care group. So if we see the safety profile, 29% patients experienced immune-related adverse events, but no fatal reactions were encountered. And OS response, OS and PFS benefit of avelumab was seen irrespective of the best response to chemotherapy. That means if the patient has CR, PR or stable disease, then also there was no difference in the avelumab activity in those group of patients. So it was also seen irrespective of the duration of treatment-free interval before the maintenance, though most of the patients were recruited before 10 weeks, but irrespective of the length of the TFI, it was seen that avelumab treated patients fared better compared to best supportive care. So there was an Asian subgroup also in Javelin Bladder 100 trial, which was presented in ASCO GU in 2020. In this Asian subgroup, almost represented 21% of the overall population, and similarly they received cisplatin based or carboplatin based chemotherapy, and within 4 to 10 weeks of interval after the radiographic assessment, the avelumab maintenance was started. They was randomized best supportive care plus avelumab versus best supportive care alone. And in this group also, when we see the overall survival, if we see the avelumab group, it was almost 25 months. In best supportive care only group, it was 18 months. PD-L1 positive population also, it was better. So 47% of the patients were exposed to more than 6 months of avelumab. 28% of the patients were exposed to more than 12 months of avelumab. And 20% of the patients were exposed to more than 24 months of avelumab. So it can be given up to 2 years safely. So when they compared, almost more than 30% of the patient had received altogether more than 12 months of treatment, and the benefit was continued even beyond 24 months. So this, if we see this maintenance, first after the first line chemotherapy, the avelumab maintenance seems the best way to give better PFS and better OS to this group of patients. So what other treatment option or second line treatment options are available post this maintenance therapy? Like if we see the patients who have received post platinum or other chemotherapy, if the patient has progressed, what are the other options? So post chemotherapy, the option of immune checkpoint inhibitors like pembrolizumab, avelumab, all these options are there. If the patient has already received checkpoint inhibitor, then the other options are chemotherapy, then other NTRK fusion inhibitors like enfortumab and edrafinib are there. The other options of chemotherapy which has not been used previously are still there. So these are the drugs. I'll just keep some slides. So in patients who are cisplatin eligible, the treatment of choice or standard of care is cisplatin based chemotherapy followed by avelumab maintenance, like the switch maintenance. If the patient is cisplatin ineligible, then carboplatin based chemotherapy followed by avelumab maintenance. If the patient is completely platinum ineligible, then IO monotherapy. This gives the best results. So this slide I have discussed. So thank you. So this is a very difficult to treat malignancy, but now we have options to improve the survival in this group of patients. Thank you.
So thank you, Jogmaya, for that marathon, both the sessions. So we now come to the session 5, which is the last session of this day 1. So the first talk will be management of cancer-related anemia by Dr. Priya Priyadarshini Naik, a medical oncologist colleague from SAM Ultimate. This session is being sponsored by IMCure. So Dr. Priya.
Good evening, house. Just so today we'll be discussing regarding this iron deficiency anemia, like which is most commonly encountered in our cancer setup, but still it is the most ignored kind of thing by all treating physicians. So just a small overview regarding this. So in our clinical practice, we encounter around 75% of all cancer patients have anemia at some time during the illness, and out of this, like around 66% are of solid tumors and 72% have hematological malignancies, and out of that 40% are severe enough to warrant blood transfusions. So in Indian context, this iron deficiency is very important because we also have prevailing malnutrition which is associated in general population. So this is like a small study which was being done regarding prevalence of iron deficiency anemia across different tumors and its association with poor performance status, disease status and anemia. So it has been seen that most of the solid malignancies, as in CA pancreas and this GI malignancies, more than 50% of patients have anemia, and out of which mostly it is iron deficiency anemia, and 40% or more have are of patients of CA lung and of gynecological malignancies who have anemia. So this anemia in cancer can be attributed to many factors. It can be due to this anemia of chronic disease and various chemotherapies, side effects of chemotherapies, various due to radiation therapies which is being given to long bones and pelvic bones, or it can be due to delayed wound healing by targeted therapies. It can be due to blood loss due to surgeries and delayed wound healing, or it can be due to bone marrow infiltration by the tumor, by hemolysis, by deficiencies of other nutrients like vitamin B12 and folic acid deficiency, and most commonly iron deficiency, and other factors can be thrombocytopenic purpura and etc. So now getting some small overview of iron deficiency in cancer patient. We have mostly absolute iron deficiency and functional iron deficiency. The thing we ignore most is functional iron deficiency, where patient has a good level of iron like serum ferritin levels, but still patient is having iron deficiency due to decreased absorption. So here this ferritin is not a good standard to measure. Here definitely this saturation, transferrin saturation level is a good marker to measure this functional iron deficiency. So just a small overview regarding this pathophysiology. So this absolute iron deficiency can be due to blood loss, which can be due to surgeries, coagulopathies and malignancies. So it can be which can lead to depletion of iron stores. It can be due to cachexia and malnutrition. It can be due to hemolysis due to various drug therapies and various this disease associated hemolysis. It can be due to hemophagocytic syndrome. Now coming to functional iron deficiency, where there is this immune inflammation which can lead to rise in hepcidin levels. This leads to block in iron absorption from gut and release from macrophages. So this leads to definitely this functional iron deficiency. Other causes can be bone marrow infiltration due to this cancer cells, which leads to this deficiency, and others can be RT induced myelosuppression. So now this pathophysiology of cancer related anemia, this can be due to the tumor leads to macrophage activation, which leads to interleukin secretion, and this again increases the hepcidin levels in the blood from liver and from the macrophages, which decreases erythropoietin levels in the blood, and this leads to decreased erythropoiesis and anemia. So now just as discussed, some like the absolute iron deficiency can be due to insufficient iron availability. Deficiency may be due to inadequate iron intake or due to chronic blood loss, and this functional iron deficiency can happen where the patient has adequate iron stores, but that is this inadequate iron supplied to erythron. This can be due to decreased maturation of erythroblast, and that is this decreased response to erythrocyte stimulating agents. So how can we differentiate between that? Here this absolute in absolute iron deficiency, the ferritin levels are like less than 30, and are whereas in functional iron deficiency, the ferritin level is more than 30. But the thing which the very good marker which actually differentiates between absolute and functional iron deficiency is like this transfer in saturation levels, which is less than 20% in absolute iron deficiency, but and also in this functional iron deficiency. So and the other thing which differentiates is in this absolute iron deficiency, this soluble transferrin receptor is increased, whereas it is normal level in functional iron deficiency cases. So what is the consequence of cancer related anemia? It definitely leads to compromised quality of life due to easy fatigability, and it also leads to poor performance status. So decreased tolerance to therapies. It can obviously lead to aggravation of coexisting comorbidities like respiratory and cardiovascular illnesses, and it obviously they cannot tolerate dose dense chemotherapies, and it ultimately leads to premature death. So now what is the goal of our treatment of this anemia? The goal first is to improve the hemoglobin levels, which subsequently will improve the quality of life and will lead to a reduction in need for this blood transfusions, and ultimately will lead to better outcomes for cancer patients. So now how to approach cases of anemia, discussing NCCN guidelines. These are the factors to be evaluated. Like whenever we are suspecting like anemia, obviously we should always go for like hemoglobin checkup, and when it is less than like 11 gram per DL, or that is like drop in more than 2 gram per deciliter below the baseline, then we can do a complete blood count. A peripheral blood smear can be done. Then now we have to evaluate the causes of anemia. We should first check the reticulocyte count and this MCV levels. So then we can consider like if the anemia is due to hemorrhage, we should rule out causes through endoscopy and this occult stool blood. We can rule out hemolysis, causes due to hemolysis by direct this antiglobulin test. We can rule out nutritional factors like if there is deficiency in iron or in vitamin B12 or folate, or it is inherited, or we can also check for like renal dysfunction. If the patient is taking radiation or not, which can lead to myelosuppression, and we can also rule out other hormonal dysfunctions. So now if we at all find out anemia, so when the patient is like asymptomatic without significant comorbidities, we can observe and we can have periodic reevaluation. And like second category is the patients who are high risk or who have progressive decline in hemoglobin with recent intensive chemotherapy or radiation therapy, or like asymptomatic with comorbidities like cardiac disease and this COPD and cerebral vascular disease. Here we can consider blood transfusion as per this American guideline for blood and biotherapeutics. So, and again, if the patient is like visibly symptomatic with sustained tachycardia or tachypnea, chest pain or dyspnea, lightheadedness or syncope, then we can go for blood transfusion definitely. So, so when if we at all find the patient is having iron deficiency, now how to differentiate between absolute and functional iron deficiency and what to do. So this NCCN guideline of this version says that, so in case the patient is having iron deficiency where the patient where ferritin level is less than 30 nanogram per ml or transferrin saturation level is less than 20%, we can consider IV supplementation or oral supplementation. And if hemoglobin increases after 4 weeks, we can periodically evaluate for the same. And if there is no hemoglobin increase after 4 weeks, then you can think of functional iron deficiency. And if the patient is having like functional iron deficiency and is receiving this erythrocyte stimulating agents, then we can consider IV supplementation with erythropoietic therapy. And if the patient is having possible functional iron deficiency, but the ferritin level is more than 500 and this transferrin saturation is less than 50%, then no iron supplementation is needed. But we can consider this IV iron in certain selected patients. And if patient is having no iron deficiency, then supplementation is not required. Now this is ESMO guidelines. So here if the patient is having this hemoglobin 10 to 11, and then we can consider this IV iron if saturation level is if this transferrin saturation level is less than 20% and or soluble transferrin soluble factor is less than 100 nanogram per ml. And if patient is having vitamin B12 deficiency, we can supplement it with vitamin B12. And now if the hemoglobin is 8 is in between range of 8 to 12 and patient is having this vitamin B12 or folate deficiency, then we can replace it with the same. And then if the patient is having absolute iron deficiency, we can give IV iron, and if he is having functional iron deficiency, we can add IV iron to this erythropoietins. Yeah. So now what are the other treatment options for anemia? We can have like we can do blood transfusions and we can give erythropoietins, we can give IV iron. And what are the indications for the same? Like blood transfusions can be done where hemoglobin is less than 8 gram per DL, where there is immediate increase in hemoglobin is required, and the complications can be like it can be the risk for mortality during transfusion. And now for erythropoietins administration, what are the indications? Here the indication can be if the hemoglobin is less than 10 gram per DL, and where slow increase in hemoglobin can be also dealt with. Now IV iron is required in cases of functional and absolute iron deficiency cases, and where fast increase in hemoglobin is required, even if it is included with erythrocyte stimulating agents. Now coming to this blood transfusions, what are its like pros and cons? It's good in the sense that it is a treatment of choice where rapid increase in hemoglobin is needed. It is also effective in patients who are non-responders to erythropoietin, and the adverse effects can be like severe, like adverse immunological reactions during transfusion. There can be transmission of infectious organisms, increased rate of infection rates can be seen, increased thromboembolic complications can be found out, and definitely reduces secondary, induces secondary malignancies also like CLL, and the patients receiving multiple blood transfusion have been found to have increased morbidity, mortality, and cost. This cost effectiveness. Now coming to erythropoietins, what are its like advantages? Its advantages are it is like physiologic therapy in patients with inadequate erythropoietin production. Responses can be maintained for long, and it can be combined with IV iron to enhance the benefit. It's like cons can be it increases thromboembolic complications, it can lead to hypertension, it sometimes leads to tumor progression also. So now coming to IV iron, it is like very well tolerated, it has very less cons. So the most commonly used is this ferric carboxymaltose because of its stable and robust complex structure. So like we can see when comparing the properties of ideal parenteral iron, we can see this ferric carboxymaltose have a very like good similarity with the ideal IV that ideal IV iron should have. Like it has good molecular weight, its stability is good, its half-life is just 16 hours. It just takes 15 minutes to administer this 1 gram of IV iron, and now this like when like these are certain studies like where we see when we administer IV this ferric carboxymaltose in anemic patients, we see like definitely we can have rapid increase in hemoglobin levels. Like as we see in this graph, the change in hemoglobin level per week is by 1.4. So it is a good response definitely as compared to just the patients who are receiving no anemic therapy. So definitely this ferric carboxymaltose is has got good advantages, like it is effective, it has got rapid response, it is relatively free from adverse events and no test dose is needed, it has got good GI tolerance also. So it is easy to administer just in 15 minutes and hence recommended for all we can use it in primary care settings. It is cost effective and definitely reduces erythropoietin this requirement. So like what is the advantage of giving this 1 gram NC-carb? Like very few clinical visits are required. It can lead to improved patient compliance. Obviously venous access is not a problem. It can lead to reduction in blood transfusions, and it definitely leads to cost savings. So why NC-carb is a good option? Because as per international guideline, they recommend 1 gram in single setting, which is obviously good because NC-carb comes in this 1K dose, so we can use it in a very good proper way. So now coming to a single like Indian clinical data, as in this AIMS Rishikesh paper, where they have used this IV ferric carboxymaltose, and they have definitely found a 100% therapeutic response. That is 4.2 gram per DL mean hemoglobin rise after 3 weeks, and definitely 0% infusion related toxicity, so which is very good. So now summarizing the slides, the iron deficiency is definitely a frequently encountered complication where more than 60% of patients have iron deficiency anemia. So this leads to functional and this emotional impairment in all cancer patients, and it leads to this poor compliance to therapy. Now we need to first clarify the cause for anemia. So if patient is having iron deficiency, we have to rule out absolute and we have to just differentiate between absolute and functional iron deficiency. So IV iron, this IV iron single agent therapy obviously had this resulted in increase in hemoglobin and has improved symptoms and quality of life in all patients. So when IV iron is combined with this erythropoietins, it has resulted in higher response rates, faster response, and has definitely spared this erythrocyte stimulating agent dose. So definitely we can go for IV iron in our setting in a regular basis. So now this NC-carb, coming to NC-carb, obviously it is effective and it has got good responses. It is well tolerated, no test dose required, no GI tolerance as discussed. So IV iron in form of NC-carb is a good option, and we can definitely use in a clinical setting to improve like quality of life for our patients, for good compliance to therapy and good outcome. Thank you.
Thank you, Dr. Priya. So now we move to a keynote speech by Dr. Subhasit Chattopadhyay, a senior scientist from Niger and my neighbor too. So he will talk on analysis of immune regulatory T cells in experimental cancer microenvironment. So over to Dr. Subhasis, please.
Yes, sir.
It's working here, but okay. Hello. So very good evening to all of you, all the organizers, organizing committee members, all the stakeholders, all the clinicians, support staffs. It's a really great pleasure to be here as Dr. Ghanshyam Biswas, introduced me. He is a renowned figure in Odisha and India and internationally for medical oncology. But apart from that, he is a very good human being. I like to say that things. And it's my opportunity that I am his neighbor. And for me, as he introduced, I am the odd one out probably in this summit. I am not a clinician. I am a simple researcher. I am a doctorate. I am a PhD. So we work on immunology in Niger, National Institute of Science, Education and Research. And we work on cancer immunology, and I had my postdoctoral research experience in the field of cancer immunology, especially melanoma, with melanoma patient. And here in India, we work not only in cancer for different diseases, and one of our doctoral student, Tathagato Mukherjee, is here. Few years ago, he registered here and participated and contested. He got the reward or award from this conference only. With that, I will start. This is the main gate of Niger, security gate. And why I am showing these things, because our immune system works like security. So you can see that things that we all know, like all the clinicians knows much more immunology than our researchers, because I don't have to give introductions, but this is the slides. What do we understand by immune system? And it works like a shield. It's just like a protections, but we understand the nature's laws. No one is perfect, nothing is absolute. So our immune system is also not absolutely foolproof to protect us, and that's why we get disease, right? And it works like homeland security. I'm not going to the details because you know better than me what are the organs and what are the systems. We know innate immunity, we know adaptive immunity, we know T cells, B cells, the stakeholders for adaptive immunity. We'll be talking today mostly about T cells, a special type of T cells, that is regulatory T cells. Now, brief outline of CMI, that is cell-mediated immunity. We are working with animal model as well as human samples. So in our lab, we are working with infection immunity, basic immunology, fundamental research, as well as with viral infections with chikungunya virus, and also where I have started my kindergarten in immunology in postdoctoral research in US, University of Connecticut Health Center, where we started the work with immune suppression and regulation. So that we are working. Tathagato did a very good job. I will briefly mention about that.
So these are the conglomerates of immune system. That means the stakeholders of immune systems, that adaptive immune cells and innate immune cells. We all know that T cells and B cells, T lymphocytes and B lymphocytes, are the major player of adaptive immune cells. But this is the time, at least clinicians understand, sometimes researchers may not understand, that our physiology works in a holistic manner. The heart needs to correlate with kidney, and it also needs to correlate with brain. Similarly, for immune systems, adaptive immunity and innate immunity works together. But when we publish our research paper, we focus so much on specific cell types, and that is quite prominent in the system. So there is a bridge between innate and adaptive immunity. For examples, I have shown the TLR toll-like receptor, but there are many innate immune receptor and adaptive immune cells. I have shown T cells, but B cells has important role for antibody productions. Now coming to the point of tumor microenvironment, that was the point, probably you are interested on that. So we understand what we mean by tumor microenvironment. It's the microenvironment, the niche, where tumor cells are there. I'm making a simplified things of a complex things. Tumorous cells, cancerous cells, malignant cells are there, which have a metastatic property. The altered growth factors, what we call as cytokines. The altered cytokines are there, and many other things. Angiogenesis is happening, we all know. But the point here to show that things, something is going up and something is going down. The suppressive factors, what we can see, that CD4 helper T cells, CD8 T cells, M1 type of macrophage, tumor-associated macrophage TAMs, and NK cells, they are the protective partner for providing anti-cancer or anti-tumor immunity, but they are going down in cancer. And that leads to finally the suppressions, or that promotes suppression or facilitates suppressions, what we can see. The other partner, right, Tregs, which is the today's topic for me, regulatory T cells I will talk. M2 type of macrophage are going up, and myeloid-derived suppressor cells are also coming up with altered cytokine milieu. We understand what is cytokine. So there are inflammatory cytokine, immunogenic cytokine, and immunosuppressive cytokines. What we see that mostly along with inflammatory cytokines, lots of immunosuppressive cytokines like IL-10, interleukin-10, transforming growth factor beta, all these things are coming up. So this is the cartoon or simplified view of cell-mediated immunity, where we can see that T cells works with antigen-presenting cells with co-stimulation and TCR-MSC interactions, and can lead to either immune response or immune regulation. And there are subsets based on the cytokine pattern, Th1, Th2, now Th17, all these things are there. So we are working in this field, and it was our opportunity to work as an review editor, our editorial board for one of the journal where we worked on cell-mediated immunity and vaccine. Now coming to the point of Treg, I will discuss in details within this stipulated time. Tregs has a beneficial role also. We know the upside down features of autoimmune diseases as well as cancer, and just I like to mention, we all know Dr. Biswas is the busiest person I have seen ever in the medical field. Sometimes at 10:30 or 11 o'clock at night when I used to see him walking, and then we used to discuss the problem with CTLA4, PD-PDL1 therapy to treat cancer. I was astonished to hear that things that patients are generating inflammatory diseases related to autoimmunity. So autoimmune diseases where aggravated immune responses are there, we need regulatory T cells or Treg, but we do not have it. We need to have these things, and that is a therapeutic strategy. Whereas in solid tumor progression, we see that in cancer there is higher regulatory T cell responses. And infectious diseases is in between, because some of the infectious diseases are immunosuppressive, are immunogenic, inflammatory, so it's a complex situation. So now some of the figures in the field of regulatory T cells, Shimon Sakaguchi from Japan, Ethan M. Shevak, and Alexander Rudensky. Shimon Sakaguchi in 1995 first shown officially that existence of regulatory T cells in animal model and it has importance in autoimmune diseases. Then Ethan M. Shevak from NIH has shown about its existence in human, and Alexander Rudensky in 2000 first time showed the existence of a real marker, a transcription factor, what we call today is FOXP3, fork head FOXP3, and that is very important. It has been shown that deficiency or deletion or mutations of the FOXP3 can generate different autoimmune diseases. At the same time, it has been shown that several cancers, in several cancer cases, FOXP3 positive Tregs are predominant. Now, is there any other type of regulatory T cells which are FOXP3 negative? For that, we need to go back to the history, because we all are waiting for the bedside assistance. But in research, academics and clinical research, there is a word statement from bedside to bedside, that is translational research. For translational research, we need to have some basic fundamental research I have seen in USA. So it is the history 1980s where the Professor Richard Garson worked on first CD8 suppressor T cells, and then his colleague with Robert Cohn, we worked on that, and it was my opportunity to work with them. We have shown that existence of CD8 regulatory T cells, which is neither FOXP3 nor CD25. Now, this is the brief classification of different type of Tregs, regulatory T cells. You can see that there are CD4 positive cells, there are CD8 positive Tregs, and different subsets are there. So it is very much complex. We cannot only tell that FOXP3 is the only Treg marker. Now this is the figure, this is the recent table in terms of cancer. You can see that there are natural and induced Tregs are there, and they are floated in different type of cancer. You can see that things starting from ovarian carcinoma to ovarian cancers. You are well versed about that. Renal cell carcinoma, RCC. Today there is a talk I see, there is a debate also. So there are references of Tregs. So who first coined the term of regulatory T cells? It was not Shimon Sakaguchi, and you will be astonished and excited to know this is not an official record, but if you search PubMed, you know PubMed search, you will find the real story. 1995, Shimon Sakaguchi published in Journal of Immunology, but long before, 6 years before, in 1989, an Indian scientist, he was an MD, not a PhD, his name is Bijay Mukherjee. He is an MD. He is not a PhD, but he worked for full time for research. He is an oncologist. He published in 1989 in Journal of Experimental Medicines and coined the term regulatory T cells in the field of melanoma. Then with the same group, again in Journal of Immunology in 1990, published another paper on regulatory T cells, but Shimon Sakaguchi's paper is well versed. Now coming to the Nobel Prize in 2018, Jim Allison and Honjo, you all know about that. We have always a discussions, what is the current update of CTLA4 and PD-PDL1 with Dr. Biswas. They are popular and they got the award for their discovery for the checkpoint regulators for cancer for using the antibodies against CTLA4 and PD-PDL1. This is the suppressive nature of Tregs, how they suppress. This is a snapshot and glimpses. I'm not going to the details. I'm just going the highlights, that inhibitory cytokines are there, apoptosis are there, ATP metabolisms problems are there, IDO is involved. Of course, Tregs are there, Tregs in the immune checkpoints. From the Mukherjee's lab, I also worked with Mukherjee's lab. We published a paper of MAP kinase, how they are important for anti-cancer CTL responses. We found that JNK MAP kinases are the major point for killing the apoptosis, inducing apoptosis for the anti-tumor CTL responses. And if we use the inhibitor, we can rescue that. We have also worked on Tregs that we mentioned, This is the cancer immunology immunotherapy paper, first one regulatory T cells and tumor immunity. And then we have shown that in cancer we get a kind of Th2 type of responses, immunosuppressive as well as Th2. So if we can maintain a Th1 conditioning, this was worked with patient samples for melanoma, where we have given a kind of ex vivo treatment with the peripheral blood lymphocytes, and we found that Th1 conditioning can give a better CTL responses. Now, this is the paper where we have shown that induced versus natural Tregs. This is our paper from Mukherjee's lab, where we have found that induced Tregs, which are apparently CD4 positive but CD25 negatives, have a major impediment for anti-cancer CTL responses. We have done a head-to-head comparison. If you have any question, we'll discuss about Tregs after the talk. Now, this is the things what we have shown earlier, that the CTL, that is cytolytic T cells, the CD8 T cells, which is anti-cancer T cell response, cannot work because one of the reason is Tregs. And we have found that inducible Tregs, which secretes IL-10 and TGF-beta, are down-regulating the CTL responses, and we publish in Journal of Immunology. Then human immunology, we have shown that Th1 conditioning is promoting a CTL response, rather suppressing the suppressor or regulating the regulatory T cells. This is the recent paper, how to manipulate about Tregs. This is the cell biological and biochemical aspects of Tregs or tumor immunity. There are changes in tumor cells, alteration of antigen presenting cells, and dysfunction of effector cells, where you can see that one of the major issues is Tregs, because we do not know whether it's a cause or effect, or it's maybe a concomitant release. It's a million-dollar question. It's going on, and it will be going on. So these are the cell signaling molecule which get down-regulated in cancer microenvironment. We know that T cell receptor is CD3, and the zeta subunit of T cell receptor get down-regulated. There is an adapter protein P56LCK which is also get down-regulated. Calcium signaling get down-regulated, NF-kappa B, nuclear factor kappa B, and IL-2 productions, because Tregs consume lots of IL-2 for effector functions. That means to kill the cancerous cells, we need CTLs that get deprived from IL-2 consumption by the Tregs. And this is the latest paper. Tathagato is also there. We worked on experimental immune suppression, where we used both animal model for melanoma as well as immunosuppressive drugs, which is basically good drugs for autoimmune diseases. We found that what cancerous microenvironment is doing, that is suppressing the immunity, especially the T cell responses. We got similar scenario with the immunosuppressive drugs, and it is associated with down regulation of and up regulation of calcium. We have also worked with a specific ion channel, that is TRPV, transient receptor potential ion channels, non-selective cationic ion channels. And these are the data. What we found that when we in vitro activate with mitogen, calcium signaling and the inflammatory cytokines are up. However, is that fine? Is he okay? Oh, thanks God. Thanks to God. So, FK506, a tacrolimus derivative, along with B16 supernatant, we found that to our wonder that calcium is going up. However, the cytokines and activations are down. So where we are standing with Tregs at this moment, this is the same word what we had a discussion with the evening work with Dr. Biswas. It's quite challenging. Why? Because we know that the deleterious effect of Tregs are there in cancer microenvironment, but Tregs are also essential to maintain the self-tolerance. That means autoantigenic activation regulation, otherwise we will get autoimmunity. So we need to have a balanced, proposed and precision-based therapy or target to specifically those Tregs which have a deleterious role, rather not by regulating the or upregulate. If we delete these Tregs, we can get autoimmune diseases. So this critical balance is important. So with that, this is the paper, review paper recently published in 2020, regulatory T cells and tumor microenvironment new mechanisms. So this is quite challenging. So with that, I will conclude. So we are working in the field of cell-mediated immunity, where we are working with infection immunity, cancer immunity, and basic immunology. So I like to acknowledge the funding agencies, School of Biological Sciences, NICER, of course, DAE, Department of Atomic Energy, Institute of Life Sciences, Department of Biotechnology, Council of Scientific and Industrial Research, IMGENX, DST, ACRB, and they are our collaborators. Thanks to all of them. And of course, University of Connecticut Health Center, where I am still working, like in online mode, I would say, because I used to work there and I got suggestions. And this is our institute, NICER, all are welcome. This is an informal party pictures where I wanted to share with you. Thank you very much. Thanks for inviting me.
Thank you. That was a great talk. So why does the tumor microenvironment differ? And can you really target a Treg as a receptor or a signal transduction?
Yeah, it's a very good question, Dr. Biswas. So probably we have to have a lots of evening work again. So Dr. Biswas asks that, can we target the Tregs in the tumor microenvironment? It's a $1 million question, and that is the challenge. Truly speaking, Tregs research formally started from 1995. Before that, there are suppressor T cells. Every day we are getting lots of marker. Initially, it was CD4 positive Tregs, helper T cells. Now we have CD8 Tregs, CD25, FOXP3. Now CTLA4 and PD-PDL1, because of this Nobel Laureates Award, it was quite highlighted, and you all know, because you are the clinicians, that anti-CTLA4 and anti-PD-PDL1 antibodies are good to regulate this suppressive function. But the point is that it has been shown in animal model, because in animal research it is easy, but you know better than me that you are dealing with human being. They are not animal. All the humans are different. They are not syngenic animal like BALB/c mice or C57BL6 mice. They are syngenic. All the genes are same. Everything identical. You are getting a kind of replicating results. All humans are different. There is no such word like wild type human. In mice we say wild type mice instead of transgenic mice. So targeting Tregs with different molecules you can get in animal models certain good results. But there was a suggestion when I was working that personalized therapy. For example, you can deplete the Tregs and generate more CTLs from the same patient. You can make the red hot dendritic cells, it's known as dendritic cell therapy, which can fight against the Tregs, but antibody mediated depletion of CTLA4 and PD-PDL1, I am not the person to explain. Dr. Biswas can explain, and he has the real data. The chances of autoimmune diseases and inflammations are quite higher. So I believe needs a thorough research.
Thank you so much.
Thank you very much.
So we move to the debate. So this will be an adjuvant therapy in renal cell cancers, for and against. So expert comment by Dr. Prashant Parida. Please call Prashant to the room. Yeah. So you can be there in the front. So for Dr. Vivek Agarwal. So Vivek will be virtually present. So over to you, Vivek.
Yeah, I think the slides are visible, and I am well heard. So I again thank the organizers for giving me this opportunity. And in this debate on adjuvant therapy in renal cell carcinoma, I am speaking for the motion. So adjuvant therapy in renal cell carcinoma is quite an unmet need. What we see is that 50% of resected patients in various stages go on to develop recurrent metastatic disease, And these patients are going to need therapy for life when diagnosed with metastasis. And there is ample research on to what are the risk factors which can predict whether these patients are going to recur or not. And there are multiple risk factors that are already being accounted for and discussed. Also, 25% of the RCC patients, they will present with metastasis or in a locally unresectable stage. And if somehow being oligometastatic or giving some neoadjuvant surgery is done, still these patients are going to have a very high recurrence of up to 60 to 80%. So effective adjuvant therapy is something that is the need of the hour. You ask any urologist. Now, if you look at the old recommendation for adjuvant therapy in RCC, the old NCCN clearly says surveillance, surveillance, and if adjuvant, a category 3 recommendation. And when Dr. Kamath sees this NCCN, he feels that he is going to have a home run. He is already winning this match. But I am starting this debate as an underdog. And when we look at the adjuvant studies, it had all started since the tyrosine kinase era, the VEGF era. The need was always felt, and there were multiple tyrosine kinase inhibitors, sorafenib, pazopanib, they were all tried. And in the last few years, there has been an interest in immunotherapy in this field. When you look at the trials on the TKIs, what we see is that most of the trials failed in showing any significant difference in the DFS or the OS, except the S-TRACK study, based on which sunitinib had received a category 3 recommendation for adjuvant treatment. So yes, it did improve disease,
Vivek, you are muted. You are not heard. Vivek, you are not heard. Vivek, we can't hear you.
Can you all hear me?
Yeah, so able to hear you, please.
Okay, I'm really sorry for this thing. So, sir, were you all able to hear me some part of it, or you were not able to hear anything?
So nothing was heard.
Oh my God. So, shall I start again?
No, from here only. You can please go ahead.
Okay.
Slide 6.
Yeah, the slides are visible, sir?
Slide 6. Yeah, slides are visible. Please, go ahead.
Yeah. So I think, what I was speaking about is that the only trial which succeeded in, showing some DFS benefit was the S-track study, based on which sunitinib had approval of the agencies in adjuvant setting, and it produced a 1.2 year DFS benefit, and that was because they had probably selected the correct group. And we can see that stage 3B or node positive are included, whereas in all other trials they had also included stage 1B, stage 2 patients. But however, sunitinib, it had its toxicities, and it's not an easy drug to take for years, and the toxicity is the main reason why we really don't give sunitinib to our adjuvant in an adjuvant setting to our patient. This is a category 3 recommendation. Now here comes the immune checkpoint era, and now we have studies which are looking at adjuvant atezolizumab, adjuvant pembrolizumab, adjuvant nivolumab plus ipilimumab, as well as perioperative nivolumab, to be used. And we already have the results of the Keynote 564 study. So Keynote 564 study looked at giving adjuvant pembrolizumab 200 milligram 3 weekly for 1 year to high-risk patients or intermediate to high-risk patients. So they defined high-risk patients being either grade 4 T2 or T3 with any grade is intermediate to high-risk, and high-risk as T4 any grade, or any grade with node positive, any T with node positive, or M1 oligometastatic or metastatic patients who go on to receive surgery and do not have any evidence of disease. So these are high-risk patients, and in this high-risk subgroup, patients were randomized 1:1 to Pembro versus placebo, and treatment was started within 12 weeks of surgery, and the primary endpoint was DFS, which was met in the first interim analysis, whereas OS was the secondary endpoint. Now, if you look at the DFS analysis, we can clearly see an 11% improvement at 2 years in DFS with a significant hazard of 0.63, which is significant. Number two, when we look at the DFS, that is the primary endpoint across different types of subgroups, that is intermediate risk, high risk, and M1, we see that the hazard is, it has met its endpoint in all the subgroups, and the hazard is improving from 0.68 in intermediate high to 0.6 in the high risk and to 0.28 in the M1 disease. Now look at the median DFS in the M1 disease, which is resected, it's only 11.6 months. And if you are treating them with pembrolizumab, the median is not reached, and you have a 40% stupendous improvement in 2-year DFS, a very, very significant benefit. So you tell that as your patient is more high risk, you have a higher benefit of treatment. Now, what was the DFS by sarcomatoid subgroup? So we see that patients who had sarcomatoid features being present, there was almost a 20% improvement in DFS, whereas if the sarcomatoid features are absent, there was a 10% improvement in DFS, which tells you that sarcomatoid subgroup is again a very high risk where there was significant benefit of adjuvant pembrolizumab. Looking at OS, well, the OS data is immature. The hazard is 0.52, which is encouraging, and there is a 3% improvement, and we can see that the number of events in pembrolizumab in 2 years is 23 versus 43 in the placebo. So clearly higher number of deaths in the placebo. Numerically it is higher, but the data is still mature, and it will take years for this OS data to mature. If you look at the distant metastasis free survival, another important exploratory endpoint, looked at multiple other studies, we see that there is an 11% improvement with a hazard of 0.63. And if you look at time to first subsequent therapy, again there is a 7% improvement with a hazard of 0.67. Looking at the updated OS analysis, again we see that the updated OS analysis still looks good with the hazard improving to from 0.5554 to 0.52. So again, that it looks. Now, toxicities is something that Dr. Kamath will say that it is a toxic treatment. There are all-cause adverse events happening in pembrolizumab, but look at the adverse events in placebo. The placebo events are quite comparable to the events in pembrolizumab. So even placebo arm will have side effects, and I think all these side effects, the grade 3, grade 4 side effects were less than 10%. There was no death in the adjuvant treatment arm. Now, there are other trials which are still awaiting results. The final paper is not out, and there are more questions, more practical indications, like what about R plus resection? What about a surgery which is done where it is inadequate and lymph node dissection is not done? And what about diseases where there is locally unresectable and you have given neoadjuvant treatment to downgrade the disease where you have done R0 surgery? Now, these are all again questions which have never been answered in clinical trial and will never be answered in a clinical trial, and these are also indications where you need to utilize this treatment. Of course, in future we are going to question what is the duration of treatment, how intense it is going to be, and what more biomarkers are there which we can refine our patient selection. And now in 2022, if you see the guidelines, again we see that adjuvant pembrolizumab is a category 2A recommendation. ESMO guidelines, it is a category 1 recommendation in intermediate and high risk population. So clearly patient selection is the key, and AUA 2022, they have already come up with a scoring system to see who should receive adjuvant therapy, and when you apply this scoring system, you really select the high risk patients, and these patients definitely benefit. So I conclude with these take home messages that adjuvant immunotherapy for high risk RCC patients is standard of care. There is a significant undisputable DFS benefit, and DFS again, mind you, is a valid endpoint and an endpoint which is there across all adjuvant trials nowadays, whether you call it melanoma, whether you call it lung, or whether you call it breast. We have seen IDFS benefit and we have talked about it. OS data is immature, but we can't wait for this future. The future is now. Everyone is saying, what we are going to do in future, the future is now. Toxicity is low, manageable, comparable to placebo, and no deaths reported. Cost again is a concern, but cost is not a ground to deny benefit to those who can afford and deserve. And patient selection is the key, and you need to give it to T4 patients or T3 high grade, node positive, sarcomatoid patients, M1 resection patients, R plus resection patients, and those who receive neoadjuvant treatment. And what we see is that do not underestimate the underdog, Dr. Kamath, and if you underestimate, you're going to lose. So with this, I thank you, and over to Dr. Kamath for his deliberation. Thank you.
Thank you, Vivek. So now over to Dr. Mangesh against the motion. So he'll talk against the motion. Mangesh, please.
Thank you, Dr. Vivek, for taking a lot of jibes at me during this talk. But yeah, I'll probably answer it. ईंट का जवाब पत्थर से देंगे. अभी देखते हैं. So, well, what I would want to tell him is that while he did a great job in trying to push the buck with respect to adjuvant therapy, he himself has made my job easy by giving a lot of the limitations of all the studies that have been conducted for adjuvant therapy of RCC. So let me share my slides. I don't want to go into the long presentation that Vivek had to try and convince us that adjuvant therapy is going to be useful, but I am going to just take points at what exactly I would want to talk when it comes to adjuvant therapy. So let's just start with basics that Dr. Vivek spoke about. Vivek said we have a lot of adjuvant therapies, and DFS is great, and we'll take it as a valid endpoint. OS is, we'll take it in the future. Then why are we stopping only at sunitinib? We have so much data on other TKIs also. Why not? Why just sunitinib? Why not just go for other TKIs? The reason for that is all of these trials, when the systematic review and meta-analysis was done, it showed one major conclusion is that even though they produced a significant DFS advantage, they consistently showed that there was no significant overall survival benefit. Now, Vivek will say, let's live for today, future we'll take it later. But I want to ask him one question, that if you are going to just look at this, then in that case, you are justified in giving bevacizumab for everybody so that there is some DFS advantage. Why 3 months is not enough for you? Maybe for the patient, 3 months is very important. So in that sense, we cannot justify the fact that just because we got a DFS advantage and then significantly overall survival benefit was not seen across studies, that I am still going to give TKI. Now, it is also worthwhile mentioning that when the studies came out for all these TKI trials, many of them went into the NCCN guidelines, but now all of them, except for NCCN still sticking its neck out due to the extract trial, they are all taking out their recommendations for TKI therapy. Why would they do that? Because in reality, and during the real world scenario, during real world practice, we are seeing a lot greater toxicity than, with TKIs than even that is documented or even mentioned in the trials. So the investigators across various systematic reviews and meta-analysis, and I am not going to just quote one or two, there are multiple that have been conducted. The risk-benefit ratio is not supportive of TKI therapy in the adjuvant setting for most patients with RCC. These are all the studies that we have seen. And now I would like Vivek to comment on all the review articles that have come saying that most of these do not support the fact that TKIs can be used. But then finally, after Vivek explained about TKIs, he has come to adjuvant pembrolizumab. Now, adjuvant immunotherapy will be probably useful. In that way, he has probably conceded the fact that the TKIs are going to be shelved as soon as pembrolizumab is going to come. Now, let me explain to all my dear friends why the VEGF receptor TKIs have not been known to be beneficial, and why have they disappointed us, especially with respect to durable benefit. That's because these TKIs fundamentally work by limiting the vascular supply to tumors, and the micrometastatic tumor cells that are going to be there after a very good surgery is done, they will not be constrained by the vascular supply unless they seed. That means they reach an organ and then they start multiplying to a certain size. So it has already been controversial even at the time when extract trial results came out. Many renowned clinicians telling that anti-angiogenic therapy may not make sense, and it is more so proven with lots of meta-analysis. Biologically, I do agree at one point that it is probably more plausible that the immune system can be more effective at removing these tumors. But let me also specify that this theory, the biological theory, is applicable to almost every cancer. We understand through the hallmarks of cancer that when the immune system loses its efficacy, that's when many of the tumors emerge. So it is going to be useful for us to use immunotherapy, but you cannot say that I am going to use it for every patient of renal cell carcinoma when the patient has undergone surgery. I do agree that 40% to 50% of the patients will come back with a recurrence, but that doesn't mean that you start giving it to everybody, especially after they have undergone an nephrectomy. And that is why UCLA designed the UISS scoring system. They called for the intermediate risk, high risk, and M1 NED. And M1 NED was a new term that was coined to basically suit the study for pembrolizumab. And I agree with them to that extent that as the risk goes higher, you should definitely consider some adjuvant therapy. But again, that doesn't make the case for all the cases to undergo adjuvant therapy. So it is now clear, and this is a very significant chart that I would like to show. These are the results to date as published, as presented in the European Urological Association meeting. And it has been very clearly mentioned even by the authors that while we have seen 12-month DFS benefit, 24-month DFS benefit, the curves seem to be converging. That means that we really have to wait for another 3 years or something to actually confirm or eliminate the theory that there is going to be a OS benefit seen with pembrolizumab. And then again, as he was talking about the risk, I just wanted to drive home the point. We are seeing some benefit in the intermediate, the benefit is slightly better in high risk, and a lot better in the M1 NED. Now, the M1 NED, except for the fact that you've done a surgery, is almost similar to the fact that you're giving it in a metastatic setting. How does it change such a great deal? And again, high risk, T4 and N1. Again, it is considered to be, stage T4 is considered to be stage 4. So you are again telling that, for high risk and M1 NED. So we are almost taking them into the advanced renal cell carcinoma bracket. So it doesn't, yes, it could be called adjuvant because you removed the entire tumor, the tumor and its metastasis. But again, your applicability seems to be more in the metastatic setting. So I do want to conclude on one major thing from all these studies that Vivek has alluded to, and also my personal assessment is that there is a lot of excitement regarding the DFS benefit with pembrolizumab. And while I really hope for a renal cell carcinoma patient, even the author who presented concludes that he is not sure that there is going to be an overall survival benefit, and only time will tell. So, and the same author also said that it may take another 4 to 5 years of follow-up to actually see if there is a significant OS benefit. Now, we also know one more thing about safety results with immunotherapy over the long term. I understand that placebo is not lagging far behind, but again, I would want to see the OS benefit and then compare it with the safety results that I am seeing. I know that it's very easy for us to eliminate the elephant in the room, but I would definitely want to ask Vivek this question. For the support, for the proposed benefit of DFS, is he willing to conclude that he will give pembrolizumab or immunotherapy to all the patients after they undergo surgery? I would like to see how many of those patients stick to him, because I am very sure that it's very difficult to convince all your patients or even recommend to patients that they have to spend almost 10 to 20 lakhs before they actually find out. And again, we don't even know how long we have to give pembrolizumab to see the desired OS benefit. So is Vivek going to continuously give pembrolizumab for those patients? And again, he himself has considered in his concluding slides that there is a great deal of analysis that has to be done based on stage, grade, then whether it's sarcomatoid or not, and clinical parameters. So we still have a lot to understand. And I always, I would say that, ignorance is bliss, but half knowledge is far more dangerous than that. So we may see a role of all these therapies, many of these therapies. I don't rule it out because future is very unpredictable. But I believe it will have a role in mostly the high risk or the M1 NED, if at all. And still, for that, we don't have the robust data. Now, if Vivek can talk about me being the South Africans who probably thought that the Netherlands will not win against us. But remember, I had to choke for them to actually defeat me. And with all the data that I've presented and all my facts I've presented, I am definitely no South Africa here. In fact, I definitely would think that, he would probably be South Africa in this case, because if he is asked to counter many of my points, he might choke. And last but not the least, I also would like to tell my dear friend Vivek, don't count your chickens before they hatch. In the TKI setting also, there's the same sorts of, excitement was shown, and we know what is the result now with respect to TKIs. So I currently still stand with the current evidence of being against giving adjuvant therapy in RCC for many of my patients. And why I say many of my patients is if there is an M1 NED And again, like I said, it is still coming under metastasis. I might consider pembrolizumab, but in the lower stages, lower risk patients, I am still not convinced that I am going to give a cost-effective benefit to my patients. Thank you, Vivek, and thank you everybody for your kind hearing.
Thank you, Dr. Mangesh and Dr. Vivek, for excellent presentation for and against the motion of systemic adjuvant therapy in renal cell carcinoma. So, Dr. Vivek, you want to say something because Mangesh has made his points.
Yeah, so I think, in my initial slides, I already, showed how Mangesh should be looking at the old NCCN guidelines and the category 3 recommendation for TKI, and he would start wasting all of our time on talking about adjuvant TKI. Now, adjuvant TKI is the game of the past, and now we are in the immunotherapy era, and we should talk only about immunotherapy in the adjuvant setting. And in his slides, he has already shown and already conceded defeat by telling that yes, he will be considering adjuvant pembrolizumab for his high-risk patients, for his M1 NED patients, and they are adjuvant treatment. So I think he has already conceded the defeat, and I accept this victory with humility, and I totally agree with my friend Mangesh when he says that yes, we have to select our patient. I never said that we have to give it to all patients. We have to select our patients, and definitely not all breast cancer patients are going to receive adjuvant treatment. Not all pancreatic cancers receive. We always select our patients, Mangesh, and I think that is how we have been treating. We have been treating all patients. So I totally agree with Mangesh when he has conceded that he will be giving to high risk patients.
Mangesh, rather I would say off the record. So when I gave this topic to Vivek, he did not want to speak for the motion, because he said that I don't believe in adjuvant. So that's why I persisted that you go for the motion only.
So till now,
I have a point to make. I'm sorry, I'm just taking, but I'll take just 30 seconds. So, Vivek has kind of twisted the statements that I've made. I said, even if I may, I might use it in the high-risk patients or the M1 NED, and that too after the mature data. Now, the second point I also would like to let him know is that we are in the same phase when it comes to immunotherapy as we were in the TKIs. When ESTRAC came, it was the first study that came for adjuvant TKI. Everybody was very excited, delighted, and everybody started but we had the ASSURE study coming in. There are early concerns about immunotherapy, especially I think in the atezolizumab study that is already happening, there are early concerns that it is not working as well. And we know about the results of atezolizumab in RCC. So, and then now there is a study of nivolumab being tried in the neoadjuvant setting, followed by surgery and followed by this thing. So there will be no end to this. I want us to debate on the same topic somewhere in the future, maybe 3-4 years. A lot of more gray hair between us. So let's see that time who wins. And we'll also see who is going to be the winner of the World Cup after losing in the round stages. Let's see.
Yes, Dr. Mangesh, most of us clinicians also not convinced yet, especially for early stage renal cell carcinoma regarding adjuvant therapy. But probably looking at this promising data for 564 trial, so in future probably we will have some data regarding, because there are 4 to 5 trials on IO drugs, and we have to wait the OS data to mature, especially the 564. So thank you, Dr. Mangesh, Dr. Vivek, for excellent presentation. So regarding the adjuvant systemic trial, over the years, several TKIs has been tried, but except the ESTRAC trial, which has the lowest number of patients, 516, and there is only DFS advantage, no OS advantage. But recently, the IO drugs, based upon the response in metastatic setting, pembrolizumab in 564 trials has showed DFS advantage as well as the OS, though it is not significant. But the mature data, we have to wait the data to be mature, and there are 4 to 5 IO trials are ongoing, including atezolizumab, durvalumab and tremelimumab, then nivolumab, pembrolizumab, or nivo-IP combination. So probably in the future, we have some of the, we have options of using this IO either in combination or in as a single agent, but we need some biomarkers. And in my opinion, at least for intermediate to high risk patients, they need some form of adjuvant therapy, and at least T3 and higher disease or any grade 4 or sarcomatoid histology patients, they need some form of adjuvant therapy. And in M1 resectable NED disease, these group of patients, they need adjuvant therapy. So we need some biomarkers to differentiate whom we should give adjuvant therapy and whom we should not. Thank you very much.
Thank you so much. We come to the last topic, a keynote talk by Potent Power of Palliative Care by Dr. Shima, palliative care physicians from Karunashray.
I don't want the PowerPoint.
So you can use the mic.
I don't want, no, I've got it here. I want to move around. I don't want the PowerPoint. Okay? All those guys who are sitting there in the back, could you please to come in front so that we can salvage some bit of this talk, because all of you are very important people and I would like to convey this message in a very simple way. So the organizers are welcome to share. ठीक है, कोई बात नहीं, आवाज आएगा तो भी चलता है, कोई problem नहीं. You can share my PowerPoint with the, no, not put it on, I don't want. You can share my PowerPoint with all the delegates, because nobody is interested in listening to the PowerPoint. So, what I would like to convey to all of you is this. Many years ago, I worked in Tata Memorial, years ago. And my brother-in-law, my sister's husband is a surgical oncologist, Tata Memorial trained, so, I hear a lot of talk about this. One of the very important things that we also have to realize when we talk about all these wonderful statistics and all the research and say that this is better and that is better, what exactly are you talking about? Many years ago, a very close friend of mine with carcinoma stomach, I'm basically a general surgeon, but I had to give up surgery due to health reasons. He had recurrence, and one of my very close friends, medical oncologist, suggested that we give one more round of chemotherapy, and I asked that person, अच्छा है क्या? So he said, हाँ, बहुत अच्छा है. So I said, अच्छा है का मतलब क्या है? So that person said, probably it will give an additional 2 months. So I think what is very important, I'm sure that I'm much older than many of you are, I'm almost 70. And in all the enthusiasm that you people have about, fighting the cancer and doing the best for your patients and doing all this, which is fine, is perfectly fine, I would like you to keep this aspect in mind. What does the patient actually want and what are you actually achieving by that? So there are definitions of palliative care of WHO, International Association of Hospice and Palliative Care. I'm not interested in rattling that out because you will probably hear it and you will not remember. Fundamentally, palliative care is the active and total care of an individual whose disease has gone beyond cure. It is the care of that person and it is care of the family also. And finally, it is also the care of the professional caregivers. Now, for example, a person like you, if you're a medical oncologist and you're seeing somebody, you're also a human being, you feel frustrated that your treatment is not working. And tomorrow if one of your colleagues looks at you and says, hey, you know what, you don't seem to be all right. He said, yeah, I felt very bad because the person, whom I was treating reminded me of my aunt or grandmother or whatever it is going to be. So you need to remember that palliative care is the care of the person, the family, and the professional caregiver. Palliative care is a holistic approach and pays a lot of attention to the dignity of the human being. Now, years ago, for a very short time, I worked in Tata Memorial. And I still cannot forget when there was a gentleman who probably had spinal mets, I don't know for which malignancy, came in, I think he was paraplegic. His two sons brought him in a train, spending something like 48 hours, and brought that person to the OPD. And I was very busy doing endoscopy, you know, rigid endoscopy during those days, carcinoma esophagus. I was working with Praful Desai. And my registrar was busy, and he said, "Yaar, jaake dekh lena." I went and said, "Kuch nahi kar sakte hum." And the guy looking at me like that, I said, "Aap unko ghar le jao." And that was a sad story in those days. And that is how Dr. Lucito D'Souza, very senior surgical oncologist of Tata Memorial Hospital, started Shanti Avedana. Okay, now palliative care is not only for cancer. You can use palliative care for anything, any disease. You know, there are patients with end-stage kidney disease not fit for transplant. There are patients with cardiomyopathies which are not worth it. Plenty of people with interstitial lung disease and emphysemas and bronchiectasis which require palliative care. Now, lots of people, okay, and I'm saying this in a very respectful and affectionate way as an old man, okay, so please don't mistake me. I would like the oncology community, be it the medical oncologist, the surgical oncologist, the radiation oncologist, anybody else is there, that please keep this in mind, that you are not treating a patient, you're treating a person. Now, somebody may say, "Oh, we know about that." Okay, but from my experience, working in palliative care for the last 25 years and having interaction with lots and lots of people, my submission to you is that please keep in mind that this individual, okay, is a human being with all his hopes, aspirations, fears, and whatever it is going to be. Okay, so this second thing and the final point that I would like to make to all of you is this. A lot of people under the mistaken notion, and I'm saying the oncology community is under the mistaken notion that you refer person to palliative care only when that person is dying. There is an enormous resistance on the part of my fellow professionals. Now, when I talk to them, okay, they will say, "Yaar, agar humne nahi suggest kiya to aur kisi ke paas jayega, hai na? Aur wo suggest karega, fir humko lagega ki yaar humko kuch pata nahi." I think there is a need for change. And therefore, palliative care is supposed to start at the time of diagnosis. Now, if I am, you know, all my patients I start at the time of diagnosis, then you will tell me that yaar tu फालतू डॉक्टर है, क्योंकि जो भी साला तेरे पास आता है डॉक्टर पेशेंट लोग वो सब एडवांस कैंसर है. Not true. First of all, you know that most of the patients in India, 75% of the patients of cancer in India reach you people when it is already advanced, right? There are few cases, and there are, of course, if you pick up, I have, you know, in my family, my wife's two sisters, carcinoma breast, my wife's second sister, carcinoma breast, I operated her, then she developed carcinoma of the endometrium due to the tamoxifen, and then she developed carcinoma of the lung due to the radiation. And she's still surviving because of good surgery, because of good chemotherapy. So I'm not trying to discount that. But there is an enormous amount of advantage if you bring in a person into your team from a palliative care background. You will find that you are going to be much more satisfied with the care that you're giving, because we're all human beings. And I'm not trying to say that you guys are, you know, coming from some other planet and have no desire to look after patients. So there is an enormous amount of advantage. And pushing people to the ICU. When I went to the UK to work in a hospice for a little time to pick up infection, and I heard a joke, okay, with no offense to anybody, that there was this, sorry about the medical oncologist, you might have heard about it. The medical oncologist went on the round and said, you know, "Where is this patient?" So he said, "He died." So how can he die without taking the last dose of chemo? So was he buried or was he cremated? He said he was buried. So, kholo grave ko. They found the body was missing. And the nephrologist had taken the patient for dialysis. Yeah. Now, some of you may be offended with what I'm saying, but I can tell you that I have seen, even in the recent past, very, very, very eminent, very, very qualified oncologists who have shown enormous lack of compassion. So that is my appeal to you. The reason why I gave up surgical practice was because I had chronic renal failure, and I had not one, not two, but I have had 3 kidney transplants. Avascular necrosis, bilateral hip replacement, and all kinds of things. And I was almost dead so many times. And finally, there is always this fear about, if I don't send a patient to the ICU, then what will happen? What will people think? And the law today is terrible, because if you have to withdraw life support treatment, because I've been working on it at the national level, okay, you have got to form a committee in the hospital, you got to form a committee at the district, and by the time you ask the district committee to take a decision, etc., 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 you can't do anything about it. So what do many hospitals do? They ask the patient to go against medical advice. And I have heard of patients, okay, they don't want the patient to die in the hospital, so they put the patient in an ambulance, take the patient outside the compound of the ambulance, and when the patient dies, they bring the ambulance back inside, and the emergency or the casualty guy will certify the patient's death. All these things are happening. Now, I don't have time to explain to you. There are a lot of work being done to try and modify it. And finally, the Narcotic Drugs and Psychotropic Substances Act has been amended. And I'm proud to say that I was part of it, because I was president of the Indian Association of Palliative Care. Getting opioids is much, much easier than it was before. And the state of Odisha is very good. Other states are also there. There's some problem in the borderline states like Punjab and others because of the, the narcotics smuggling and all that stuff. So my final take-home message for you is this. Please look at palliative care. Please get a person from the palliative care background in your team. Please include them in your tumor boards so that they can do a lot of work. And I can tell you that there are some, I've got a very dear neurologist friend in Hinduja Hospital, and those of you who are from Mumbai, Dr. Roop Gursani. He's got a palliative care physician there. There are pulmonologists like Dr. R.K. Mani in Delhi, and a few other people who have palliative care people in their team. So in the midst of all this, great things that we are doing, robotic surgery and all kinds of things, and the technology that is available to us, okay, it is my fundamental appeal to all of you that please consider looking at palliative care. Morphine is not addictive. Morphine does not cause respiratory depression in a person who has got pain. In fact, we give small doses of morphine to reduce the air hunger in patients who are breathless. Okay, so I would like to stop here. I'm very grateful to all of you for having, listened. And it's not my intention to hurt all of you, but I think that you guys need to look at, apart from all the wonderful research and the debate, I was listening to all the lectures, enormous statistics and this and that and ye and wo and all that. Ultimately, matlab kya hai? Okay, you got to ask yourself that. And if somebody comes to you for second opinion, don't pata kato your colleague and say ki bhai main aisa karta tha, usko kuch pata nahi hai, okay? Because that's being dishonest, okay? And I'm very grateful to all of you for having come here and listened to some blabber by one crazy old 70-year-old guy, okay? Thank you.
So before we end, so there are 3 questions quiz. 4th question of the day. So which trial assessed the efficacy and safety of osimertinib as adjuvant therapy in resected EGFR mutated non-small cell? Flora, Adura, Aura3, none of these. Antra. Santosh. 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 Check the. Next. So the Lancet, name the trial. Radiotherapy versus transoral robotic surgery and neck dissection for oropharyngeal squamous cell carcinoma and open label phase 2 randomized trial. So name of the trial. Yes, Kripa. Great. Orator. Dr. Kripa Shankar. Last. So osimertinib in CNS metastatic disease. So what is the recommended dose? So this is a question which was there previous. So now things are different. So you have to recommend the dose and which trial. So I'll go back to my DM students only. Maybe Sushil. Are you Sushil? Sushil, please. So what is the dose and the trial name? And? Anybody else? Kripa, no duplication. Bhavesh, Jogmaya, do you want to answer? But I cannot tear 500 rupees half. So it was actually 160 milligram, the initial trial, and that was a Bloom trial. I won't pay anybody. So thank you. So let us meet tomorrow on day 2 at 9 a.m. Thank you so much. So like every year, so we are also coming up with our 4th session of Indo Oncology Summit. So last 2 years, everybody has been affected throughout the globe with COVID. So that's why we could do only the virtual one. So this time we are coming up with the physical also and the virtual. So it will be hybrid mode. The theme of this year's conference will be Cancer Care Era Precision. So last month in the ASCO 2022, so there was a buzz about cure in cancer in rectal cancer, and that was MSI high rectal cancers, where out of 18 patients, so 41 had no evidence of disease, and that made a huge impact in the whole society. So that is what about precision. So we want to discuss it out with you all and bring out what's new in this cancer field.